Hello. Yes, I think ma'am is lined up in another program, but she will briefly join. But a recorded message just now came that which can be played till she joins.
So it's 3, 2, 1. We are live now. Over to you.
A very good afternoon to one and all. On behalf of Mppcos Society, I, Dr. Nalini Kopale, an associate professor and consultant endocrinologist at Hyderabad, invite you all to the 4th annual conference of Mppcos Society. We are living in the times where metabolic syndrome and diabetes are ravaging the world. With numbers in hundreds of millions, it's time to act now. Today's conference is a small attempt, and it aims to getting new insights into the metabolic problems that have plagued the country and the world alike. And without much further ado, let us begin the sessions. It is indeed an honor and privilege to invite the stalwarts with us who have contributed immensely. And today, let me first take the chance of inviting our chief guest, Dr. Soumya Swaminathan, who would be joining us very shortly. Dr. Soumya Swaminathan is the chief scientist of WHO. And let me also take this opportunity to invite Professor Randeep Gularia, who is the guest of honor for us today. He is the director of All India Institute of Medical Sciences, New Delhi. And with us today is also our special guest, Professor A.G. Ahangar, director of Sher-e-Kashmir Institute of Medical Sciences and USG. Welcoming all the dignitaries, and also not to forget the immense contribution done by Mppcos Society and the members, the senior members. Let me take the opportunity to invite Professor Sarita Bajaj ma'am, who is a professor and endocrinologist at Prayagraj, Professor Rakesh Sahai sir, who is professor and head of the Department of Endocrinology of Osmania Medical College, and Dr. Sanjay Kalra sir, the past president of Endocrine Society of India and consultant endocrinologist. Without much further ado, I hand over the inaugural ceremony to Professor Sarita Bajaj ma'am.
Thank you, Nalini. Thank you so much for this introduction. As a syndrome, PCOS has been christened and rechristened several times over. The credit of taking PCOS to a whole new level in the country goes to Dr. Muhammad Ashraf Ghani, who has been hands-on and very active with the ICMR PCOS multi-centric project Pan-India. What makes it all the more praiseworthy is that the momentum of the project was maintained even during COVID times. The annual PCOS conference is also his brainchild. His trustworthy pillars of support are Professor Rakesh Sahai and Dr. Sanjay Kalra, who are both excellent academicians. Dr. Saptarshi Bhattacharya has been burning the midday and midnight oil in his endeavor to ensure the success of the conference with all the dedicated coordinators. I would like to mention them: Dr. Mohan Shenoy, Dr. Shalimar, Dr. Nitin Kapoor, Dr. Afia Rashid, Dr. Nalini Kopale, she's been there at every step of the way, Dr. Abhilash Nair, and of course our compare Nalini, Dr. Shehla Sheikh, Dr. Amrita Chaurasia, Dr. Atul Dhingra, Dr. Semanti Chakraborty, Dr. A.G. Uni Krishnan, Dr. Parjeet Kaur, Dr. Sambit Das, Dr. Suman Kotwal, and Dr. Tejal Latia. Now, if you Google the Mayo website, it defines PCOS as a hormonal disorder common among women of reproductive age. We know now that it is so much more beyond that. Apart from the fact that it does not end when the so-called, quote, unquote, reproductive age does. The 4th annual conference of Mppcos hopes to provide a great opportunity for academic progress through scientific deliberations by accomplished national faculty. And all national faculty is, I believe, a first for any conference. There will be exchange of ideas, experiences, achievements, new developments in various aspects of PCOS, busting the myth that it needs to be managed by women only. In fact, it is for each and every practitioner of medicine, no matter what the specialty. And I hope that all the useful insights will certainly help in improving healthcare. The fourth annual conference of MP PCOS was planned as a physical meeting at Prayagraj. It would have been a pleasure to welcome you to Prayag or Tirath Raj, one of the largest cities of Uttar Pradesh, the most vibrant and spiritually awakened city of India. Nevertheless, it is a privilege and an honor to extend a very warm welcome to our renowned and revered chief guest, Dr. Soumya Swaminathan, Chief Scientist, WHO, the most dynamic director of AIMS, Delhi, Professor Randeep Guleria, who is our guest of honor, who wears several hats with great elan, and our special guest, distinguished Professor A.H. Ahangar, who is Director of SKIMS and EOSG. Dr. Soumya is perhaps not with us, but I would just like to show you the monograph that we published, and this is Diabetes Mellitus Issues for the Indian Women, in which she immediately consented to write the foreword. And with Dr. Randeep Guleria, it's been a pleasure interacting during the ICMR PCOS project meetings. A very, very warm welcome to all the esteemed faculty who will be joining us from every nook and corner of the country. And again, the most special welcome is for all the delegates for whom this meeting is being organized. A very, very warm welcome to everyone. Thank you. Thank you very much. Over to you, Nalini.
Thank you so much, ma'am, for all your kind words. And next, we move on to the inaugural session. It's very important to understand what the society is doing, and to know that we have the Secretary's report. May we have Professor Rakesh Sahai to give the Secretary's report, please?
So, thank you, Dr. Nalini. Dr. Soumya Swaminathan, the chief guest of today's function, Professor Randeep Guleria, the director of AIMS, and Professor Ahangar, the director of SKIMS, and Dr. Sarita Bajaj, the chairman of the organizing committee, Dr. Ashraf Ghani, the president of the Mppcos Society, Dr. Sanjay Kalra, the chairman scientific committee of the 4th annual conference of Mppcos Society, and Dr. Dr. Bhattacharya, and all the others who have joined in today. A warm welcome to all of you. Professor Sarita Bajaj has given us a very good overview of PCOS, and she has highlighted the fact that PCOS is a lifestyle disorder which is increasing in prevalence and has myriad manifestations presenting to various different specialties in medicine, and therefore there is a need to sort of get together all these specialists who are dealing with the management of PCOS, because as she has highlighted, it's not just a disorder of reproductive age, it goes beyond that, it extends from before that and goes beyond that, and has many vast implications in terms of increasing the risk of diabetes, cardiovascular disease, and all other metabolic disorders in these women who present with PCOS. Hence, there is a need to get together all these specialties and get all the professionals managing these patients with PCOS together on a common platform, and it is with this objective that this society called the Mppcos Society was formulated. And today we are very proud to have the 4th annual meeting being conducted. The third annual meeting happened last year at Hyderabad, where we had more than 400 delegates who attended the function, attended the conference, and we had a very successfully conducted conference in the pre-pandemic era. And during the pandemic era, we were the 4th meeting was to be held in Allahabad, and it is now being held virtually. So we are pleased to have all of you joining in this program virtually. Now, looking at what the society has been doing, apart from holding these annual conferences every year, which are providing a platform for interaction amongst various healthcare professionals dealing with the management of PCOS to update themselves with new knowledge and to improve the research in the field of PCOS, with the ultimate objective of improving the lives of women who suffer with this problem. Apart from this, the annual conferences which we have been holding, the society has also been organizing many midterm meetings which have been organized. In the last year, we had one meeting which was conducted on the Science Day in collaboration with the JK University and also with the Sher Kashmir Institute of Medical Sciences, and the theme was on thyroid disorders. We had another midterm meeting which was held in the month of July 2021 in collaboration with the Indian Thyroid Society, once again with a focus mainly on thyroid disorders and PCOS. So these meetings have been very useful in updating the members and having a good a good overview about PCOS management and thyroid disorders, and various aspects of PCOS were discussed in these meetings. Apart from this, one of the other activities of the society in the recent past has been to initiate a real world study looking at the presentation and phenotypic presentation, the various complications of PCOS, the treatment modalities being followed, the response to treatment, the outcomes of various treatment modalities that are being used. To understand all these aspects, a real world study is being initiated, and this is going to be soon rolled out, and we have in fact a meeting tomorrow to discuss many of these aspects of this study, which is going to have more than 50 investigators from across the country in the form of endocrinologists and gynecologists who will be participating from different parts of the country. So this is also going to give us a lot of information about various aspects of PCOS, and also help us in improving our management strategies for women with PCOS. With these few words, I welcome all of you to this important meeting of the Mppcos PCOS Society, which has been christened as the Mood 2021, that is metabolic syndrome, obesity, ovarian dysfunction, and diabetes 2021. So and I would like to thank Dr. Saptarshi Bhattacharya, who has played a very important role in getting together all the coordinators and all the people involved in organizing this meeting and coming up with this excellent show. So thank you, Dr. Nalini.
Thank you, sir. That was indeed a commendable work done despite the setback of COVID. Moving on, the president is the head of an institution, and it's very important to know the vision of the society. Giving the presidential address with us is Professor Mohammad Ashraf Ghani. Sir. Sir, please unmute yourself.
Thank you, Nalini. Respected Professor Dr. Swami Nathan, Dr. Randeep Guleria, Director AIMS, Dr. A.G. Angar, Director of our Institute, Professor Sarita Bajaj, Professor Rakesh Sahai, Professor Sanjay Kalra. As vividly ma'am said, they are my two big supporters, and with Dr. Saptareshi, he has been always doing a commendable job working for us. And the pat which is on my shoulders is from Ma'am Sarita Bajaj. So we all three of us would have not been there successful in this event unless Ma'am has been there. So I welcome you all to this scientific bonanza. At the beginning of this event, I should say that the way the program has been orchestrated It is like a very sweet dish with all adequately put spices and salt, pepper by Professor Sanjay Kalra. And I always see his programs with interest because he's the one who can always get together people of all the levels. That is a God given gift with him, and I have always actually nurtured his friendship and also the guidance. He has been my senior at All India Institute of Medical Sciences. And he has always been guiding all of us, and his friendly approach brings a lot of people to him, closer to him. Now, giving the idea that it is fortunate on to my luck that I have got the advantage or I have got the opportunity to lead this society. Just I'll take a quick break here. Professor M.S. Kuru, who is our very renowned, world-renowned scientist, has joined us. He will be replacing Dr. A.G. Ahangar. There is an internet issue around the institute. We had to come out of institute to do the meeting. And Professor Kuru is this time lined up in a conference in Moscow. He's there. Similarly, all the three dignitaries are lined up in some meetings. So he has taken 2 minutes. So I will continue my presidential address after he delivers his speech. He will be there also on the valedictory function for award ceremony. But this time I will request Professor Kuru to give his quick comments about our society and work. Then I will continue my address after this. Professor Kuru, sir. Let me introduce Professor Kuru, that he has done his MBBS in GMC Srinagar, MD in GMC Srinagar, DM and gastroenterology from PGI Chandigarh. And since then, he has been working on hepatitis. In fact, the first description of transplacental, the carrier of hepatitis E was described by him only. That was recognized by WHO and world bodies, and that is why he is leading the all hepatitis programs globally. And he has been, I am fortunate that I have been his student in his times. He has been my examiner in MBBS. So I am very fortunate to have been student in his. He has been always guiding us in the research and even in our PCOS task force and otherwise also. So Professor Kuru to say some few words.
He's there, but I'm not sure.
So you might have to unmute yourself.
Yeah, most probably.
Unmuted.
Yeah, he's very much there.
He's unmuted.
Yeah.
Am I
Yes,
audible
yes,
now?
Yes, sir. Yes, sir. You are
Yes,
audible.
very warm welcome to you, Dr. Kuru. We can hear you.
Right, thank you. Dr. Ashraf, it's been very kind of you to give me this chance to join you in this meeting. Actually, I'm caught up in a parallel meeting now in Moscow on hepatitis C, the Allianz medal they're just giving to the few people, and I'm just speaking there in probably another few minutes. But thank you very much for inviting me to join you this meeting. I'll be probably in this meeting again tomorrow evening. You've been doing a good job on PCOS, and I've been on several meetings reviewing your work, and I think
Shweta, can you hear me?
the work is going very well, and the project is, with all the difficulties of COVID, it is fast moving with all the efforts of all the people who are in the ICMR group. I wish you good luck for this conference as well as for your project, and I'll keep tracking of your developments. And I hope we hear some good news from India about the PCOS and the criteria and how we can look at these young ladies with this endocrine and multidisciplinary disorder. And it is diagnostic criteria, it is how we approach it, and what are the treatment protocols. Thank you very much for giving me this opportunity to join you in this meeting.
Thank you very much, sir. We will listen to you in detail tomorrow. Thank you very much. So, Nalini. So, can I continue with my?
Yes, Dr. Ashraf, go ahead.
Yes.
Go on.
Yes. So, I was saying in fact, I was saying that I am fortunate to have been given the chance to make this multidisciplinary group of metabolic syndrome, pre-diabetes, and PCOS. How actually it came to my mind when I was a faculty in AIIMS New Delhi, we convened a brainstorming session, a public lecture at AIIMS New Delhi. That time, I am thankful to few of the mentors, namely Professor M.C. Mishra, who was that time heading who was director AIIMS New Delhi, Dr. Randeep Guleria, who was that time head of the pulmonology division of AIIMS, and Dr. V.M. Katoch was also the DG ICMR. And shortly after that, Madam Somya Swaminathan also joined. Then there was that time Secretary DBT, Dr. Vijay Raghavan, who is this time Principal Scientific Advisor to the Prime Minister. So these few people were that time instrumental. We did a brainstorming. They guided us. I just presented some presentation in front of them. I said that PCOS is just close to diabetes, is close to metabolic syndrome, obesity, fatty liver, sleep disorders, and psychiatric comorbidities. So we told them that there is a need to converge between the specialties, because although there is a lot of diversification happening, but sometimes because of diversification, we lose track of these sister concerns. So there is a need to reconverge these specialties to understand a disease like PCOS and the related diseases. So that is how the names were suggested. Then there were my friends like Dr. Manas Barwa, Dr. Rakesh, Dr. Sanjay, and several others who gave their thoughts, and we put it together. And I was not, believe me, it was not my effort. It was the handiwork of all these friends who came together, and they told me, okay, you lead this group, and we got the society registered pan India, and we are looking for getting this society registered globally. And we have been, as Professor Rakesh rightly said, that we have done so for 3 meetings, and this is the 4th one. Despite of COVID, we have been doing some midterm programs also, and our membership has not gone beyond 130, 140 because of the COVID. We were not able to actually reach people. But the beauty of this society is how it is different from other societies, that we is a multidisciplinary platform. We have gastroenterologists, we have basic scientists, geneticists, we have endocrinologists, we have general physicians, we have gynecologists, pediatricians, psychiatrists, and whatever, most of the people are there just to give their thoughts. And idea is that we have to lead research in this country, not only understand PCOS, but understand all the lifestyle disorders. As Professor Rakesh introduced, that we are willing to involve some people who are in the outside government sector also, who are representing various areas, who are experts in their fields. They are seeing a lot of patients. We would like to see how this real world scenario is happening in our country. Actually, India is not a single country, it's a multitude of countries. So we need to know how these diseases are here, how these diseases are going to behave, how we can make people aware, and how we incite research into this area, so that the clinical practice changes tomorrow. So I am sure that the next 2 days we will be deliberating on the various topics which have been very carefully and scientifically made by Professor Sanjay, and I am sure that we will have deliberations. At the end, we will have a very detailed report which Dr. Saptareshi will give us, so that we will try to reorient our research areas in this. The PCOS task force study, which is supported by ICMR, is one of the small initiatives, but I am sure that we should start multiple initiatives through this society to incite research and involve more and more people into understanding these problems. With this, I thank all of you to giving me an opportunity to contribute in a little way for making the image of our country at a global level. Thank you very much.
Thank you so much for the excellent vision, sir. Moving forward, no session starts without thinking of the higher entity God. So a small lamp lighting ceremony, can we have the meeting, please? After the invocation and thinking in mind of the higher entity, let's move on with the address from the scientific chair, Professor Dr. Rakesh Sahai, sir. Sorry, Dr. Sanjay Kalra, sir.
Thank you, Dr. Nalini, and warm greetings to everybody who is gathered with us today. It's been a very fruitful, a very meaningful, a very pleasant experience having served as the scientific chair for this particular meeting. Everybody has contributed. Dr. Saptarshi and the entire team has done a great job under the tutelage and under the visionary leadership of Dr. Sarita Bajaj and Dr. Ashraf Ghani, Dr. Rakesh Sahai. The fourth Moods conference promises to be the jewel in the crown that Mppcos academics already is. I would like to make special mention of all the people who have contributed abstracts. I know that Dr. Bindu and Dr. Kotwal had a really tough time deciding the top 6 which would reach the platform. Actually, all of them are deserving. Let me spend just 1 minute talking about types of reasoning. Now, when you talk of reasoning or logic or theory, there is something known as deductive reasoning, D for deductive. There is also abductive reasoning. And then you can have reasoning which is incremental or inductive. In Moods 2021, all 3 will be on display. Deductive reasoning is when you have a generalized statement or a generalized fact, and then you D for deductive or you D for decrease it to apply to a smaller entity. As an example, almost all the metabolic disorders in women are associated with insulin resistance. Polycystic ovary syndrome is a metabolic disorder of women. So therefore, PCOS will be associated with insulin resistance. So you will find many abstracts, many discussions which follow the deductive path of reasoning. I for inductive, I for increase. So you have a specific observation, which is that maybe Dr. Ashraf Ghani says that in my clinic, I have seen that many women with PCOS have dysglycemia. So because of that, he inductively thinks that everybody with PCOS has dysglycemia. Now, this may or may not be true, but this is a path of reasoning. And at least it doesn't prove any hypothesis, but it allows you to create a hypothesis. Because I have seen so many girls with PCOS who have dysglycemia, let me begin testing all of them. Let me see whether I'm actually able to prove this or not. So that is I for inductive. And you will find many abstracts and many discussions which will follow the inductive path. The last one is abductive, A for abductive. And A for just A is next to A. That is that you see that in menopause, there are many causative factors, many clinical features, and many complications. You look at diabetes, you look at ovarian dysfunction, you look at metabolic syndrome, and you find that there is an overlap. the same causative factors, the same clinical presentations, similar complications, similar comorbid diseases, similar concomitant medication being given to all these. So abductive reasoning says, if this is true for menopause, it may be true for polycystic ovary syndrome as well. And if that is true for PCOS, it may be true for men also, men in midlife. This is abductive reasoning. And you will see some discussion which follows the abductive part. I would welcome all of you to enjoy Moods 2021. And while enjoying it, to just think about the thought process that all our speakers bring to the table. What kind of reasoning are they following? Is it inductive? Is it deductive? Is it abductive? And then when we go back to our clinics, when we go back to our research centers, suddenly the world will appear different to us. And none of us are going to forget Moods 2021, which is the jewel in the crown of Mppcos. Thank you.
Thank you so much, sir. Every scientific reason, and you have very well emphasized that. Next, we have a message from the chief scientist of WHO. She unfortunately could not be here, and then a message was sent by Dr. Soumya Swaminathan. Can we have her message, please? Second,
Dear Dr. Ghani, dignitaries and ladies and gentlemen, greetings from the World Health Organization. Thank you for inviting me to say a few words at this inaugural function. This is indeed a very unique gathering, and I must congratulate Dr. Ghani and all of the other office bearers who have come together in a very interdisciplinary and multidisciplinary group composed of clinicians, diabetologists, endocrinologists, obstetricians and gynecologists, probably physiologists and pharmacologists as well, to address the growing and important problem of metabolic syndrome, diabetes, and all of the related manifestations. There is no doubt that the burden of this whole syndrome, this group of diseases, is growing. Of course, diabetes is the most well recognized, and there are many prevalence surveys and estimates that have shown and a rapidly increasing trend of type 2 diabetes in India, but also in other low and middle income countries. So it's rapidly becoming a disease of the developing world rather than the developed world. And what is worse is that the outcomes are worse in the developing world because of many factors, including access to healthcare, access to diagnostic testing, and access to treatment, particularly insulin. Just last week, we celebrated the 100th anniversary of the discovery of insulin. And as you all know, Best and Banting donated the patent for a price of $1 because they considered that insulin as a life-saving treatment must be available to everyone, everywhere. So they did that in 1921, but yet in 2021, we find that insulin is definitely not accessible to everyone, everywhere. And rather than using relatively more affordable human insulin, the analogs of insulin are being marketed, and the global market is dominated by just a handful of pharma companies. So we have many issues to address, and I think this is one of those areas that you are all interested in, which has so much scope to work on, right? Starting from the understanding of the disease itself, the pathogenesis, what are the determinants of the disease, what are the risk factors, what are the modifiable and non-modifiable risk factors, how much is there of a genetic influence, how much is epigenetic. So start with answering those very basic but important questions. Then there's the whole epidemiology, because there's a spectrum of disease. One has to design studies very carefully in order to determine, what is the real true prevalence, or even to address questions like increasing prevalence in certain risk groups, etc. So to do those kind of representative population-based studies is quite challenging and requires a well-coordinated and well-funded approach. And then, of course, you come into more on the clinical side. How do you diagnose? What are the early markers? Can you actually prevent if you have certain indications that an individual or a child has this, or there is a strong possibility? What are those markers that we could use? Again, we have to think in a country like India of something that is affordable, accessible, but this is also an innovation challenge. I think once we define what the gaps are, then it is possible to get funding agencies to focus on those knowledge gaps and perhaps even launch innovation challenges to address those gaps. So, for example, if liver fibrosis is one of the things that is a good marker and needs to be detected early, is it possible to have a challenge thrown on developing innovations and solutions around detecting that kind of pathology? So that's just an example, but educating people is also a very big issue, because we know that there are risk factors, avoidable, modifiable and not. And unfortunately, in today's day and age, a lot of the risk factors for this syndrome are increasing, whether we like it or not. With increasing urbanization and the type of work that people do is changing, the type of lifestyles that we have is changing. There's much less of physical activity. There is much more exposure to processed foods for a variety of reasons, and there is exposure to air pollution, exposure to stress. So you can already start seeing that these risk factors could be adding up to precipitate onset of this disease in somebody who's maybe physiologically or genetically prone to it. So this is where, I think as doctors, we need to start also talking about prevention, because we need policy action in that space. It's not just enough to build more hospitals, to train more doctors and nurses. Of course, that is needed. But unless we address some of the root causes of the growing burden of non-communicable diseases in the country, it's like not turning off a tap, but trying to get a bigger and a bigger bucket to collect the water. It will never be enough. With the large population that we have, we will never have enough tertiary care beds to deal with all of the cardiovascular disease and the renal disease and the stroke that is going to come in the coming decades, unless we address the prevention and the health promotion issues. So I think we need to collect data and evidence not only on pharmacological interventions, but for prevention and treatment, but also on other interventions which are more upstream. And for that, we need the data, but we also need the advocacy, so that you get policy change. And the policy change probably needs to happen not just in the health area or in the health ministry, but across different sectors. So this is why it's really good to see that you have a broad and interdisciplinary group. It will be great to also include environmental scientists, chemists, social and behavioral scientists, perhaps demographers, anthropologists, food and nutrition scientists. You need all of these varying expertise and disciplines, and then one can really, I hope, come up with a research agenda at the end of this meeting that agencies like the ICMR and the other scientific funding agencies can support a research program, a research agenda, and support studies which are well designed, well conducted, of adequate size, in order to answer some of these important questions that no doubt are going to arise. But the knowledge in this field is also increasing, so it's important to have these kind of conferences to update, so that people, physicians who are dealing with patients, have the latest information available to them for diagnosis and management. So because you're having this in the virtual platform, it has been possible to connect and speak with you. I still remember my last visit to Srinagar, which was also a conference organized by Dr. Ghani and colleagues. And I'm looking forward to the day when we can all meet together in person. But meanwhile, I want to wish you all very good discussions during the conference and look forward to hearing about the outcomes, and wish you all the best. Thank you very much again for inviting me, and namaskar.
That was a wonderful message. The next in agenda is from Dr. Saptarshi Bhattacharya, vote of thanks.
So, thank you, Nalini. And so I am standing between the conference and the scientific program, and so I won't take much time. Nalini has been already pinning me that so you can only take 1 minute. So I think first of all I should thank Dr. Swaminathan, our chief guest, for delivering a very relevant message. Our sincere thanks to Dr. Kuro for taking our time. Also, our thanks to Dr. Vijay Angar and Dr. Randeep Bilaria, our special guests and guests of honor. So, this program wouldn't have been possible without the guidance of Dr. Sarita Bajaj. So, she just told me you can message me anytime, 24/7. If you have any problem in anywhere, just don't feel free to message. So, it was great to work with you, ma'am. And Dr. Ashraf and Dr. Rakesh, they were always the brain behind the whole program and the whole society. So thank you for selecting me to be part of this great program. Dr. Kalra he has been a mentor to many of us. He has again been very helpful throughout. Dr. Sarita has already elaborated the names of the coordinators. I really wanted to thank all of them personally because of shortage of time. You can't again repeat their names. Again, thanks to all the faculties for being part of it. Thanks to all the delegates who have registered, and also all the young endocrinologists and physicians and gynecologists who have sent their papers. All of them are really great. Also, our sincere thanks to USB, our pharmaceutical partner, NewMake, our event manager, and Imagica, our digital partners. So I won't take any more time. Nalini, back to you for starting the scientific session.
Thank you so much, Dr. Saptarshi, for being very brief. Due to the paucity of the time, I wouldn't take any more time. That's all from the inaugural session. I'll be handing over the stage to the scientific sessions. The first in scientific sessions is about the metabolic syndrome, and the coordinators for this are Dr. Mohan Chenoy from Sri Gokulam Medical College, and he's an consultant endocrinologist, and Dr. Shalimar, who is a gastroenterologist from All India Institute of Medical Sciences, New Delhi. Over to Dr. Mohan Chenoy and Dr. Shalimar.
Yeah, very good evening to all of you. So thank you, the PCOS Society and Mppcos Society, for giving me this opportunity. I think this is a unique conglomerate of global experts, international stalwarts, and national speakers. So I look forward to have a discussion for the session. So it will be lovely to have interactions from all of you. So we'll try to maximize the interaction quality. So without much ado, let me just also co-introduce my chairperson, co-coordinator, as well as the chairperson, Dr. Shalimar. May I request the organizers to please share the screen?
Okay, thank you, Dr. Chenoy, for the.
Yeah, let me just introduce you, Dr. Shalimar.
Sure.
Just a minute. Yeah. Yes, Dr. Shalimar, sir, is the additional professor working in All India Institute of Medical Science, New Delhi. He is associated with the Gastroenterology and Human Nutrition Unit. Sir has been honored by so many awards like ICMR International Fellowship 2015 to 16, Young Investigator Award, IST 2014, as well as 2010. Also, Srimati Kirpal Kaur Medal for House Physician 2001. He is actively interested in acute liver failure, acute and chronic liver failure, and so on, non-alcoholic fatty liver disease, which is also a point of our. Over to you, Dr. Shalimar.
Thank you, Dr. Mohan Shenoy, for the kind introduction. And it's an honor to be part of this fourth Mppcos virtual meeting. And gratitude to Professor Ashraf Ghani and Dr. Sarita Bajaj and the entire committee for the kind invitation. So it's a pleasure to introduce my co-chairs for this first session on metabolic syndrome. My co-chairs are Professor Nitish Naik, who's a professor of cardiology at the All India Institute of Medical Sciences. Maybe
can you share the screen? Excuse me, sorry. Imagica team, can you please share the screen?
Yes, sir.
Because we haven't introduced the other chairs, please. Thank you.
Okay, can we go to the next slide, please?
Previous slides, previous two slides. Yes.
Yeah, Professor.
Professor Nitish and.
Yes. Okay, go ahead,
okay.
Dr. Shalimar.
Let me introduce my co-chair, Professor S.K. Singh, who's a professor and head department of endocrinology and metabolism at the Institute of Medical Sciences, BHU. And along with Professor Singh, I have another co-chair, Professor Nitish Naik. Can I go to the next slide, please? So Professor Naik is the professor of cardiology at the All India Institute of Medical Sciences, and his interests includes clinical cardiology and cardiac arrhythmias. And so let's move on to the first session on metabolic syndrome. We've got two excellent talks in this session and followed by a case discussion. So I'd like to hand over to my co-chairs for the introduction of the speakers for this first session.
Thank you, Shalimar, and greeting from Varanasi. First of all, thanks to the organizer for giving me this opportunity to co-share with gastroenterologists as well as with cardiologists. And that we can sense that we are going to talk something common. And therefore, we have all these three co-chairs for the next two talks. As we just passed the dark days of COVID-19, and we all have gained this information that patients with diabetes, patients with hypertension and obesity had high chance of mortality with COVID infection. In fact, the obesity and hypertension, diabetes all had similar odd ratio. But what was more alarming that patients with metabolic syndrome actually had many more fold of odd ratio. They had odd ratio of 7 to have the seriousness of COVID infection as well as the chance of having COVID infection. So I think perhaps that was the reason it has become focus of the scientific committee to keep it as the kickstart lecture of the whole event. That's very, very topical, and I'm sure it is of interest to each one of us. So we have very good speaker, Dr. KVS Harikumar, my junior faculty, and I know him is versatile. I always sense academic interest of Professor Hari, and therefore I have taken this responsibility to introduce Professor KVS Harikumar. Can I have his credentials on the screen? Yeah. He's a consultant endocrinologist, now based in Hyderabad, affiliated to MAGNA Clinics, Fernandez Hospital. He had awards Sakuntala, Amir Chand, and MN Sen oration from ICMR. That is perhaps credit to his research work. And JS Bajaj Oration Award from National Academy of Medical Sciences, NAMS, New Delhi. His interest in thyroid disorders, gestational diabetes mellitus, and perhaps he has flipped to his interest to metabolic syndrome. And he is going to share with us on metabolic syndrome and COVID infection. Over to Dr. KVS Harikumar. Now, podium is yours.
Thank you.
Thank you, sir, for those kind words. It's always pleasure to listen from you and learn from you. And thanks to Professor Bajaj and Professor Ghani for the opportunity to be the opening batsman for the excellently conducting conference. And I mean, the energy with which the team was working is actually will put a lot of us into shame that what we are doing actually. Thanks to the kind words. Without wasting much time, I shall start the presentation, which actually will, as Sir has rightly said, it will be of interest to most of the people who are in the panel, that metabolic syndrome is going to touch each one of us. And does it worsen the prognosis of COVID and vice versa is what I'm going to discuss. I shall try and finish this in about 15 to 18 minutes so that we can have some discussion. Before I start, this is one of the memes which was there about last April when Corona was making noise in the world, not so much as then, but it was already there. When Corona is killing 3,000 people globally and we all lose our shit, whereas obesity is killing 3 lakh annually, but nobody bothers. That was actually the message. So possibly somewhere this has helped us in understanding or maybe putting back our focus onto the metabolic syndrome or maybe the non-communicable disorders per se. So I shall cover the topic under the following headings. Few slides about the introduction, the bidirectional pathophysiological links between the metabolic syndrome and COVID, some interesting data about the management approaches, what we look at, because some of the issues concerning ACE and ACE inhibitors, there were a lot of issues, and some practical recommendations to the clinicians who have logged in, and I'll conclude in 15 minutes. The pandemic of NCD was there lurking, which was growing by unimaginable leaps and bounds, but we all have taken it for granted and not maybe, I mean, educating people about lifestyle is not anything, I mean, it's not rewarding. That is why we just neglect it. Maybe prescribing drug is the easiest thing to do rather than educate or emphasize about the weight loss. But sadly, the obesity, the hypertension, the diabetes, they're all growing and growing. COVID came, COVID actually affected the entire population. And thankfully, some focus shifted towards the health of the patients, health of the population. So if you look at metabolic syndrome prevalence per se is about 15 to 20% of population, whereas the COVID almost about 70 to 80 or maybe 80 to 90% of the population. So in that bargain, you have a huge chunk of population burden involving these two disorders together. And the initial data which has shown that who are the people who are dying more, somebody who had hypertension, somebody who had diabetes, somebody who had obesity, they were dying more than when compared with the other people. So there is a link that you are likely to die more if you have these disorders. And the lockdowns, the remote monitoring, whether they have helped or not helped, lifestyle changes because of lockdown or maybe sitting at one place without movements, all those things. The world has completely changed the way we live and deal with the NCDs and even with the CMEs because we are doing it virtually now mostly. So that is how there is a sea change in what in our life in the last 1.5 years, which also is translated to the metabolic syndrome per se. The components of metabolic syndrome I need not emphasize, but it is just waist circumference, which is population and country specific, elevated TG and reduced HDL, and if hypertension or diabetes, either be your value or you're on treatment, they qualify for a label of metabolic syndrome. 3 out of 5 should be there. This was one of the paper published in Lancet, which showed that as your BMI goes up, your criticality with COVID goes up. So the patients with severe COVID, critical COVID, and critical COVID-19, the odds were very high as your BMI goes up. So you have a direct link that obesity induced worsening of the COVID spectrum. And why it happens? Because there are multiple reasons, mechanisms which are there. The obese host, they had increase in the ACE receptor expression. This is where the virus gets the portal of entry into the cell. So you have more viral spread. And obesity is a state of chronic inflammation. So you have more pro-inflammatory cytokines. So you have more inflammatory damage. and you have associated insulin resistance, which also impairs the immunity. So in a nutshell, the obese host, you will have a severe disease and poor clinical outcome. Not just a simple obesity. There are later on papers have looked at, is there an issue with the visceral fat alone also? Yes, most of the papers which have looked at the visceral fat also showed that you have a higher odds of having severe disease than when compared with the normal patients in patients with COVID. Looking at diabetes, a review from Professor Badada team at PGI, you have again a bidirectional link between diabetes and COVID. Again, some of the things which are there with the obesity will be applicable here also. Poor immunity, pro-inflammatory cytokines, and maybe a per se down-regulated ACE2 levels. I'll discuss ACE about at a later date. The use of ACE inhibitors, ARBs, which upregulate the ACE, they all will give you an increased risk or worsening of COVID. And COVID per se, some of the direct effect on the beta cells, the drugs, steroids were being used rampantly across the board, even in mild cases, or even if you have just a PCR report positive, and some associated insulin resistance and beta cell damage, all this will lead to a diabetes. So it's a self-perpetuating cycle, which is almost detrimental to the patient, that both promote each other and worsen the condition. Looking at hypertension, the third component of metabolic syndrome, the patients with hypertension, the all-cause mortality, they just had 23% increased mortality than when compared in patients without hypertension of about 7%. So if somebody with RAS blockade, almost the same. So this is one of the key factors initially, that you were using ACE inhibitor and probably the upregulation of ACE2 was happening, which was considered to be detrimental, but in the data did not show. And that is how most of the societies have given patient education leaflets immediately, that you need not stop your ACE inhibitors or ARBs. There is increase in the damage, increase in the fibrosis, increasing in the inflammation because of the overexpression of TNF alpha and IL-6, which is more inflammatory mediated damage rather than a direct upregulation of ACE2. So that is how a per se presence of hypertension because of vascular, because of inflammatory changes, you are likely to have higher mortality in patients with COVID. This is the issues regarding the ACE. The ACE is the protein which lets the S protein, the spike protein of the SARS virus bind on it, and this internalizes. Now, wherever there is the expression of ACE2, there is increase in the COVID burden in those tissues. So wherever, if you look at the specific clinical features, predominantly the lung, obviously the respiratory tissue, renal tissue, and some of the cardiovascular and GIT also. Now, beta cells also have ACE2, podocytes, cholangiocytes, and some of the glial cells. So any of these tissues which exhibit more of the receptor, that is ACE2, will have more damage in this infection. So these are the cells which are expressing the ACE2, and what happens, the loss of smell and taste was one of the key clinical symptom which we all looked at in the practice, and the expression of it is because of the ACE2 in the glial cells and neurons. You have significant proteinuria because of the expression on the podocyte and involvement of the kidney, and pneumocytes, obviously that's the prime portal of entry. Beta cells, again, lot of COVID induced diabetes at a later stage, there plenty of increase in the incidence of diabetes afterwards, is all because of this. So you had a significant issue because of wherever the ACE2 expression and more impact in such tissues. Dyslipidemia, there are two components of it in the metabolic syndrome. Recent paper published in the American Journal of Physiology, which said that cholesterol also plays a game as far as worsening the COVID-induced vasculopathy. The adipose tissue acts as a reservoir for the COVID virus, and again the cytokine and inflammatory damage, which leads to more of the inflammation and fibrosis and possibly the worsening of hypoxia and progression of the disease. Some of it has been implicated in the vascular events even after the COVID infection. That's why we use mostly the anticoagulants or antiplatelets. The liver dysfunction, which is not part of a definition of metabolic syndrome, but most of the times you get transaminitis seen, and ALT is a more specific marker. A network meta-analysis searching the published literature linking the COVID, AS, and liver disease had more links towards the ALT, and ALT is more related to the metabolic syndrome than AST, and possibly ALT was looked at as a clinical clue to predict a severity of COVID infection or maybe worsening progression, along with ferritin, along with interleukin-6 and other markers. So a more widely available marker and more robust marker which predict the liver dysfunction also. And the background is all because of inflammation and interleukin-6, lymphocytes, the NLR ratio, all those things are there part of COVID management protocols to predict or to assess the severity of the infection. And some of them are actually something like what is known as give you an indirect clue in the clinical practice. Something known as a chronic inflammation, that is inflammaging or inflammasome, actually will give you the true picture inside whether what is going to be the organic dysfunction or the metabolic dysfunction. And some of it is silent, so not picked up early other than the parameters, because at this stage of active inflammation, there may not be a very severe clinical feature. There may not be hypoxia setting in, there may not be tachycardia. So it is important to look at the inflammation also in the clinical practice. So in a, if I have to summarize the pathophysiology, the factor, the forest plot just tells what are the issues concerning the severity of the infection. If you look at the BMI, as you have a higher BMI, you have more severe risk. Age, obviously a higher age, you have a higher risk of the disease. And male sex have a higher worsening than when compared with female sex. Asthma, we will leave it. And diabetes with no diabetes had a better chance of survival. Diabetes with a decent control, 58 millimole, just translate to 7.5% A1C, and more than 7.5 have worse prognosis. And same with the worsening of kidney function and presence of heart disease or liver disease. So in a nutshell, the presence of metabolic syndrome worsens COVID, and vice versa, COVID, because of its affecting the multiple organs, worsens metabolic syndrome. What are there for treatment? We know that it does cause damage, but how best to prevent this or how best to streamline this? In next 5 minutes, I shall just give you some clues of selecting the ideal drugs. Metformin, thankfully, remains the best possible drug. Various mechanisms which says that it is anti-inflammatory and antioxidative, stress-induced damage, anti-neoplastic, anti-inflammatory. So there are a lot of mechanisms, and the meta-analysis in the COVID patients suggests that metformin users fared better than when compared with patients who did not have metformin. So you have some basic mechanisms also and clinical evidence also to suggest so. Pioglitazone, I will skip it for the paucity of time, not much data. DPP-4 inhibitors were the major culprit actually, because the DPP-4 as a receptor for the original, the Middle East respiratory virus, MERS was one of the, DPP-4 was one of the receptor for it. So they thought if somebody uses DPP-4, you are likely to get a better deal because you are inhibiting the receptor. So some data to suggest that if you are using DPP-4 inhibitor, you may have less severe COVID-19 because by reducing the virus cell entry and reducing the viral load, and they are anti-inflammatory because of wide CD26 inhibitions and increase in the GLP-1 levels, which helps in the cardiometabolic control. So the DPP-4 inhibitors, possibly along with metformin, if at all you have to use as a oral drugs in the management of diabetes in such, will give you the maximum benefit for improving the metabolic conditions, and some animal data to suggest that you have benefits even in the lung inflammation parameters. SGLT2 inhibitors were used left, right, and center in across the board spectrum, including the COVID, because again, they are one of the drugs which will reduce your weight, which will reduce glucose, which will reduce your blood pressure. So much so that there was a trial with dapagliflozin, which was published in Lancet few months back, the DARE 19, which did not show that people using DAPA did better than when compared with others. But pathophysiologically, they have some benefit because you're having more concentrated hematocrit because they are more diuretics. You have more oxygen delivery into the tissues. You will reduce interstitial edema, all those things, but not much benefit in the clinical practice. Acute care setting, possibly you should not be using them because you have more chances of euglycemic ketoacidosis and severe dehydration. HCQS more political drug rather than actual beneficial drug, approved in this part of the world for type 2 diabetes management, and chloroquine was used as a drug for avian influenza. Even HCQS, there are a lot of flips and flops about using this, not using that. A meta-analysis published a few months back again showed that users of HCQS did not show any much benefit with COVID-19, be it on the mortality or be it on the need for mechanical ventilation. So much so that it was more of a noise rather than actual benefit to the patient. If at all you have to use something, there are better drugs available rather than HCQS in the for the management of diabetes. This is a paper in the Journal of Diabetes which showed actually the anti-inflammatory properties of all the anti-diabetic drugs, and metformin, pioglitazone, and some of the gliptins did score better, and some of the gliflozins and GLP-1 molecules obviously will do better. So this is as far as the OADs were concerned. So if you look at the anti-diabetic drugs, critically ill appropriate, possibly only insulin and GLP. Improvement of COVID-19 may be DPP-4, and cardiovascular improvement, you can use GLP, metformin, and SGLT and pioglitazone. Anti-inflammatory effect, you can use mostly, and direct respiratory effect with GLP-1 and pioglitazone. So some of them have shown benefit, and then you can choose depending on what sort of benefit you want to get other than the primary glycemic benefit. The other issues in the metabolic syndrome, ACE inhibitors, ARBs, that lot of noise that to stop, but the data did not say, and because of upregulation of ACE2 is not worsening, it's a double-edged sword. So you're reducing the inflammation, fibrosis with the ACE inhibitors. So you are supposed to use them, continue to use without stopping. Statins also showed a mixed result. People were advised to stop statins. Again, a paper which Coronado was the study which said that not much of a relation directly in worsening the disease. So continue to use if the statins are indicated otherwise. Antiplatelets, again, there was a meta-analysis published which said that there is no direct worsening of a COVID with the use of antiplatelet agents as well. So you, by and large, keep the patient as per their primary indication with these drugs without altering them in the clinical practice. So to conclude, metabolic syndrome and COVID have bidirectional links. There's no doubt about it. Each one worsens the other. But mostly, I would say it's a great opportunity to focus on NCDs during this time, because many patients came that they wanted to get their sugar under control. So this is the time actually that it's like the window of opportunity what gestational diabetes gives you, that educate about their lifestyle, educate about the every aspect of the NCD, then that will be a good in a long run. Select OADs based on their immunomodulatory activities and use ACE, ARB or DPP-4 as per clinical condition. And mind you, very little RCT evidence. Now we are getting some RCT evidence, but most of it is observational data only. And educate about the comprehensive management of metabolic syndrome. That will give the best possible benefit rather than any of the things, whatever I have discussed till date. I have finished here. I shall be happy to take any questions now.
Thank you, Hari, for extensive coverage of the biology of metabolic syndrome and COVID-19. The time has passed, but then it has left a mark on our memory that the importance of metabolic syndrome in such situations is of paramount importance, as that we have seen. We never actually foresaw it that this is going to happen in COVID pandemic, but this is what has happened. So now there is a clear indication that the metabolic syndrome, which was initially not thought of as a disease, it was never classified as disease in the beginning. We didn't accept it as a disease, but now we understood that this is one of the very important comorbidity, and that we have just seen in COVID-19 pandemic. So I hand it over to the next co-chair for introducing the next speaker of the program.
So thank you very much for having me here. I would really like to thank Dr. Ashraf, Dr. Mohan, Dr. Sarita for inviting me here. It's good to see Ashraf, at least virtually. So hi, Ashraf.
Hi.
And
I welcome. I think I welcome Dr. S.K. Singh, who's been our mentor, and Dr. Shalimar.
This is a little exaggeration. I never have been his mentor. I'm his senior colleague. Maybe I am having less hair and he's having more. That's the only difference.
No, sir. Mentorship is a continuous process. It's not a one-time issue.
So kind of you.
So there are some questions in the audience, sir. Should we take it up now or should we leave it to the end, sir? Now only Shweta has sent some questions in the chat box, sir.
I think we can take it right now because maybe this is related to the present topic, and the next would be.
Yeah, I have typed one in the chat box. I can read it out. There is a question related to, so maybe the question can be seen by you, sir. I have shared it. Maybe SK Singh sir can also see it, sir.
Let me check if I can see.
Yes, sir. Why is IGHD type 1 presenting with reduced? That's different, sir.
Yeah. Okay. Why IGSD type 1 present with reduced birth length when intrauterine growth is dependent on IGF?
That is related to growth, sir, but I think we should take it up or not. That's actually come in the chat. So maybe you should decide.
I think it is Harry to decide. As he's flipping from one area, GDM, to now, he can be, he would be happy to answer this.
There are another question also has come, sir, related, because Shweta is sending me, so I just putting it on the group also. Increased incidence of dysharmonogenesis. That's also another question related to thyroid. So these are all questions which are coming up. So I request that we may decide whether it is required or not, sir.
I think don't leave it. We as endocrinologists, we have habit of thinking and brooding. So let us take this question. Why IGSD type 1 present with reduced birth length when intrauterine growth is dependent on IGF-2 basically. But when there is a growth hormone deficiency, IGF-1 is also deficient, and that is also responsible for intrauterine growth. It is not only IGF-2, but IGFs, in fact, all 6 IGFs, but predominantly it is IGF-2. So when there is a growth hormone deficiency, they will have some growth retardation that may be there. Many of the IGF type 1 may not have actually a growth retardation at time of birth also. That has also been observed. So I think Harry can also answer this question. This is what I have understood. Yes, Harry.
By and large, the growth is only IGF-2, and you don't get a significant length shortening at the birth even with GHD. So you don't actually look at in that perspective. So it's a mild way because of only the IGF-1 being with the GH. Okay, so I think because these are all actually Klinefelter, we'll just finish off here. Klinefelter should be start with adult dose. Generally, we don't give a full dose of testosterone to start with whenever the patient comes. So just gradual building up, maybe a rapid build-up rather than a very monthly build-up is only thing to be done. Subclinical hypo, do we diagnose if TSH above 97 percentile? Unless you have the normative data, we don't look at 97 centile. Most of the labs, you give you that value and then you take on that. There are increased incidence of dysharmogenesis, hypothyroidism reported in Asian, are the same trends seen in Indian population also.
These are all the things because the COVID context makes us more vigilant towards thyroid diseases. So maybe that's an audience which is really observing so much of these are lab issues are also happening around. So that's why I think the questions are, though not relevant to your talk, maybe they're all vigilant towards all the aspects of thyroid and metabolic syndrome. So I think We should always try to think, but I think these are all different from the topic. So I had one observation to make, sir, regarding ICU and steroids, sir. So do you have, sir, because I just wanted to know from you also, sir, regarding that. The ICU patients with COVID infection may get steroids, and do they have a prolonged requirement of insulin later on? So do they have a chance of resolving diabetes also later on?
Yeah, some of them actually, when they were not picked up, it's like most of the patients first time came into medical attention through COVID. And that is the time you look at the, whatever be the severity, if they are admitted in the critical care, they were given steroids. Some of them, those background, if you check those A1Cs, they are about 7%, 8%. So it's like those picked up diabetes at that point of time and then continue to remain requiring some of the drugs even later stage, continue to remain requiring insulin for a longer time. Actually, COVID-induced diabetes, there are very many number of patients whom I saw in the clinical practice who just had COVID, maybe a mild COVID also, and suddenly somebody with a normal annual checkup last year, and now he is coming with A1C of 9 or 10. So a lot of them does exist. So including the dose of steroids, but more than that, ICU, I would say the rampant misuse of steroids in OPD setting, even in mild COVID, has actually worsened the spectrum.
Yeah, I think my experience, we have very large diabetes pool, and we had a level 3 COVID center in our hospital. What we observed that most of our patients who were on anti-diabetic drug and fairly controlled had very high sugar after hospitalization with COVID infection, even though they had not been on steroid. And many of them who were having borderline uncontrolled diabetes, when they received steroid, their sugar level was very high. Interestingly, though we knew that because of cytokines, maybe insulin resistance was the major thing, but the literature also suggested that there would be a defect in the beta cell function with COVID infection, and that was also propagated. But what I observed, and many of my colleagues observed, that most of these patients actually have done well after COVID has gone into remission and steroid dose were tapered off. Their sugar level settled. And many of my patients actually are coming now to say that their sugar is fairly controlled with the same drug which they were before COVID infection. So I don't buy that idea of beta cell destruction due to COVID infection, which has been propagated. That's an interesting observation. And the second thing, that steroid was used quite illogically, I would say, in many settings. And that was the major cause of mucormycosis, which we saw across. Now we have stopped seeing mucormycosis. People blamed could be diabetes, but I have not seen. I have seen only 2 patients of mucormycosis in my settings. You can imagine with a patient turnaround of diabetic patient turnaround of around 700 a week. Still, I have only 2 patients of mucormycosis in my whole of 30 years career. So it seems that irrational use of steroid along with suppressed immunity due to COVID was the major cause of these things.
Okay. So thank you, sir. So I think we can move on with the, so Dr. Nitish, sir, please take over, sir. Thank you, Dr. Harikumar, sir, for that excellent talk. Thank you, SK Singh, sir. So thank you, Doctor. So can you just, sir, Dr. Nitish, sir, back to you, sir.
Yeah, so I think so we have Dr. Nitin Kapoor in the waiting. He is a professor of endocrinology at in CMC Vellore, and he has numerous credits to his honor. He has received the AR SAID Gold Medal by the Endocrine Society of India in 2020. He's also received the Sri Lankan Endocrine Society Award. He has got a research scholarship from Melbourne, and from the Tamil Nadu, Dr. MGR University has awarded him a gold medal for endocrinology in 2015, and numerous other awards to his name. He has got a number of publications, over 140 PubMed indexed articles in various areas in endocrinology. And he is currently also the editor of a book on A Practical Guide to Diabetes Mellitus, which was released in 2018. And the topic that he's going to be talking upon is metabolic syndrome and gallbladder disease, newer insights. So we look forward to his talk, and then we can have discussions later.
Thank you very much, sir, for that kind introduction. Thank you, Dr. Ashraf, Dr. Sarita ma'am, Mohan, and everyone for having me here today and for that very kind introduction. Over the next 15 to 20 minutes, I'm going to take you through this topic of how there is an interrelationship between the gallbladder and metabolic syndrome. And this is indeed a very interesting topic, and we are going to look at what the evidence is there to suggest the link between the two. And over the years, I think all of us know that gallbladder has been considered as an organ which is, not really essential for life. It has been considered non-indispensable and can be removed. Rather, cholecystectomies are the most commonly done surgeries across the world. But the irony is that even though cholecystectomies are the most common surgeries done across the world, it is the data that has emerged from these patients who underwent a cholecystectomy that have actually taught us how the importance of gallbladder is there as a metabolic orchestrator. And that's what we are going to try and focus. And this will be the first part of my talk, where we are going to look at the metabolic consequences following cholecystectomy. That's one part, which is let's take a step backward before cholecystectomy. And when we have patients with cholelithiasis, and again, what we know from our knowledge and literature is that metabolic disorders themselves can predispose to develop cholelithiasis. So that's another dimension how we relate gallbladder and metabolic syndrome. But there is also a third dimension to the whole thing, and that is when you talk of weight loss regimens or treatment of these metabolic disorders, and that also has an impact on gallbladder. So this would be the theme of my talk, and these would be the three broad domains that I would cover. And I think let's get started with the first aspect, where we look at the metabolic consequences following cholecystectomy. Now, I think we all know that cholelithiasis or gallbladder stones is something really common in our community. This was a community-based study from PGI Chandigarh a couple of years ago, and they looked at symptomatic and asymptomatic people in the community, but even asymptomatic people from the community who have no complaints. The prevalence of cholelithiasis from Chandigarh was about 3.3%. I think we all have learned from our medical school the famous 5 Fs that we talk about with cholelithiasis, and that was again proven in this study as well. The fat, 40, fertile, female, maybe fair for the Western counterpart, but these 5 Fs predisposed to gallbladder disease, and cholelithiasis is indeed very, very common. Well, that is there, but how about the metabolic syndrome story? And when you do a PubMed search with respect to cholecystectomy and metabolic syndrome, we see that most of the literature has emerged in the recent years, in the last 4 or 5 years. That's true, but the first paper that talked about this was way back in 1957, a German article which talked about metabolic disturbances after cholecystectomy. So this is not something that's very new, but yes, more and more literature is emerging in the recent years. So let's talk about some absolute figures as to what is the metabolic risk conferred by cholecystectomy. And this is a paper which was published in 2012, data for around 800 patients. And when we look at the odds of developing diabetes, high blood pressure, dyslipidemia, and the other risk factors put together, we see the odds is really high, especially for blood pressure, 5.1 times higher in people who underwent a cholecystectomy as against those who have not. So all these metabolic disorders seem to be more common in people who underwent cholecystectomy. So this is published data. There's several such data, but really when you try and understand why does cholecystectomy cause or is associated with metabolic syndrome more commonly than those who've not underwent a cholecystectomy. And for that, I think it's important to just go back to physiology and just see what is the normal function of gallbladder. And I think all of us know that the major function is to concentrate bile, basically to absorb the salts and the water from the bile and make it more concentrated, maybe 5 times more concentrated than the usual. But what is another function of the gallbladder is also known as the motor function, wherein it empties about a third of its capacity every 2 hours, and it empties up to 3/4 of its capacity after every meal. And I would say when we talk of metabolic syndrome, this indeed is the most important function that we have to know about. And I'll come back to that in a minute. Well, the other functions are obviously to also let the bile acids get into the enterohepatic circulation and the bile that is helpful for absorption and the storage of all of that. And we know again from literature, bile acids per se are really good for metabolism. Several pathways that have been described. I won't go into all the details, but yes, it's good for lipid metabolism. It's good for glucose homeostasis, and overall, it improves energy expenditure. So bile acids per se are really, really good. So if bile acids are good, what does cholecystectomy do it so bad that we develop metabolic complications? And well, the answer to that is regarding the motor function that I spoke about, the physiological function where it is important for the gallbladder to secrete bolus amounts of bile acids in the circulation. So this is what happens in a normal person without cholecystectomy, where a bolus amount of bile is secreted when the food comes in, and there is an intermittent secretion that happens in between. But it is this bolus amount which is really helpful in stimulating all those good metabolic pathways that I showed you on the previous slide. But what happens once the gallbladder is removed? Once the gallbladder is removed, the bile acid flow becomes continuous. It's no longer a bolus flow. And the closest analogy to this, probably from endocrinology, that I can pick up is of parathormone. We all know parathormone can be used for treatment of osteoporosis if it is given intermittently. If you give parathormone every day, one subcutaneous injection, 20 micrograms, it improves bone mineral density several leaps and bounds. But the same parathormone, if it's secreted continuously by a parathyroid gland, it causes osteoporosis, it causes osteomalacia, it breaks the bone. There are fractures. Similarly, here, it's really good to have a bile acid flow, which is in huge quantities. And as I mentioned, about 3/4 of it comes after every food. And that stimulates all the good functions of the bile acid. And intermittently, it would empty about 1/5. So that this peak and trough, which is said to be important for doing the metabolic functions. Is that all? Is that the only reason why removing of the gallbladder is bad for metabolism? Probably no. And there's also this talk about FGF19. This is another, I may say, a hormone or the endocrine function of the gallbladder. It secretes this hormone FGF19, which is also very, very important in improving the metabolic profile. It reduces the serum triglycerides, the cholesterol. It increases the glycogen synthesis. Very importantly, it also improves the insulin-induced, suppresses the insulin-induced fatty acid synthesis. So therefore, reduces fatty liver and many of these good functions. So FGF19, another hormone secreted by the gallbladder, is important for improving the metabolic function. And after cholecystectomy, that is also gone. So these are two things that I mentioned. I mentioned about the importance of bile acids going away. I mentioned about the importance of FGF19, but that's not all about it still. Yes, there is increase in enterohepatic circulation after cholecystectomy. So there's a lot of bile flow to and fro, lot more cholesterol absorption than what would happen in somebody who has a gallbladder. Not only this, after cholecystectomy, especially in patients who've had terrible pain because of stones intermittently, they feel more fit and they tend to eat more. Not only this, there are also epigenetic mechanisms that have been described. So we see that several mechanisms have been described that after cholecystectomy, there would be changes. There would be changes in hormones. There would be changes in different metabolic pathways, which ultimately increase the pro-inflammatory adipocytokines, increase the inflammation, increase the risk of developing all these metabolic problems, and increase the insulin resistance as well. Right, so that's what it causes. So maybe cholecystectomy may be a way forward for getting rid of cholelithiasis and pain, but it may be a step backward for metabolic syndrome. And most current literature would say that cholecystectomy should not be just done at the drop of a hat. It should be done in people who actually need it. We don't think that it's just another vestigial organ that can be easily removed if not required. So that's the first part of my talk, where we looked at how cholecystectomy can lead on to metabolic syndrome. Let's look at the second aspect, and this is where I said that let's step back before cholecystectomy. And when a patient we have with cholelithiasis, can metabolic disorders contribute to cholelithiasis? I think we've all heard about the omnious octet of diabetes. So this is also something that is there, which is an omnious octet of obesity. There are 8 different aspects which are described. And in the gut, I think the gallbladder takes a major role. So far, in this entire complicated cycle of slide, I have spoken to you already how cholecystectomy is bad for metabolism. But now I'll concentrate on this aspect of the slide where we're going to look at how metabolic disorders can cause problems with the gallbladder. And I think this is something that we all know. Whenever we study risk factors for formation of gallstones, we see all of these factors well within there. If you have to actually pen down some numbers, and this was an interesting study which looked at the importance, the association of metabolic syndrome. And this was done in over 200,000 patients, looking at different components of metabolic syndrome and the incident cholelithiasis. And we see as the number of components increase for metabolic syndrome, the odds increases. And the most important, and if there was one important point from the metabolic syndrome that I have to pick up, it is the low HDL, which is having the highest risk. So yes, people with metabolic syndrome are also prone to develop cholelithiasis. This is data from our own center here in Vellore from the obesity clinic, where obviously people have a lot of high risk, and this was an ultrasound done in asymptomatic people for looking at fatty liver, and about 23% of them had asymptomatic cholelithiasis. So what is the pathogenesis of obesity leading on, or metabolic problems leading on to gallstones? And I think, again, we look at the normal physiology. We look at how normally the bile is formed. This is formed through the cholesterol, through the bile acids. But what happens in patients who have insulin resistance? There is increased HMG-CoA reductase activity, which you all know is the rate-limiting step for cholesterol synthesis. So this is increased. There's more cholesterol. There's more intestinal absorption of cholesterol, and therefore there is more cholesterol pumping inside the bile. With insulin resistance, there's upregulation of these nuclear receptors called LXR, which also pumps in more cholesterol. But unfortunately, there's also downregulation of the FXR. Downregulation of the FXR is important because it reduces the bile acids, which is an anti-lithogenic component in the bile. Not only this, increased insulin resistance also causes dysmotility of the gallbladder. This motility is contributed also by autonomic dysfunction. But insulin resistance everywhere today, there's also a talk about whether metformin should be used for preventing gallstones, but that's still a matter of research. But overall, we see several mechanisms, not only how gallbladder removal can lead to metabolic problems, it's also the metabolic problems can lead on to gallstones. When we talk of individual studies and we look at the odds ratio, there's several studies for each of these factors. So if there's low physical activity, you see there is an increased risk of getting stones. If there is hyperglycemia, diabetes, hypertriglyceridemia, NAFLD, and even dietary factors that have been described, overall, if all of these are present, the risk increases. But for us as clinicians, probably what is important, it is important to be able to know which are the risk promoting factors, which are the risk reducing factors, and there are several evidence to support several different diets which are not good for cholelithiasis and otherwise which are good for cholelithiasis. So this was the second part of my talk where I wanted to mention about the impact of metabolic disorders on cholelithiasis. There's a third dimension to this entire combination of associating gallbladder with metabolic syndrome. This third aspect is talking about the impact of weight loss regimes on the gallbladder disease. And this is a slide that I showed sometime before. And if I was to pick up one of the factors for cholelithiasis, which is most important and with the highest impact or the odds ratio, and that is marked weight loss to the scale of 25%, can have an odds of 4.4 in causing cholelithiasis. So even treatment of metabolic disorders at times can lead to cholelithiasis. This treatment has to be more strict weight loss. So it's either with very low calorie diet or when we talk of remission of diabetes or bariatric surgery and where in this recent guideline led by Dr. Saptrishi, it is mentioned that abdominal ultrasonography should be done in patients who have a suspected symptomatic biliary disorder. And when we look at the evidence with respect to bariatric surgery, evidence with respect to very low calorie diet, I think different studies have shown an increased risk of gallstones. The figures of incidence are about 3 to 5% every year. Amongst drugs, these are the FDA approved drugs for obesity. I think the only one which can cause some good amount of weight loss is GLP-1, not to the scale of 20 to 25 kgs. Semaglutide, the role is yet to be studied, but even for liraglutide, there is evidence of increased risk of getting gallbladder stones by using liraglutide, and the hazard ratio here is 1.6. So again, cholecystectomy is more frequently performed in patients who use liraglutide. What is the reason why the acute weight loss causes cholelithiasis? Very similar, as I mentioned before. Again, there is cholesterol oversaturation in the bile. Several mice and rat experiments that have shown how cholesterol oversaturation in the bile leads on to increased cholelithiasis. So I know I mentioned 3 dimensions, and maybe I thought it would be good to sum up all of that in a single slide. Dimension was, yes, cholecystectomy itself is a risk factor for developing metabolic disorders. We talked about the role of bile acids in FGF19, that is from the gallbladder aspect, but in addition, there is epigenetics, there's increased cholesterol absorption, there is increased appetite, that is a problem, but also we saw that the cycle is complete with metabolic disorders also leading on to gallstones. Several metabolic disorders, insulin resistance in center, but low HDL is said to be one of the important ones. Not only that, even therapy, rapid weight loss can also lead on to gallstones. So this is, in short, the whole summary of the association between gallbladder and metabolic syndromes. The key takeaways from this presentation would be that we need to avoid cholecystectomy if it's really not needed. And those who need to go, they need to undergo metabolic screening. I know the evidence is still emerging, but as we get more evidence, this is probably how the future will look. Those at risk need to be screened. So those with metabolic disorders are at risk for developing cholelithiasis and even acute weight loss, especially patients with bariatric surgery also have a high risk of developing cholelithiasis. So I'll stop here, but would be happy to take questions. Thank you.
Thank you, sir. Sir, so far we have not received much questions, so I think shall we wait for some time before after the panel? Can you just wait on for some more time till we have the panel as well? Because we are a bit late on it. So thank you, sir, for that talk. Thank you, Nitish, sir, for being the chair. So Dr. Shalimar, can we go ahead with the panel discussion?
Sure. I think let's move to I think we had a very excellent discussion and excellent session so far. And so our next in the agenda is our panel discussion. So let me just hand over to Dr. Arundhati for the introduction.
We can have the CV slides as well. Request the team for the CV slides also. Yeah. Shweta and team, please.
So over to Dr. Arundhati.
Dr. Arundhati, we can introduce her. Madam is working in Siliguri in Rudraksh Specialty Center. Madam is honored with the A.V. Gandhi Award 2012 Best Thesis and Diabetes Awareness Initiative 2018. She is a very renowned endocrinologist in Northeast as well as in whole of India. So welcome, Madam. So I think we also have the presenter with us, the interesting case we'll have. So we can also have her CV as well. Dr. Parul Gupta, she is working in AIMS, Jodhpur as a third-year DM resident. She's honored by so many laurels. You can see her in the MBBS, MD level, all these. And she's continuing to have raising the flag of ESI in the DM endocrinology course as such. So she's having an active interest in pediatric endocrinology and also in type 1 diabetes. So we also have the panelists with us. So can we proceed with the panel discussion CV slides also? Next slide. Yeah. Dr. K.T. Shinoy is a professor and head of Department of Medical Gastroenterology at Sri Gokulam Medical College and Research Foundation, Trivandrum. He is working in Trivandrum for the last 35 plus years. His awards include award of Dronacharya Award, Hepatology 2019. Interests include hepatology, clinical research, biostatistics, research methodology. Welcome, sir. Next panelist, we have Dr. Next slide, please. Dr. Madhukar Mittal, sir. Madhukar Mittal, sir, is working as additional professor in Department of Endocrinology and Metabolism in AIIMS, Jodhpur. Dr. Parul's teacher, and he's honored by 27 national international publications, including 10 book chapters, lot of awards, and active interests include endocrine health advocacy, osteoporosis, metabolic bone disease, reproductive endocrinology. Welcome, dear sir. Next slide, please. We also have with us Dr. Mangesh Chitwativaskar. Sir is a consultant physician and diabetologist working in Shilpa Medical Research Center, Mumbai. His honors include is the honorary General Secretary of National API, which is the largest body of physicians in India. He is a gold medalist of MD, MBBS level. He is on editorial board of major journals, including Medicine Update, International Journal of Diabetes. He is also editor-in-chief elect of the Journal of Physicians of India. He has delivered more than 1,000 lectures at national and international levels, as well as a MRCP examiner for the Royal Colleges, UK. Next panelist. We also have with us Dr. Devasenadipati Kantaswamy. Sir is working as additional professor in AIIMS, New Delhi. He is having more than 100 index publications and over 100 lectures and conferences and CMEs. Active interests include radiology in pediatric, then endocrine imaging, as well as abdominal imaging and imaging informatics. I remember him because he came for us in the SECon 2017 in Trivandrum. Welcome, sir. That is a panel so far. So next slide. I think we have done with the introduction of CV slides. So over to you, madam. Madam.
Thank you so much, Dr. Mohan. That was a wonderful introduction of all our panelists and our presenter. So the scheme of this part of the meeting is that we're going to have a case presentation, a wonderful case presentation by Dr. Parul Gupta. And once she's done with the presentation, and we have allotted her 5 minutes and she has to really rush through her slides, but we hope to get to the major points at the end of the presentation. And then we will have, as you just saw, and Dr. Mohan just introduced to us, we have a spectrum of expertise from gastroenterology to radiology to endocrinology and internal medicine. We hope to discuss the various aspects of the case with our panelists. So please do keep in mind the points that you would like to highlight on so that you can give us the questions and we could put it forward to them. So on that note, I'll ask Dr. Parul Gupta to take over and present her case, please.
A very good evening to everyone. My case is a 49-year-old female. She is a receptionist. She presented to us with complaints of
I cannot hear Parul very well. Can you hear?
Yes, please increase your volume, Dr. Parul.
Yeah, hi, Parul. Are you there?
Maybe you can come closer to the mic.
Yeah, please come closer to the mic. Yeah.
Sure, sir.
Yeah.
Is it audible now, ma'am?
Yes, yes. Yeah. Perfect. Perfect.
So my case is a 49-year-old female. She is a receptionist. She presented to us with complaints of type 2 diabetes since last 8 years, for which she is on oral drugs. She is a known hypertensive since last 4 years, and she has a history of 8 kg weight gain over past 2 years associated with increased snoring since last 1 year. She also has history of pain in the upper abdomen since last 1 year, which is diffuse, dull aching, and associated with postprandial bloating. She has history of irregular menses since 1 year with progressively increasing cycle duration and history of amenorrhea since last 2 months associated with climacteric symptoms. She also has noticed increased facial hair growth since last 1 year, which is predominantly on the face without any associated virilization. She takes a mixed diet of almost 2400 kilocalories per day. She has a habit of intermittent snacking, including at night, and she takes fast food occasionally, almost 1 to 2 times per week. She does not follow any routine exercise regimen, and because of the work profile, she is sedentary for almost 8 to 9 hours. She takes occasional alcohol, and she has to do a night shift once per week. Her family history is significant since both her parents were diabetic, diagnosed at the age of 40 years. Both the kids are obese, and the daughter has history of menstrual irregularities and is on OCPs since last 6 months. There is a history of premature cardiovascular death in the father, who died at the age of 48 years. She is currently only on tab metformin 1500 milligram along with glimepiride and telmisartan, on which she has a poor compliance. On examination, her blood pressure was within normal limit. Her BMI was 32.8 with a waist circumference of 96 centimeter and a waist hip ratio of 1.09. Her modified FG score was 9. She also had acanthosis nigricans grade 3 along with multiple skin tags. On per abdomen examination, she had hepatomegaly, but there was no other stigmata suggestive of chronic liver disease in the form of icterus or spider nevi. Her rest of the systemic examination was within normal limit. On her investigations, she had a deranged fasting and postprandial plasma glucose with an A1C of 10.4 and a time in range of only 18%. Her fasting insulin was on a higher side with a HOMA-IR ratio of 8. She did not have any anemia or cytopenia. Her kidney function test showed a EGFR of 90 and urine and fundus examination was normal. Her LDL was 153, triglyceride was 266. Her SGOT and SGPT values were 92 and 87 respectively. And ultrasound upper abdomen was suggestive of a fatty liver grade 2. So we calculated the APRI and the FIP4 score for her, which were both in the indeterminate range. The AST-ALT ratio was more than 1. The NAFLD fibrosis score turned out to be 1.47, which was suggestive of a fibrosis. So we underwent a fibroscan for her, which showed a fibrosis value of 6.5 kilopascal with a CAP score of 250, suggestive of a mild fibrosis. Also, in view of history of menstrual irregularity and facial hirsutism, we did her further hormonal profile, which showed an elevated testosterone and an ultrasound pelvis with a bilateral bulky ovaries with polycystic ovarian morphology. So our final diagnosis in this patient is, she's a case of 49-year female with type 2 diabetes with a poor glycemic control, with hypertension, obesity grade 2, obstructive sleep apnea, and diabetic dyslipidemia. Thus, our patient had all the 5 components of metabolic syndrome associated with non-alcoholic fatty liver disease with a possible steatohepatitis and a possible polycystic ovarian syndrome. So we initially started her on a lifestyle management. We advised her a diet of 1400 kilocalorie with regular exercise. We suggested her to start injection liraglutide, but she refused due to financial constraint. So we continued her on metformin glimepiride and added a DPP-4 inhibitor along with a statin. We are planning to follow her on a 3-monthly basis and are targeting a 5 to 7% weight loss over the next 6 months with a good glycemic control. Thank you.
Thank you so much, Dr. Parul. That was an excellent presentation. So I would just request you, Dr. Parul, could you just go back to the slides and just keep one slide where you had all the entire diagnosis so that we could just mention these points one by one. So let us look at this case that she has presented, where you could use the slide where you've given the final diagnosis, See, when we see such cases, she has very beautifully, split up the diagnosis. Generally, these patients will get mentioned as type 2 diabetes and hypertension, and the rest of it will not be mentioned in the clinics or in a busy OPD, or maybe at most the dyslipidemia. The obstructive sleep apnea part is a lot of time missed. NAFLD, if you're looking for it, then you get it. If you're not looking for it, a lot of times we do not get to see, we are not looking for what we should have looked for, and we miss out on that. And that may result in a lot of issues. So my first question to our panelists would be to Dr. Kandaswamy. We would like to have a bit of elaborate discussion as much as you can within these 6 to 7 minutes that would be allotted to each panelist, that what do you think is the most accurate measure imaging for the estimating the liver fat? And we usually do an ultrasound in our practice. We don't generally go for the MRI. Fibroscan is also not available everywhere. So could you just elaborate on the roles of the USG, the MRI, and the Fibroscan, please?
Yes, ma'am. So as far as fatty liver is concerned, in liver, we can look for 3 things: fat, inflammation, and fibrosis. These are 3 things we are interested in. As far as fat is concerned, the best imaging modality is MRI, which is the current state of art. MRI is based on PDFF, proton density fat fraction method, is the most accurate measure of fatty liver. If you're looking for fibrosis, then even MRI elastography, fibroscan, or shear wave elastography, these are the 3 options. So if I restrict myself to fatty liver, most commonly used investigations are either ultrasound. Ultrasound is mainly widely used because of its availability, ma'am. and ease of doing it, and cost is also less. Otherwise, ultrasound is not a great modality to assess fatty liver, but as a screening tool, you can use it in any clinical scenario. But if you want to use it for any clinical trial, or if you want to do it in follow-up, then ultrasound is not a good modality. But it is very insensitive to mild fatty liver, and even during follow-up, if you are interested in looking at difference of 5% or 10% change in the fat quantity for fat in the liver, then ultrasound is not a good modality. So in short, the best modality would be, modality of choice would be MRI, both clinically as well as follow-up, and in the clinical trial scenario, MR-PDFF is the most accurate one.
But say for our clinical practice, asking a patient to do an MRI is not always feasible.
True.
They'll be paying it from their pockets. So do you think FibroScan is equally good? I mean, we're getting the FibroScan in a lot of centers these days.
Yes,
so.
FibroScan. Yes, ma'am. FibroScan gives at least one vendor gives two parameters. One is the fibrosis, the amount of fibrosis in kilopascals, and the other parameter is CAP, which is controlled attenuation parameter, which roughly translates into the fatty fat content in the liver. But again, ma'am, it's not the accurate measure of the fatty liver. There are many studies which has conclusively proven that ultrasound or any ultrasound based modality, even FibroScan is also an ultrasound based modality, just the technique and the way of reading is different. But these are ultrasound based modalities. They are not optimal. If there is 10% change in the fat content or 5% change in the fat content in the follow-up, just based on ultrasound, it will be difficult. But if you want to just screen the patient, whether there is there is anything abnormal, then ultrasound is a good modality. But if you are interested in follow-up and want to accurately assess how much it is, which usually needed in case you want to intervene, then MR is the best modality. Not even CT, ma'am, here. So MR is the way to go.
And how often would you ask for follow-up from the imaging point of view?
Yes, ma'am. So it depends on the intervention you give it to the patient. If it is just exercise, or that should be entirely based on the expectation based on your intervention. If it is exercise based or food based or even drugs, then accordingly you have to change the follow-up time. But MR is very sensitive, so we generally do not entertain anything less than 6 weeks, ma'am. So if it is exercise, it can be 3 months, it can be 4 months, but not anything less than 6 weeks.
Right. Thank you so much. My next question is to Dr. Katie Shenoy. We just saw this association between this patient had a PCO. We don't know whether that's PCO. We'll term it as PCO or not. We'll go on to that discussion. And the NFLD. So could you tell us the connection between PCO and NFLD, or obesity and NFLD? How strong is the connection? How often should we suspect? Should everybody get screened for an NFLD if he or she has obesity, or he or she has a PCO? Would you advise that?
Well, I think this question can be answered with the two different aspects. As we know, the syndrome of PCOS is not one single entity. It is a complex phenomena with at least 4 different phenotypes, A, B, C, and D. In our own population-based study of approximately 2,000 subjects, out of which 1,000 were approximately females, we find that among the females in the population, 8 to 10% of them have PCOS. And if you look at the PCOS phenotype and their weight, 85% of those with the PCOS are obese compared to 15% who are not obese, something like non-obese PCOS. The relation between PCOS, obesity, and NAFLD is almost like a coin. If you investigate PCOS for NAFLD, 95% of them will have non-alcoholic fatty liver disease. The reverse is also true. If you take an obese woman and try to look at the prevalence of PCOS, approximately 85 to 90% of them will have the features of PCOS, which will be a classical PCOS, or which is called as the phenotype A, which is hyperandrogenism, ovarian dysfunction, and all the other features like the scoring system, which Dr. Parul mentioned. So 8 to 10% of women in the population of PCOS, and obesity is one of the most important concomitant or a predisposing risk factor. But nevertheless, PCOS is not a disease related to ovarian dysfunction. It is a disease which is occurring at the hypothalamic level. The changes in the hypothalamus in the form of changes in the kisspeptine, the melatonin secretion, I think is a very important factor. And I believe that PCOS, NAFLD, both these diseases are more related to changes occurring in the higher system. We have a study with Rajiv Gandhi Center for Biotechnology with Dr. Malini looking at PCOS, NAFLD, the kisspeptine, and the melatonin, as well as the various receptors for these hormones. Now, coming to the obesity itself, I think obesity itself can be taken as something like a phenotype marker for a woman who can develop PCOS.
So on that note, could you please tell us about the determinants of NFLD? And are you regularly following for this, as you just said that, NFLD is very common in PC or obesity. Would you recommend using of these scoring systems that were mentioned in the case? Would you recommend it to the clinicians for regular usage to identify NFLD or to identify the prognosis thereafter?
I think the scoring system which Dr. Parul mentioned, they are all directed towards not the diagnosis of NAFLD, for the diagnosis of fibrosis. If you look at fibrosis, the markers can be non-invasive or the invasive markers. Invasive marker is the liver biopsy, which is not always done unless it's a research setup where you want to try a new drug. But if you look at the non-invasive markers, we have a plethora of markers, which are blood-based markers, and these markers have various degrees of sensitivity, specificity, and the area under curve. Parul mentioned about 3 important non-invasive markers, starting from the FIB-4 score, the NAS score, and the APRI. But whatever done, she has given the formulas for all the 3 important scoring systems. The sensitivity and the specificity of all the 3 important markers which he has mentioned, the NAFL fibrosis score is probably the best one. It has almost a linear relationship with the FibroScan. And as Dr. Kandaswamy mentioned, FibroScan has to be interpreted under the background of obesity, whether he has taken food or she has taken food, whether there is an inflammation in the liver, which can change the values. So these are the 3 important caveats which you should take into consideration. But taken these all together, when we look at a patient with the PCOS or NAFLD, we always try to do the non-invasive markers because they are routinely done. They are available to you and you can measure them periodically, maybe 6 months and find the change. But if a FibroScan is available, which should be approximately 3,000 to 4,000 rupees for a patient, and I don't think MRI is far expensive compared to this. I think Dr. Kandaswamy can correct me. We have done studies with MR, with the MR PDFF and MR spectroscopy. And then we found that we can do it at about 5,000 to 6,000 rupees. An addition of 2,000 rupees can give you 2 important parameters. One is the PDFF, the fat value of more than 5%. The second is elastography. And this elastography is the most important marker. Even FDA has recognized MR elastography as one of the indicators for entry into the clinical trials. So MR elastography combined with the PDFF or doing an MR spectra can be probably a gold standard in the evaluation of patient. How frequently we have to do, it all depends upon, but a frequency of anything like 6 months to 1 year will be sufficient to know the progression of the disease.
So Could you just tell us briefly about the recommended treatments for NFLD, and is anything new coming up? Is there anything in the pipeline that we should look forward to?
I think the recommended treatment will be 90% and repeatedly is lifestyle measures. The most difficult thing to do, but if somebody tries to achieve a weight loss of approximately 7 to 10%, which means the energy intake has to come down by at least 15 to 20%. You want to achieve a weight loss of 7%. It is an energy excess problem. It is not an energy deficient problem. The plenty of energy because of urbanization, the food, the fast food, and food with high calories have contributed. So the hallmark, if you look at a pyramid, if you draw a pyramid, the base of the pyramid, a weight loss of 7 to 10% achieved within a period of 1 year, should be able to remove all the fat from the liver. If it is about 20%, it can be brought to 5 to 6%. We have done studies using MR spectra, MR elastography by changing the diet. You adopt a diet which is rich in polyphenols. For example, red rice compared to white rice. They have got a low glycemic index. So the important mantra here is a diet with a low glycemic index, trying to achieve a weight loss of 7 to 10%. The bacterial flora changes into the ruminococci, which are bacteria predominant in a fiber-rich diet. And our own clinical trials, if you Google, you will find this trial with the Nottingham group, which is called as the Fighting Fatty Liver in Kerala. We have been able to demonstrate a 1% reduction in the glycated hemoglobin over 16 weeks period, able to bring down a few millimoles reduction in the blood glucose. We have been able to improve the choline levels in the metabolomics. We have been able to manipulate the bacterial flora into ruminococci. And we believe that ultimately the lifestyle, and I will take 10 out of 10 minutes to say lifestyle is the mantra. You ask me for new drugs. There are plenty of drugs available in the market, starting with the presenter mentioned about liraglutide, semaglutide, and then we have obeticholic acid, which is one drug. Then we have saraglitazone, a product from Zydus, very promising drug, 4 milligrams daily. It can tackle the hyperlipidemia. It can tackle the blood glucose. It can cause a reversal of fibrosis, not to the extent of reversing the whole fibrosis. And we have new drugs which are coming up, and we have to wait whether these are safe, whether they can be used on a long-term basis.
Thank you so much, sir. I'm going on to the third panelist, Dr. Mittal. Could you tell us about anything in the treatment of diabetes which could have a role to play in NFLD? There was a mention of liraglutide. Any other medicines? Do you think that the treatment could have been modified a little more in favor of losing weight or in favor of some benefit in terms of NFLD?
Yeah, good afternoon, everyone. And thank you for that question. And let me take this opportunity to thank the organizers, Dr. Sarita Bajaj and Dr. Ashraf Ghani, for having me here. With regards to the discussion ongoing, anti-diabetic medications, we know that non-alcoholic fatty liver disease, I mean, the name change has also been suggested, metabolic dysfunction associated liver disease. So as Dr. Shenoy also mentioned, he would recommend targeting these metabolic risk factors and obesity. So many of these anti-diabetic medications, which would sort of lead to weight loss, have shown to have definite benefits. And amongst these, the GLP-1 receptor agonists, especially liraglutide and semaglutide, they have shown beneficial effects on liver enzymes, weight loss, and even in liver histology. Also, pioglitazone is another drug which has shown to sort of help in improving liver histology over a period of time. Other drugs, if I may say, metformin, we know data is there that it reduces weight, and also it leads to a reduction in hepatocellular carcinoma. But about liver histology, the data is not so robust. Along with that, DPP-4 inhibitors, we sort of have conflicting data with regards to its effect with the various available drugs. Another class which has recently come, the SGLT2 inhibitors, we know leads to a bit of weight loss. So it has also shown to improve liver enzymes, but yet we are awaiting data with regards to improvement in liver histology. So basically these 4 or 5 classes of drugs are the ones which have basically shown, and amongst them pioglitazone and GLP-1 receptor agonists, has sort of robust data for non-alcoholic fatty liver disease.
On that tune, regarding vildagliptin, do you think if a patient has fatty liver, then should vildagliptin be restricted, or could we just go ahead if the enzymes are normal?
Yeah, so I mean, there is again sort of a different data with regards to CETA, VILDA, and we have data from VILDA where sort of there is an improvement in fatty liver disease. Plus, there is data to show that vildagliptin may not be so good in advanced liver disease. So maybe yes, in initial part of fatty liver disease, there is some data, but yes, with regards to DPP-4 inhibitors, I would like to again emphasize there are no randomized clinical trials as such. So the data is not so robust, but yes, there is data from, you have certain data from with regards to vildagliptin separately in the initial phase of fatty liver disease, but not as an RCT.
Right. I'll go on to Dr. Mangesh. My question being that this lady with the diagnosis of NFL, does that mean that, or any patient with a history of NFLD, does that mean that the patient has to stop alcohol completely, even if the person is a social drinker, maybe just takes it once or twice a month? Would you advise complete stoppage of alcohol, or would social drinking be permitted in those cases? Dr. Mangesh, please.
Dr. Mangesh has just technical issues. Maybe you can ask others, Dr. at the thing.
I think I'll add to Dr. Mithil then. I mean, what would you do in such a case? Would you stop the alcohol completely?
Yeah, and I think Dr. Shinoy and his group also has written about it. The name changes has been proposed for the past, I think, couple of years, from moving from non-alcoholic, which is sort of a negative connotation of excluding of alcohol intake totally as a fatty liver disease cause, and moving towards a metabolic dysfunction associated liver disease. So yes, social drinking, alcohol is permitted even in, and Dr. Shinoy can correct me here, in non-alcoholic fatty liver disease. But yes, beyond a certain amount is not what is recommended. And that is why there is a big group of physicians across the world which are proposing that this name change happens soon. But yes, the consensus is still elusive with regards to moving from non-alcoholic to metabolic associated liver disease.
So as Dr.
That
Mithil,
answers your question.
up to a certain amount, may I ask Dr. Katie Shinoy, what would that certain amount be? Till how much would you allow your patients with a history of NFLD? What amount of alcohol could be allowed? Because these are very commonly asked questions in our practice.
I think population-based studies have really indicated that any dose more than 20 grams of alcohol per day for a male, or maybe more than 10 grams of alcohol for a female, because female livers react in a much bad way compared to the male livers. We do not know why it happens. Maybe it has to do some with the hormonal profile. But an alcohol, excess of 2 drinks per day are likely to be more deleterious. So anything like 1 drink, which will convert to about approximately 18 to 22 grams, which means a 30 ml of brandy or a 30 ml of rum or a 30 ml of vodka is equal to 10 grams of alcohol. So we have to convert a drink into the grams of ethanol. So 30 ml of hard liquor, such as brandy, whiskey, rum, vodka is equal to 10. 250 ml of beer is again equal to 10 grams of alcohol. 100 ml of wine is equal to 10 grams of alcohol. So if you take equivalent volumes, it is 30 is equal to 100 is equal to 250, starting from hard liquor to wine and to beer. I take the beer, which has about 4 to 5% alcohol, and that is what is being the standards. So the terminology which Dr. Mithil has been mentioning, I think there is a lot of dust and heat around this terminology. Though in 2020, people have suggested the change in the name, it is too early to change the name, because when you say metabolically associated fatty liver disease, it all stems to what are the metabolic abnormalities. It is not only the diabetes which has the metabolic disease, but diabetes is a concomitant feature of a non-alcoholic fatty liver disease. So the term is not widely accepted. There are schools which are opposing this change in terminology, but nevertheless, till a new term appears, I think the best will be to take NAFLD.
Thank you so much for that. We also had a mention of PCO, where the patient had menstrual irregularities, there was hirsutism, and then I believe the rise in testosterone level. So Dr. Kandaswamy, could you tell us a little bit about the imaging in PCO? Does it vary across the ages? I mean, this is a perimenopausal woman. Would the imaging modalities or the criteria be the same for diagnosing PCO in this lady as it would have been in maybe a 20-year-old, or are there any changes?
Yeah. So again, the imaging criteria we use for PCOS has evolved a lot. When it started in 1990 till now, there has been multiple modifications as far as the criteria is concerned. So if I go by the recent criteria, which is as late as 2018, which is evidence-based criteria, the modality which is optimal for imaging PCOS is ultrasound, and specifically transvaginal ultrasound. High resolution transvaginal ultrasound is the modality of choice. And if the cutoff for age is 20 years, we can apply the following criteria in any patient more than 20 years, or anybody who had started puberty 8 years ago. So that's the criteria. So roughly it's around 20 years. Any female over 20 years, we can use ultrasound, transvaginal ultrasound as the modality to diagnose PCOS. The criteria is any ovary, either one of the ovary, if it has more than 20 cysts, more than or equal to 20 cysts of the size ranging from 2 to 9 millimeters, is diagnostic for PCOS. The other criteria is if you are not able to use transvaginal ultrasound, which is also a problem often we encounter, you can use trans-abdominal ultrasound, but you cannot use the number of cysts as a criteria. Then you have to use the volume of the ovary as a criteria. If the volume of the ovary is more than 10 cc, either of the ovary, again that is consistent with the diagnosis of PCOS. So over the years, the volume of the ovary has the criteria of 10 cc has remained the same, whereas the number of cysts had gone up from 12 cysts as it was in Rotterdam criteria to 26, and now it has been corrected to 20. So even in a perimenopausal woman or there is no difference which is given in the criteria as far as the recent guidelines are concerned. So it is just that anybody more than 20 years, you can use this criteria.
Thank you so much. We had a lot of other questions, but in the interest of time, I think we'll just take up some of the questions that have been asked. Yeah, Mohan, I cannot see all of them. But one important thing, I think we have answered this, but very briefly, can the APRI score be used in peripheral centers as screening? What is the specificity? Any one of the panelists can please take over.
I think the Society for Liver Disease, the International Society for Liver Disease, is coming out with the guidelines. There was a guideline committee, and I think Shalimar also knows about it, which looked into the non-invasive markers to be adopted at 3 different levels. One is at the level of periphery, which can be done in a primary health center or a doctor at the primary health center. The second is at the secondary levels or the taluka. And the third is tertiary, which is the general hospital or academic centers. So we have come out with the different guidelines depending upon the healthcare facility. But APRI can be done by anyone. There are only a few parameters which are not very difficult to do in a good periphery. Only thing is, it has to be a standardized laboratory with a cutoffs and a good quality parameters. All the three things which Dr. Parul mentioned, the APRI, the FIP4 or the NASCO, can be done in any given setting because they can be repeated and you can try to find out the change, whether it is purely negative, indeterminate, or it becomes positive. And then once in a while, probably in a year, you can do a fibro scan so that they spend about 4,000 rupees every year to know not the fatty liver, but for the fibrosis scoring.
Right, so thank you so much. We are actually running late. That is why we have to wrap it up. So thank you, Dr. Parul, for that very nice presentation. Thank you to all the panelists for such excellent inputs. So all in all, NFLD, not very, we are seeing it very often in our practice. We need to keep our index of suspicion low. There are good imaging modalities. There are good, other markers also which could help us diagnose NFLD. Again, PCO is not very uncommon. The imaging modalities might slightly differ across the groups. The diagnostic criteria might differ. But at the end of the day, to all the one of the major answers to all these questions is lifestyle changes. So we really, really need to emphasize on the lifestyle changes for all our patients presenting with such complaints. On that note, I'll hand it back to the organizers. Dr. Mohan, please.
Yes, thank you. Thank you. I think we have first batsman is metabolic syndrome. So we have the total coin of mood, which is that metabolic syndrome, obesity, and ovulated dysfunction. So the opening is set here. So I thank all of you for joining in every faculty, starting with chairpersons, Dr. Shalimar, Dr. Nitin sir, then Dr. Nitish, Dr. S.K. Singh sir, and the panel discussion, the speakers, Dr. KVS Harikumar sir, Dr. Nitin Kapoor, and the panelists. The panel discussion was icing on the cake. So we had a lot of points discussed from all of the perspectives. So panel discussion was justice, I believe. Dr. Arundhati did a great job. Thank you, everyone. The panelists were also superb. So with this, I hand it over to the next session. I thank you, organizer, for giving me this opportunity. Anything to say, Dr. Shalimar? Anything to add?
I think it was an excellent first session, and I'm very think that Professor Shenoy, Kitty Shenoy, would be really proud of you. So I think everyone should know that regarding you're Professor Shenoy's son. So I think that's one thing just wanted to add. And you've done a great job. Good.
Thank you, sir. Thank you, sir. So I leave it to the next session that is handled by Dr. Afia and Dr. Nitin Kapoor. So the session will be on obesity. Over to you. Thank you, sir.
Thank you so much, Dr. Mohan. And
Alimar.
Yeah. Right. So thank you so much, Dr. Mohan, and taking it forward, as Dr. Mohan said. So we're done with the metabolic syndrome part of it, and we move on to obesity, which I would say is the mother of all the diseases that are there as part of this consortium. And to invite our chairpersons for this session, I request Dr. Afia Rashid to please take over.
Background.
Dr. Afia, if you could unmute yourself. Yeah.
Good evening. I warmly welcome you all to the second session of this meeting. Before I take the pleasure of introducing all the eminent chairpersons from the country, I would like to express my gratitude to the organizing committee for giving me an opportunity to be part of this mega scientific event. As we all know that non-communicable diseases are the biggest public health challenges of this century, and obesity is one of the major health problems. Globally, the prevalence of obesity is on rise and has nearly tripled since last 4 decades. In India also, the prevalence of obesity has increased rapidly in recent decades, and it has led to an notable increase in the burden of non-communicable diseases over the decades in our country. Before taking the discussion further, I am delighted to introduce the noted chairpersons for the session. Can we please have the introductory slides? We are having with us Dr. Sandeep Agarwal, Professor of Surgery, AIIMS, New Delhi, with special research interests on pediatric and metabolic surgery. He is the editor, Journal of Minimal Access Surgery, member, editorial board, Obesity Surgery. He is also associate editor of Journal of Pediatric Surgery. He has received Best Researcher Award of IAGS 2021. The another person with us is Dr. Nishant Raizada, Associate Professor, Department of Endocrinology, UCMS and GTB Hospital, New Delhi. With research interests focusing on diabetes mellitus and obesity, he has received multiple awards and honors like Sudhir Rahan Memorial Award 2011 and Dr. MMS Ahuja Award in Endocrinology 2016. We also have with us Dr. Vandana Jain, Professor of Pediatric Endocrinology, Department of Pediatrics, AIIMS, New Delhi.
Can we move their slides, please? CV slides. Yeah. Welcome, Dr. Vandana, Dr. Sandeep, Dr. Nishant.
Welcome.
Welcome.
Dr. Vandana.
Good afternoon. Good afternoon, Dr. Ghani.
Good afternoon. Good afternoon.
Dr. Vandana has research interests focusing on relation of growth and body composition in infancy with later cardiometabolic outcomes, metabolic syndrome, and NFLD, innovations in diabetes care, and differences of sex development. She has completed almost 13 funded research projects as PI. She is editor of textbook case-based reviews in pediatric endocrinology, and she has more than 120 peer-reviewed publications to her credit. With this, I request the chairpersons of the session to introduce the speakers. Besides, I would also request the co-coordinator of the session, Dr. Nitin Kapoor, to carry forward the session. Thank you very much.
Yeah. Good evening, everyone. At the outset, I'd like to thank Dr. Ghani for this opportunity and congratulate the organizers for this wonderful meeting. Our first speaker is Dr. Neeta Deshpande. She is a professor and head of Department of Medicine at Dental College, Belgaum, and associate professor in medicine at USM KLE International Medical Program. She's a renowned diabetologist and bariatric physician at Belgaum Diabetes Center, Children Diabetes Center, and Weight Watch Obesity Center. She was awarded the prestigious Sam GP Moses Oration at the National RSSDI last week for her work on obesity spanning over more than 2 decades. Welcome, Dr. Neeta. And she is going to talk about a quick take on current pharmacological options for weight loss. Dr. Neeta, please.
Thank you, Dr. Agarwal, for that kind introduction. At the outset, I would like to thank the organizers for giving me this opportunity to speak at this very prestigious conference on a topic that I'm very passionate about. And I have been asked to talk about a quick take on pharmacological measures in obesity. I shall start by sharing my screen. Yes. So I'm not going to be talking only about the current options. I'm not going to talk about what has happened in the past because pharmacological agents for obesity have had a very checkered history. And I'm not going to focus too much on the future as well, just on the current things. The disclosures for this talk is that I have been a principal investigator for the SCALE trial. So is it just about weight loss? Are we talking here only weight loss in obesity? Because losing weight, being healthy is not just about calories. It's not just the weighing scale. It is actually ye dil mange more. So along with weight loss, what we also have is we want something with the fatty liver. We want that to go down. We want the waist circumference to go down. We want the blood pressure to be normalized. We want obstructive sleep apnea to come down. So we want so many other things. I've not listed all of them. So is it just about weight loss? So pharmacological therapy would also depend upon what our aims are, and the choosing of the drug would depend upon whether all these parameters, or at least some of them, are going to be affected favorably with the drugs that we are going to be using. So if you look at an overview of obesity treatment, we know we have diet and lifestyle, we know we have pharmacotherapy, and we know we have bariatric surgery. If you had to be realistic about the percentage of weight loss, for diet and lifestyle, it could be 0 to 8%. Now, I am talking about the median weight loss. There are outliers. We have weight loss even up to 15-20%. I know with diet and lifestyle, and actually that is my passion. But to be realistic here, if you look at the vast majority, it is quite small. And then, of course, with bariatric surgery, you can have anything between 13 to 35% weight loss. And what you have in between is pharmacotherapy. Now, why do you need pharmacotherapy? Why not just kick up or ramp up your diet and lifestyle, and those who can't go to bariatric surgery? But that cannot happen. And the reasons for that are that there's a gap between lifestyle interventions and surgery. And the gap is that behavioral modifications do have a limitation. Old habits die hard. And gastric bypass, gastric band, sleeve gastrectomy, in general, metabolic surgery has its limitations because we don't have enough people doing it, and there are not enough people opting for it, the ones who need to. And that is why there is this huge gap. Lifestyle and diet is not enough. Surgery is unattainable, unavailable, or not being able to be done. So what you have in between to fill this treatment gap is pharmacotherapy. And why do we need pharmacotherapy? We all know that diet and lifestyle work, but then it is not easy because weight maintenance with diet and lifestyle does not happen. Because once a person has, the person in the middle is the one who has undergone diet and lifestyle and has lost weight. But then, unfortunately, there are compensatory biological changes because of which all the hormones go in the wrong directions. You have an increase in ghrelin and a decrease in satiety and energy expenditure. And unfortunately, the brain response to food cues in homeostatic and reward regions increase. And that is the reason that weight maintenance does not happen and there is often a relapse. So to fill that gap, in efficacy, and also the challenging aspect of chronic weight loss maintenance, we have pharmacotherapy. So with that little introduction about why we need pharmacotherapy, I'm going to go into details of some of the drugs. This is the FDA approved list of anti-obesity medication, people without diabetes, just obesity. So you have two GLP-1 receptor agonists, one at the top here, liraglutide, and one below, semaglutide. And then in between, you have three other drugs. Now, orlistat, the one in the center, is the one that is perhaps one of the oldest, but it has got the least efficacy. So I'm not really going to dwell too much upon that. Naltrexone bupropion combination and phentermine topiramate combination do give good weight loss, not available in India yet. So I want to talk just a little about that. Liraglutide is available, though it is off-label for the use of simple obesity without diabetes in India. And semaglutide is not available as of now in India, but should soon be, especially the oral version of it. So as you can see here, the weight loss that is there, apart from orlistat, most of the others are somewhere between 5 to 6%. But I draw your attention to semaglutide, which has reached about 16%. So I want to dwell upon that a little more. And if you want a visual look at this, you can see here, as I mentioned, that orlistat stands at about just 3% at the end of 1 year, and lorcaserin not available anymore. And you can see that liraglutide is around 4.5%, but phentermine and topiramate going all the way up to 6.5, and naltrexone bupropion also going all the way to around 5%, though we don't have them yet. So we have decent weight loss with all of these drugs, but let's look at what is the one that is most promising. So drug-induced weight loss mechanisms fall into many categories. And these are the 4 drugs that I'm showing to you over here, because these are the ones that act at all these different levels in the, to reduce food intake. They talk about food intake, they talk about energy expenditure, and then of course, the different hormonal manipulations that occur to help lose weight. So each of these drugs act at very, very different points, and that is how their mechanism of action is, and that is how we get weight loss. So let's go to this first combination that I talked about, that is phentermine and topiramate. And what you find is here that this combination reduces food intake itself. It acts at the level of the brain, and it reduces food intake by inhibiting norepinephrine reuptake in the hypothalamus, and by stimulating GABA secretion also it reduces food intake, and that is how we have phentermine and topiramate. So I'm just showing this meta-analysis to you that has been written by a good friend of all of us, Professor A.K. Singh. And you can see here that the reduction in weight in these two trials, Conquer and Equip, is considerable. And you can see here that it has a very good data to show, this particular combination has a very good data to show us that weight loss is achievable with this particular drug. Then this is the other one, that is naltrexone and bupropion, and this is from the Core Eye trial. And you can see that as compared to placebo, both of these two different drug doses have a much better weight reduction, that is change from baseline in terms of percentage, and that is close to 5 and reaching even 6%. And that's what we have with liraglutide and some other drugs as well. So this drug is also giving us a good weight loss. And these are the drugs that I'm talking about now are the ones that are being allowed, at least by the US FDA, for long-term use. Now let's come to the newest kids on the block, and that is GLP-1 receptor agonists. And we know that they have multi-faceted effects with respect to weight loss and the rest of the metabolism as well. Importantly, it acts at the level of the brain to reduce body weight by reducing food intake and increasing satiety. It also acts at the level of the stomach and reduces gastric emptying. At the level of the pancreas, it increases beta cell function, insulin biosynthesis, because you all know that they first came out as anti-diabetic agents, and then we came to know that they have all these other effects on the brain, on the stomach, and also causes weight loss. And importantly, as I showed you in my very first slide about Dil Mange More, and that is that they have been known to reduce cardiovascular risk, improve cardiac function, reduce blood pressure, reduce inflammation. I'm going to show you some data about that as well. So it's not just taking care of weight, but also taking care of all the consequences, comorbidities, and metabolic risk factors that accompany obesity. That is going to be very, very important. And the other thing that they do is acting at the level of the liver as well, because now that we know, you've had a session on that, we know that the liver is an important a link in the chain of events that cause dysmetabolism. So you have reduced de novo lipogenesis, reduced lipotoxicity, etc. We have some glimpse of the amount of weight loss that can happen with the different GLP-1 receptor agonists if you look at the different CVOT trials, and you can find here that all the molecules that I have listed here, and this is in the CVOT trials, and you can see that there is weight loss with all of them. With semaglutide subcutaneous, it is more. Of course, in the SUSTAIN trial, the dose that was used was just about 1 milligram. It was much less than it is used for obesity. And in the oral semaglutide, it is minus 3.4. So you can see here, this is the leader trial, which has given us all wonderful data, especially with respect to atherosclerotic vascular disease. And this is the weight loss that can be achievable. Let us go a little more into the details of liraglutide, and you can see that as you increase the dose of liraglutide, you get much better response with respect to weight loss. And we know today that 3 milligrams that is available in the US and licensed to be used for obesity without diabetes, the dose is 3 milligrams. It's available there. We don't have it here yet. And as I mentioned earlier, if you use it for simple obesity, it would be off-label. So this is how we know that weight loss with liraglutide is very good. The scale set of trials looked at liraglutide and the various facets of it. And this was a study that was given where liraglutide was given with lifestyle modification. And you can see here that they had individuals without type 2 diabetes and a BMI of more than 30 or more than 27 with dyslipidemia or hypertension. And you can see that whether it's more than 5% weight loss or more than 10% weight loss, it fared far, far better, significantly better than placebo. And there was a greater reduction in A1C fasting, glucose fasting, insulin in the liraglutide group. And if you had to look at the summary of all the scale trials that used 3 milligrams, which is the one that is being said to be used for obesity, you can see here that most of them have used it for 1 year, the first 3 trials at least, and you can see that there is between a 6 to 8% weight loss at the end of 1 year for scale maintenance, scale diabetes, and scale obesity. And of course, in the scale obesity and pre-diabetes, there was a reduction of 80% risk in the development of type 2 diabetes over the next 3 years. Now, this is huge. If it can prevent diabetes, that is something that we really desire. A1C in diabetes patients in the scale diabetes reduced by 1.3, which is quite considerable. And in scale maintenance, 81% maintained more than 5% weight loss after 1 year. We still haven't found the holy grail for weight loss maintenance. We try our best. We have so many things in our armamentarium, but we haven't quite reached there yet. But yet you can think of this kind of a pharmacotherapy for weight loss maintenance. Now, this is the additional benefit that you are getting, and this is a meta-analysis, and there was reduced all-cause mortality with liraglutide with GLP-1 receptor agonist compared to placebo. Again, I come to the plethora of non-weight related outcomes that we are looking for, and this is one of them. Now look at NASH and excess weight. So it favorably affects this as well. This is something that we want. So it's not just the weight, it's the entire metabolism that we are talking about. Then came semaglutide. Now, semaglutide has 94% similarity with human GLP-1. And that is why probably we are getting far more weight loss with semaglutide than even with liraglutide. It has multiple mechanisms of action and multiple targets and outcomes as well. So that is why we are looking for semaglutide, of course, for diabetes, but also for cardiovascular disease, obesity, non-alcoholic fatty disease, chronic kidney disease, etc. And it has several attributes to it, that its stability, its bioavailability, etc. And all of these make it a multidimensional molecule that we are looking at today. So this was a dose finding study with daily semaglutide, and you can see here that compared to liraglutide, it showed much more weight loss at all these levels. It was a dose finding study, and they've gone all the way from 0.05 to 0.4, and yet found that it is much better than liraglutide in terms of weight loss, as you can see here. And these were treatment differences that were seen versus liraglutide 3 milligrams. And semaglutide was used in this particular dose. Then if you look at the CV outcomes, again, a desirable outcome in obese patients. If you look at the primary CV outcomes, both liraglutide and semaglutide showed that there was a reduction in CV mortality, non-fatal MI, and non-fatal stroke. Now, if you look at semaglutide 3 milligrams, that is the one that semaglutide 2.4 milligrams subcutaneously once a week. That is the one that is propagated for weight loss, only weight loss. And they had a series of programs called the STEP program. So you had step 1 that looked only at weight management. You had the step 2, which looked at weight management in type 2 diabetes. Step 3 was weight management with intensive behavioral therapy. And step 4, interestingly, was sustained weight management. And in all of them, they look for the efficacy of 2.4 milligrams versus placebo or versus 1 milligram of the same drug. That is what they were trying to find out, how the weight loss would be. And if you look at the results over here, you can see that the percentage reduction in body weight from baseline in all of them was considerable. And I don't think we've got this kind of a weight loss with any drug so far, which is 15%, 16%, 17%. with the baseline weight being in the range of 95 to 100. And as I said, in all the different step programs, 1, 2, 3, and 4, you had very good weight loss as compared to the placebo. So this is what we are looking at. I'm going to show you some more. Now, this is the important slide for me because this is where we are talking about lifestyle modification being there. So it's actually a comparison between lifestyle modification and lifestyle modification plus semaglutide, and the difference is phenomenal. So what you see here is a double-blind randomized trial with patients of obesity, BMI more than 30, with comorbidities and no diabetes, and both the groups received intensive behavioral therapy. So that was there in both. If you remember the other trials that have been done, when they use standard behavioral therapy in both, but this was one study where they used intensive behavioral therapy in both the groups, and one of them got semaglutide and one got placebo. And look at the weight change. And this is the weight loss at week 68, as you can see. And if you had to categorize it from 5 to 20% weight loss, you can see that in every category, semaglutide scores over the placebo. Now, this is important to us because we all talk about lifestyle modification. I talk about lifestyle modification and weight loss. And if your target weight loss is huge, then simply doing diet and lifestyle may not always be enough, is what I'm saying, because here you have proof that two groups, both having intensive behavioral therapy, and one of them getting semaglutide and the other not getting semaglutide, and you can see the results over here. Now, this is another interesting study where they looked about sustained weight management. It's very interesting because they're talking about weight maintenance. And that is our biggest problem, you know that. So for the first 20 weeks, everyone got semaglutide. But you can see here that at the end of 20 weeks, one was taken off and they were given placebo. And then, so this was the maintenance period actually. And the other was continued with semaglutide, and you can see the big difference. So if you want weight maintenance, whether you've given semaglutide in the beginning, or perhaps there could be some other patients where you have done only lifestyle modification, but they're struggling with weight maintenance, this could be the answer. And that's why I said that this is the bridging gap between lifestyle modification and weight maintenance, and lifestyle modification and bariatric surgery. Again, as I said, we are now looking at the pleiotropic effects of these drugs, and here is the waist circumference. And we Indians, the thin fat Indian, typically wants a reduction in waist circumference, and you can see that compared to placebo, there was a considerable significant reduction in waist circumference at the end of 68 weeks. The other secondary endpoints were systolic blood pressure, diastolic blood pressure, and an inflammatory marker, and that is HSCRP. And you can see here that there is the p-value is very, very significant everywhere. And you can see that there is a significant reduction in all these inflammatory markers in HSCRP, in the blood pressure, and as I said, in the waist circumference, and some more to come, and that is triglycerides, fasting plasma glucose, the insulin resistance, everything that is wrong with the metabolism in obese individual seems to be getting itself corrected with the help of this particular drug. And that is why it seems like an exciting drug. And if you look at this post hoc analysis in these studies, at baseline, if you had 46.7% people without the metabolic syndrome, after week 68, that number shot up to 75.4%. That means that metabolic syndrome could be ameliorated to a large extent with the help of this as compared to placebo, as you can see in this particular slide. So overall, it is shown to reduce energy intake, controls appetite, and we have a huge database of 5,000 and odd patients with overweight or obesity, which showed a mean weight loss of 17 to 18%. As I said, we've never seen this kind of percentage weight loss in the recent past with any drug. So Semaglutide 2.4 milligram is effective in inducing weight loss, maintaining body weight, as I showed you, and improving cardiovascular risk factors. The newest thing that has come in now, luckily for us, is oral semaglutide, the pioneer program, where there is an A1C reduction, there is weight loss, and there is reduction in waist circumference as well. The last part of my talk is individualizing pharmacotherapy. You have all these drugs. Whom do you give to, and what do you give and to whom? So you have liraglutide and semaglutide. Ideal candidates would be patients with coronary artery disease, pre-diabetes, and diabetes. I do not need to tell this august audience what the adverse effects are of GLP-1 receptor agonists. We have some contraindications with respect to cancer, that to thyroid cancer and kidney disease or history of pancreatitis. About naltrexone and bupropion, not yet available here. Ideal candidates would be those with depression, those interested in smoking cessation, and those who have food addiction and strong cravings. So if someone who's very, very hungry all the time, maybe this is the drug to go to. Orlistat, as I mentioned earlier, I really wouldn't recommend this because the data shows us that it's very little. The quantum of weight loss is very, very little. Phentermine topiramate, ideal candidates would be patients with chronic migraine, and there are certain contraindications to this as well. So this is how you individualize therapy. You take a good history, find out what the patient needs, what the patient has, what the symptoms are, and then tailor the therapy. Now, these are some other drugs that are used, some of them off-label, and there are certain candidates for this. For example, for binge eating disorders, this particular drug, lisdexamfetamine, has been licensed for use in the US. So people with chronic migraines, metformin we use with diabetes and pre-diabetes, you'll get a little bit of weight loss. SGLT2 inhibitors if there's diabetes already. These are rare genetic causes where you use leptin treatment. I'm not going to go into the details because there are just 3 slides of rare syndromes where setmelanotide is used in these trials in children with POMC or LEPR deficiency. This is very, very new, tirzepatide, dual GLP, GIP, and dose-dependent decrease in body weight has been seen in this drug, with this drug, if you had to compare it to dulaglutide. So to summarize, obesity is a chronic disease requiring lifelong treatment, and it is associated with many cardiometabolic, osteoarticular, and oncological morbidities. There are a number of treatments that can be successful. Though diet and exercise remain the cornerstone, it may not be enough. You may need to supplement it with pharmacotherapy and in some cases bariatric surgery. So you have to respect the patient, involve them in the planning, take a good history, see which one suits the patient best depending upon his comorbidities and his symptoms. And at the end of the day, it is a balancing act. You have to balance what the patient wants, what his pocket can afford, what you know, what you can give to the patient. And with this balancing act, you should be able to give a good treatment so that they have a weight maintenance. So thank you all for a patient hearing.
Thank you, Dr. Neeta, for a wonderful lecture covering all the aspects very comprehensively, and probably one of the best I've ever heard on this topic. So congratulations on your talk.
Thank you so much.
Now, and my question is, you talked about the efficacy part of the GLP-1 analogs, which we know, are effective compared to the previous pharmacological agents. What about the cost efficacy? Now, you're looking at 62 weeks of semaglutide.
Yes.
What would be the cost vis-a-vis a similar patient going for bariatric surgery? I'm a bariatric surgeon, so I have a little bias towards bariatric surgery.
It's right,
And you,
right.
obviously, everybody admits the quantum of benefits bariatric surgery induces, and it raises also the GLP-1 level. So how do you compare the cost, efficacy?
Well, see, it is a cost benefit adverse reactions ratio. I would say it's not just cost benefit. I would also look at adverse events. So if you had to look at all of that, yes, as of today, pharmacotherapy is quite expensive. And as you rightly said, the cost needs to be seen because the treatment is indefinite. There is no such thing that you take 6 months of liraglutide and then stop. People are doing it, but then the weight comes back. So yes, I agree that weight loss, relapses are common if you stop the drug. As opposed to that, if you had to do a bariatric surgery, I know bariatric surgeons make a lot of money, but maybe between 3 to 4 or 5 lakhs or whatever it is that it costs for a sleeve gastrectomy or a gastric bypass. But it is not without its side effects. Having said that, if there is morbid obesity, I would definitely prefer to send a patient in for bariatric surgery. That's for sure. And there are, every patient is different, and I think customization becomes very important. Now, with lifestyle modification, I have achieved weight loss in some patients for 30 kgs, but these are outliers. These are not all my patients. These are outliers. So 30 kgs. Now, again, it remains to be seen about the relapse of weight loss. I agree that the relapse of weight loss is slower with bariatric surgery, but it can occur if the right kind of counseling is not done. So every patient, and there may be patients who are averse to surgery. So you have all kinds of patients. So you will have to see what the patient wants. That's why I said it's a balancing act.
Yeah.
What the patient wants, what he can afford, and what is best practice. Again, that is a different thing.
I agree with you. I think these GLP-1 receptor analogs have added a good another addition, another option for the patients. The class 1 obesity and morbidly obese patient definitely should be advised bariatric surgery. And thanks for the answer. I think there's a question from one of the delegates from Trivandrum. Dr. Neeta, in your practice, do you use 3 milligram liraglutide? And how much weight loss are we able to achieve in clinical practice, and how well the patient tolerate this dose?
Right. So when I did the scale trial, I had to use 3 milligrams because that was the requirement of the scale trial. A lot of patients, and also, though it was a double-blind randomized trial, we did know who were the ones who were getting it because of the gastric side effects. So we knew who was getting it. So some of them have achieved good weight loss of 10%, 15% even. But in practice now, I do use liraglutide, but I have never had to go up to the level of 3 milligrams. If weight loss has to happen, which you come to know within the first 8 weeks, and if there's not good weight loss at that point of time, you're supposed to stop it in any case. So if I get good weight loss, it is usually at 1.8. The dose that we give for diabetes. I've never had to go, there are very few patients where I've had to go above 1.8. There are very few, but we do get good weight loss even at 1.8.
Thank you. Any other question from other panelists or other delegates for Dr. Neeta before we go on to the next talk?
Yeah, I can just give one more little practiced tip over here, and that is that I have had patients, because we have only liraglutide now, we don't have semaglutide yet. Many patients who have lost weight on diet, lifestyle, and then we have started them on liraglutide as well. When they find it very costly, when I've brought them down to half the dose, so the cost comes down. Weight maintenance is becoming easier.
So 0.6 or 1.2?
Some even with 0.6. Some even with 0.6. But then the diet and lifestyle modification is maintained in a very strict manner. But they, instead of going all the way to 1.2 for maintenance, a lower dose for maintenance seems to be working, though I do not have any data as such to prove that.
That's promising. I think that's a very good tip, I think, and can be probably used as a point for a long-term, research, future research. Thank you so much, Dr. Neeta. It was a brilliant lecture, and really congratulations.
Thank you so much.
Thank you so much, Dr. Neeta, for the lecture, and thank you, Dr. Sandeep Agarwal, for chairing the session. I think in interest of time, we will move on to the next talk. I invite Dr. Vandana Jain to please introduce the next speaker. Slides, please.
Good afternoon, everyone. So I take this opportunity to thank the organizers, Dr. Ashraf Ghani, Dr. Sarita, Dr. Saptarishi Bhattacharya, and all the team for inviting me to this wonderful academic meeting. So it's a pleasure to introduce Mrs. Shilpa Joshi. She's a dietitian with more than 20 years experience, and she's currently the National Vice President of Indian Dietetic Association. and Honorary Secretary of All India Association for Advancing Research in Obesity, and she is based in Mumbai. So Mrs. Joshi will be talking about critical analysis of different. So I hand it over to her.
Thank you very much for the kind words of introduction. Am I audible?
Yes, ma'am.
Yes, you're audible.
Yeah. Thank you so much, Dr. Jain, for kind words of introduction. At the outset, I would like to thank all the organizers for inviting me for this meeting to speak on critical analysis of different dietary strategies. So before I begin the talk, I would like to tell you that every year new diets trend. It is as good as a Netflix show trending, it's exactly like that. And you'll find that every year different diets come, create noise, but not all of them stay. There are few diets which I'm going to be discussing, which have stood the test of time and been there. But before I begin, this is the prediction for diets trending next year. 2022, the diet which will be trending is called the sugar sucks diet, that is modified keto diet. Now, what is the difference here is there is an increase in protein. In the same keto diet where the fat goes up to 75%, your fat percentage is slightly lower, and they have increased the amount of protein in this diet. Then there is immunity rocks diet because there are superfoods in it because of the COVID pandemic which happened. Then the diets which are again going to be very popular in 2022 is eat plants, that is a plant-based diet. Paleo diet again has been here for a long time. Don't eat diet is time-restricted feeding essentially. And the new diet which is on the block is called the mind diet. That is, it is a mix of Mediterranean diet and DASH diet. So it's a combination diet wherein it's essentially plant-based but salt restricted in nature. So again, when we speak about diet, there are two kinds. There are, the diets which come and go in fashion are called as fad diets. Now, what does diet mean? So diet comes from a Middle English word diete or a Latin word dieta, which means way of living. Actually, therefore, it has to be a holistic approach, and it is not just the diet which will cause, help you to get healthy weight, but it is the whole lifestyle. So it is not just the diet, but exercise, etc., which is very, very important. Fad diet is any weight loss plan that promises quick results and usually has some temporary nutritional changes, and therefore these diets are not sustainable. And this is the history of popular diets across so many years. So starting from 1820 to 2011, there were so many diets which are actually noted, and now I just showed you which are the diets which are trending now and are expected to trend next year. Now, low carb diet has actually stood the test of time. There is a lot of data on low carb diet, and the first successful client on low carbohydrate diet was Banting. Banting reported that at age of 66, on following a low carb diet, he was never hungry. And in a year, he had lost 47 pounds of his initial 202. So this is the first and most famous follower of low carbohydrate diet. And what is a low carbohydrate diet? It is defined as a diet with carbohydrate percentage below 26% of energy intake, and moderate carbohydrate restricted diet are between 26 and 45% of the total energy. So there are again many types of low carb diets, the most popular one being the Atkins low carbohydrate diet, wherein there is a period of severe ketosis, or there is two-week period of sharp decrease in carbohydrate intake to less than 20 grams per day, and then gradually it is liberalized over a period of time. So these are various carbohydrate restricted diet. That's Carbohydrate Addict, Protein Power, Sugar Busters, and South Beach diet. Each diet is having different levels of carbohydrate restriction, which go on for a different period of time. So in Atkins diet, the restriction is maximum, And then as you come towards South Beach diet, there is only a 2-week period of carbohydrate detoxification, after which good quality carbohydrates, which are lower in glycemic index, are actually reintroduced, to achieve the weight loss. Again, these are various kinds of carbohydrate restrictions. So if you look here, the carbohydrates go from 5% to 40, 55% in various kinds of carbohydrate restricted diet. Now, when you compare these diets to what Indians eat, you will realize that Indians are eating about 70% carbs and rest coming from fat, and very little protein. So these diets become a huge challenge to be followed in Indian setting. So in Indian setting, even a non-vegetarian patient tends to eat much more carbohydrate than the protein or the fat that comes in the diet. So what is ketogenic diet? Ketogenic diets are characterized by reduction in carbohydrate, usually to 50 grams per day or less, with a relative increase in proportion of protein and fat, but more specifically in proportion increase in fat rather than in protein. These are types of ketogenic diets which are available. There's a standard ketogenic diet where there is 70% fat and only 10% carbohydrate or even lower. Then there is cyclic ketogenic diet. There is targeted ketogenic diet, which happens only adding carbohydrates on the day workouts happen. And there is a high protein ketogenic diet where there is increased amount of protein and a slight reduction in the fat percentage of the diet. Now, whatever data that we have today about ketogenic diet, they are on standard ketogenic diet, or there is some data available on high protein ketogenic diet. Cyclic and targeted ketogenic diets are recent modifications of the ketogenic diet itself, and there isn't much data available on these kinds of diet. Now, for this August audience, I do not have to tell you what is ketosis. But we know that in ketogenic diet, when carbohydrate percentages drop so drastically, body is forced to use fat as a source of energy, where ketosis begins. Therefore, ketosis is 100% guarantee of fat mobilization. So we know that there are studies on ketogenic diet and their impact on diabetes, where it has been shown that triglyceride percentage actually drops drastically, and also sugars come back, or sugars drop drastically, but they have to be sort of matched with the kind of pharmacotherapy that the person is taking. There is a huge people are worried that consuming ketogenic diet might actually work on the cholesterol or the LDL or total cholesterol of individuals, and it has been shown that the reduction of dietary carbohydrate actually reduces HMG-CoA reductase activity, and hence compared to the proportion of fat which is consumed, which is up to 70 to 75%, there isn't as much increase in the LDL or total cholesterol. Okay, so the effect of keto diet on cardiovascular system has been that physiological ketosis actually leads to significant benefits on blood lipids. Ketogenic diet has shown to have marked impact on blood triglycerides, but there has been some data to show that it has positive effects on total cholesterol reduction and increase in high density lipoprotein. So there is data to show to this effect. Now, the other diets which are not popular now, but they were very, very popular about 20 years ago, were very, very low fat diets. So these are different kinds of very low fat diets. Pritkin diet, Dean Ornish diet, diet which is low fat but enriched with PUFA, and one which is enriched with omega-3 fats. And again, here the speciality of this diet is total fat percentage is below 15%. So here, the low-fat diets contain fat between 11 and 19%. Proponents of this diet claim that reducing caloric intake and increasing energy expenditure is the way to achieve weight loss. And here the focus is on type of calories and calorie density. Now, what are the metabolic effects of low-fat diets? These diets lower total cholesterol, more specifically LDL cholesterol, and they also lower the risk of heart disease. But triglycerides are reported to increase in response to very low fat diet. And the reason for it is when fat percentage in the diet is dropped, consequently carbohydrate percentage which a person consumes, the amount of carbohydrates that the person consumes can increase, and this leads to increase in triglyceride. Blood pressure decreases in most subjects consuming low fat diet. Low fat diets can sometimes lead to essential fatty acid deficiency, especially if they are sort of followed on their own, if care is not taken to supplement essential fats or foods which are rich in essential fats. Now, what are the Indian problems with low fat diets? Low fat diets are very similar to Sattvic diets, which are essential part of Indian culture. But in today's day and age, when eating out is a trend, eating out options are really very low with low fat diets. And what happens is dieters choose to eat commercially prepared low fat food rather than choosing good foods like fresh fruit, vegetables, or even nuts as recommended in the diet. So typically what we see is when people go on a low fat diet, they buy packaged food, and which is something which is really not advocated in the diet. Now, these were fat diets, but look at these diets. These are actually other kinds of diets like Mediterranean diet. It varies across Mediterranean country depending upon which country you're talking about. So there's Greece, Italy, so on and so forth, many countries there. But the central characteristic being high consumption of monounsaturated fat, which is based on olive oil, nuts, fruit, vegetable, legume, and low consumption of meat and dairy products. Now, Mediterranean diet, like I said, these are the salient features of the diet, and you will see that the biggest salient feature is red meat consumption is consumed in low frequency and in low amount, and olive oil is used as a principal source of dietary lipids. Now, also very, very popular part of Mediterranean diet is there is wine consumption in low to moderate amounts, generally with meals. But we do not know what happens with wine consumption in other people other than which live across the Mediterranean Sea. So what are the advantages of Mediterranean diet? There are 13 meta-analysis of observational studies and 16 meta-analysis of RCTs for a total population, which is like in couple of lakhs. Most of summary estimates support the notion that greater adherence to Mediterranean diet determines in reduction of chronic diseases and overall mortality. When they were compared to other diets or control diets, they had better anthropometrical and metabolic and a decrease in inflammatory risk parameters. So these were Mediterranean diet and their impact. So they on various metabolic parameters like LDL cholesterol, HDL cholesterol, triglycerides, glucose, blood pressure, so on and so forth. And they are all favoring Mediterranean diet. The other kind of diet which has become very, very popular is intermittent fasting. So this is not a kind of diet. This is the way food is eaten. So intermittent fasting is approach is a diet. It's an approach of dietary pattern that is centered around periodic fasting and time restricted feeding, which is very, very popular now. And typically people follow 16:8, where there is a 16-hour period of fasting and an 8-hour interval of eating. And again, there has been studies to show that these kinds of diets are important to increase longevity, but their effects on blood lipids, blood sugars are very, very minimal. Now, this is an old paper, but it's a very interesting paper where the authors actually have studied various kinds of diets for different duration of time. So this is a paper by Yancey et al., where he has compared diets which is low carbohydrate as compared to low fat over 6 months period to see what happens to the weight and what happens to the lipid. And what has been shown is significant weight loss was achieved in the low carbohydrate group as compared to low fat group, and the difference between the weight loss between the low carbohydrate and low fat group was significant. So in a shorter period, like 6 months, what has been seen is faster weight loss happens with carbohydrate restriction. Also with low carbohydrate group had a greater increase in HDL cholesterol and decrease in LDL cholesterol. So this was found on a short-term study. Again, Brem et al. Compared low carbohydrate diet with a calorie restricted low fat diet, okay, with less than 30% of calories coming from fat. And this was also again studied for 6 months, wherein again the same thing was found, that low carbohydrate diets were actually causing more weight loss than the low fat, than the normal diets. Okay. Now, these were the studies which were done for 1 year. So there were 2 studies to low fat diet, and here they have compared low carbohydrate diet to calorie restricted diet. In both the studies, post 1 year, what they have shown is there was no significant difference in the weight loss between the groups. So if the period of the study is longer, then the weight loss, the difference in the weight loss between the groups is not significant. And the same thing is with lipids. Now, this is the most interesting one, Dazigner et al., where they have compared all kinds of diets. Atkins versus Zone versus Weight Watchers versus Ornish, all kinds. So Atkins is low carbohydrate, very low carbohydrate, or ketogenic. Zone is low carbohydrate. Weight Watcher is calorie restricted, and Dean or Ornish diet is low fat. Now, what they found is after 1 year, all diets cause same amount of weight loss. And interestingly, what they said is the amount of weight loss is correlated with self-reported dietary adherence and not the type of diet. So it is very important to keep following the kind of diet that you are following. So compliance is very, very important as far as weight loss is concerned. Again, this is a recent paper where it is where high carb and low fat, low carb diets are compared with high carb, low fat diets on various metabolic parameter. And again, there is data to show that low carb diets on a short period of time, there are a lot of randomized controlled trials to show that in a short period of time, whether it is diabetes, pre-diabetes, type 2 diabetes, low carbohydrate diets are actually showing a greater impact on metabolic parameters as well as on weight. Okay, so there are recommendations for low carbohydrate diet. Again, it has, there are various recommendations done where they have shown that very low carbohydrate diet can be a reasonable option for some patients, but for a limited period of time. So it can be a modality to kickstart the weight loss program, but it has to be then shifted on to probably a Mediterranean diet for a long-term maintenance. So these are again recommendations for cardiovascular risk factors where they have shown that there is a reduction of triglycerides with low carbohydrate diets. But in Indian scenario, because people eat so much of carbohydrate, even a reduction, you don't really need to go to the level of ketogenic diet. Even a reduction to up to 40% of calories coming from carbohydrate, you will find a drastic drop in triglycerides and in blood sugar, and also a drastic weight loss, and also reduction in waist circumference. Now, there are safety concerns with low carb diet, especially in individuals who have diabetes or probably who are taking SGLT2 inhibitors. In such patients, it is not recommended that a low carbohydrate diet a very low carbohydrate ketogenic diet should be given. Last couple of dietary therapies, again, meal replacement therapy. We know that these are very, very popular because they're intended to substitute for 1 or 2 regular solid meals or snack on a daily basis. And there are 2 kinds of therapies, total meal replacement and partial meal replacement. And the whole idea of using meal replacement is to limit food choice, ease of use, taste, and ease of availability. And again, there is a lot of data on use of meal replacement versus use of isocaloric food intake. So say you are getting 800 calories of meal replacement and you are getting 800 calories by a planned diet, but there are review articles to show that even then meal replacements tend to cause more weight loss or probably beneficial for a longer period of time as compared to isocaloric substitution with full meals. So there is a lot of data to again show that. Now, Dr. Neeta also said in her talk that ultimately holy grail of diet following a lifestyle is compliance. And it has been shown that if one wants to comply to the diet, then the compliance to diet, which is closest to normal eating pattern. So if you look at these compliance parameters, Weight Watchers, which is just calorie reduced diet, but it's the same diet. You are not touching the carbs, proteins, fat, has the greatest compliance over a year. Whereas if you look at a very diet where there is drastic reduction of carbohydrate like Atkins diet or Ornish diet, you will find that the compliance actually drops as the time period goes on. But the most important thing, like it has been shown in the meta-analysis, is compliance to diet is very important. Last one, because it's a PCOS meeting, these diets are very, very popular in PCOS. These are called as anti-inflammatory diet. Again, the diet should be low in glycemic load, low in omega-6 fats. And this is a big problem again in India, because most of the cooking oils which are sold in India are loaded with omega-6 fat. Okay, and they have to be rich in EPA. And again, in the anti-inflammatory diet, it is recommended that you give a diet which is around 1200 calories in case of women with PCOS. And the amount of carbohydrate that you can give is about 150 grams of carbohydrate with a low glycemic load, which comes from 10 servings of non-starchy vegetables, limited amount of fruit, relatively rigid but not total exclusion of high carbohydrate glycemic load foods such as bread, pasta, rice, or potato. Again, about 100 grams of protein is recommended with low fat sources of like fish, chicken, because this paper is published abroad. So naturally dals will not be a part of this. But again, they have spoken about limited amount of soybean or, mock meats as they are called at, or tofu. So we can give dals here, and fat has to be about 50 grams per day. So this diet is called as a 1-2-3 diet. That is, for every 1 gram of fat that you consume, the individuals would consume 2 grams of protein and 3 grams of carbohydrate. It has been shown that 1-to-3 ratio stabilizes postprandial insulin levels, thus relieving the inhibition of hormone-sensitive lipase in the fat cell. And it also has shown to reduce silent inflammation. So these diets are very, very popular in case of women with PCOS, where inflammation is a huge issue. So again, we know that there is a lot of, just last 2 slides where it has shown that there is a lot of data to show relationship of nutrients to mortality. And again, all these years we were worried about consuming high fat. I remember when I was a student of dietetics, talking about fat was like giving bad words. People would proudly come and tell me, "Madam, hum khane mein tel nahi lete. We do not use cooking oil." And now we have come to full circle where we have shown that even if the fat percentage increases slightly, but carbohydrate drops, there is actually reduction in mortality from cardiovascular events as well. So we have come to a full circle. So here, when you replace one nutrient for other, if you replace carbohydrates with proteins and fat, it has actually shown to benefit people. And in Pure study, it has shown that even replacing carbohydrate with saturated fat does not cause a huge problem, whereas a huge hue and cry has been made about consuming saturated fat for past so many years. And this is a beautiful data which is given by Sarah Siddleman, where she has shown that high carbohydrate and low carbohydrate both cause high mortality. So when you consume about 50% of calories coming from carbohydrate, mortality is least. And I think if in India, we can just follow this mantra, I think we will do a lot of good to people, to get people from year to year is the biggest challenge. And as a dietitian, I can tell you, it is wheeling and dealing with patients. Madam, ek aur roti de do, thode se chawal aur de do. So it's literally wheeling and dealing to get this percentage of carbohydrates. So in conclusion, diets have a huge impact on human health. Modification of dietary calories, macronutrients have been tried to decrease the risk or maintain the metabolic status. Lowering of a single macronutrient does cause weight loss, but metabolic benefits can vary. And we have seen this with low-fat diets especially. The biggest issue of any diet is compliance, and fad or extreme diets, due to their removal of a nutrient food group, compliance is very poor. So mantra of good diet is not only weight loss, but weight maintenance. And fat diets usually do not succeed in weight maintenance. They're great for weight loss, but when it comes to maintenance, they lose the battle. So it is prudent to have a diet which includes all food groups in recommended amounts, which result in long-term benefits. Thank you so much for a patient here.
Thank you, Mrs. Shilpa. I think that was an excellent talk, and it really clarified many of our concepts. And especially, I liked the slide where you showed that okay, even if you come to 50% of energy intake from carbohydrates, that itself is probably going to reduce the mortality. So that was really something that gives confidence that okay, what we advise to the patients is right, because even I am following this. That okay, it's okay to cook your food in ghee. It's okay to cook your dal in a little bit of ghee. That is fine, but reduce the amount of chapatis. So my question was, one question to you is, because I am a pediatric endocrinologist, I see a lot of adolescents and even young children with obesity. So how much caloric reduction can be advised for them, especially in light of the fact that when we see NIN guidelines, then for adolescents, the caloric allowance is too high, I guess. It's really high. If we allow that much, everybody will become overweight or obese. So what is your advice for that?
I think if you look at the ICMR NIN recommendations for whether it's adults or it is children, the calories are too high. Most of the calories are above 2000. I think what is important while planning diets in pediatric age group is taking a robust recall. And from the recall, a very simple thing would be whatever calories are coming from non-healthy food sources. So don't touch the roti, sabzi, dal, chawal if you can. But if whatever is coming from, say, cookies and chocolates and packet of chips or whatever, so they land up to 300 to 400 calories is what I typically find in my practice. If you can just eliminate that, I think a lot of good is done. And you can do it stepwise. You don't have to do it in the first consultation itself, because it becomes very overwhelming for a child to give up everything. That's something which is normal. So I start with one thing at a time. So I find worse of what is eaten and sort of remove it. So remove 100, 150 calories and keep doing it till you achieve about 500 calorie reduction. But you have to give them a little more time than you would give adults.
Yeah, I agree.
I mean, in adults, we do it at one go, but I don't think they follow it. They also take their own sweet time to follow it.
Yeah, but in children, if we are too strict, then they just rebel and they just say, okay, nothing doing. So I agree with you, one step at a time. And so there is no hard and fast rule that how much caloric reduction. If you just take away the empty calories, that itself will probably solve the issue. Okay, there is one question from you for you from the audience, that what is your take on a diet for sarcopenic obesity, where we need to give food/protein for improving muscle mass, at the same time restrict calories for reducing obesity?
Correct. So for sarcopenic obesity, it's very important that you give good amount of protein in the diet, reduce carbohydrate, because there is a lot of fat. Whatever is the BMI is really coming from the fat of carbohydrate of the diet. So it is still important that you restrict carbohydrate, but just eating is not going to improve sarcopenic obesity. What you need to improve sarcopenic obesity is resistance training. So you will have to put those people through some form. They may not go to gym, but they can do some form of resistance training and then supplement protein, and that will give good results. Because I find people not eating carbs and eating, but they lose more weight and they start looking very, very lean. And again, that is looking fat is a taboo, but looking very lean is also a taboo in India, because they'll say कि बीबी खिलाती नहीं है या माँ खिलाती नहीं है. It starts there. So it is something that they need to do is they need to start weight training. That is very, very important, or any kind of resistance training, and then start building up protein, reduce carbohydrates, and add on good quality fats. I think adding on good quality fats is also as important.
Okay, Mrs. Shilpa, I think
if there is a time, I think I would like to come in here. Very wonderful presentation by Dr. Shilpa.
Thank you.
Shilpa ji, I would like you to drop a mail, or I can mail you. We have to discuss something beyond this. Here I would like to say we have done a comparative study between vegetarian and non-vegetarian healthy women, as well as veg and non-veg PCOS women. We found that inflammatory markers, ICAM, interleukin, TNF-alpha, IHS-CRP, and several other markers we found higher in vegetarian subjects than non-vegetarian. So we are trying to study that further now, but the results were a little astonishing. If you take Mediterranean diet, that is more of a vegetable and some seafood diet, and it is beneficial in inflammation, cardiovascular risk, diabetes, and so on. Here we found opposite results. In your experience, what do you think in Indian diet is there? Why we have inflammation high?
See, sir, I'll tell you something that in India, not saying that you're vegetarian is all khun maaf. It becomes that you can do anything within the purview of being vegetarian. So people in vegetarian diet eat a lot of reused oil. That's the biggest problem. They use a lot of trans fat. There is a lot of frying. So because people don't eat non-veg, they eat a lot of fried food. There is a lot of intake of sugar, sweetened beverages may not be there, but mithai, is eaten. Whereas non-vegetarian people are a little happy when they eat non-veg. So they really do not care about eating other kind of high-fat food. So mithai nahi khate hain, So I personally, that's my experience in practice, that when to a non-vegetarian patient, when I give an egg or I give a piece of chicken, they say, "Ha, madam, acha khana hai." But vegetarian patient is perpetually unhappy. So then he or she is looking out for so many high fat choices. Indian diets are only carb and fat. There is nothing else. So whatever is protective, vegetable, fruit is not consumed by a vegetarian Indian. No vegetarian Indian is eating 250 grams of vegetable ever. In my 20 years of practice, I have not found a single person eating recommended 250 grams of vegetable. Non-vegetarian तो खाते ही नहीं है, पर vegetarian भी नहीं खाते.
Dr. Ashraf,
I think
yeah.
means aloo arbi.
That's not vegetable, no, but.
So probably the definition of vegetable is different.
Yes.
Samosas and puris. Yeah. Okay. Thank you. Thank you, Mr.
so much.
Thank you so much for that lecture, and thank you, Dr. Vanna, for chairing that session. I think in interest of time, we need to move on. And I request Dr. Nishant to introduce our panelists for the panel discussion that we have today. Over to you, Dr. Nishant.
Thank you. Thank you, Dr. Nitin. So after these two
Manchu, slides, please.
Back-to-back talks, excellent talks, we are now moving on to a panel discussion, which is equally promising. So I'll begin by introducing the panelists. Can I have the slides for the panelists, please?
Can you have slide for Dr. Sanjay Kalra?
Yeah, so Dr. Sanjay Kalra really needs no introduction, well-known figure both in national and international endocrinology. He is the immediate past president of Endocrine Society of India and also the president-elect of South Asian Federation of Endocrine Societies. And he is the chief endocrinologist at Bharati Hospital, Karnal. Our second panelist, Dr. Shravani Mukherjee. She is scientist staff and senior deputy director at the ICMR National Institute for Research in Reproductive Health. She is the winner of ICMR Swarnkanta Dingle Award, the Labh Shweta Award, and also the GP Talwar Gold Medal. She's a fellow of Frontier in Reproduction in USA, and she's also the recipient of multiple grants from DBT, DST, and DHR. She's got publications in JCM, Cell, Human Reproduction, and other international journals. Her area of interest is reproductive endocrinology and female infertility, and special interests include mechanism of ovulatory dysfunction in polycystic ovary syndrome and biomarkers to predict oocyte quality and pregnancy outcomes. Our next panelist is Dr. Dheeraj Katula. He's one of the lead psychiatrists at the bariatric clinic in CMC Vellore. He's been there for past 6 years. He's MD, DPM, MPhil, and DM in addiction psychiatry from prestigious AIIMS, New Delhi. And his interests include addiction psychiatry, behavioral addiction, and obesity and ethics. And he's also propounded the concept regarding food being an addictive substance. Our next panelist is Mrs. Ujjwala Bakshi. She's a founder of Potion Cure Through Diet, which is a Singapore-based licensed company. She was in fact working in Singapore and now shifted base to India. She's a registered dietitian and certified diabetes educator. She's affiliated to the Singapore Nutrition and Dietetics Association. She is also a Singapore Health Promotion Board Youth Ambassador and a member of Indian Dietetics Association. She's won multiple awards, including the first prize in Tarla Dal's cookery contest, third prize in the Marwadi Mitra Mandal cooking competition. She's also won in the NM College Intercollegiate Cookery Contest, and also multiple other awards that she's got. And she's got research in therapeutic diets in PCOS, diabetes management, and gut health and physiological responses. With this, I hand over back to the moderators to conduct this very promising discussion.
Thank you so much, Dr. Nishant. And I think I really thank all the panelists for joining in. And the best part about this panel discussion is that we have specialists from very different fields. And that's the best part about this conference and probably of this society as well, that we have an endocrinologist, we have a molecular biologist, we've got a psychiatrist, we've got a nutritionist, all talking about the same subject on the same table. And I think that is really interesting. Today, we'll have a panel discussion on syndromic and non-syndromic causes of childhood obesity. But we are running a bit late, so I'll request all the panelists to keep their answers really brief. And maybe I think I should just start with our panel discussion. And maybe I request Dr. Sanjay Kalra to, sir, please answer the first question. And we've spoken a lot about exogenous obesity in the last two lectures. And though Dr. Neeta did mention about some syndromic causes and inherited causes of obesity, but sir, if you could enlighten us as to what are the causes of syndromic obesity in children, and since these are very less talked about in practice.
That's a very important question, Dr. Nitin. In obesity management, we tend to blame everything upon the person or the child. And we say that either you're eating too much or you're exercising too little. But there are many other reasons for obesity. The first would be the classic endocrine disorders, maybe hypothyroidism, panhypopit, insulinoma, Cushing's. A second group would be hypothalamic disorders, where either you have injury to the hypothalamus, a surgery that has been done on the hypothalamus, maybe an operation for craniopharyngioma, or you have a congenital malformation. Why will obesity occur in a hypothalamic disorder? Either there is a change in the production of orexigenic or anorexogenic peptides from the hypothalamus, or because the blood-brain barrier gets disturbed, all the peptides that are formed in the GIT or maybe in the pancreas, they are able to cross the damaged blood-brain barrier, and then they are able to go and bond to, or they are able to activate the receptors which are present in the hypothalamus. So the first is classic endocrine disorders. Second is hypothalamic disorders, injury, surgery, congenital. The third would be genetic issues, focusing especially upon the leptin signaling pathway or on other receptors. But when we speak of syndromic obesity, we don't speak of all these, we just speak of all the syndromes that are there. Now, our colleagues in pediatric endocrinology remembered the syndromes offhand, but for other mere mortals, it is difficult to do. An easy way is just to see if your patient, if the child is coming in with a developmental delay, is coming in with a diminished IQ, is coming in with an abnormal diet, really severe hyperphagia, or perhaps with dysmorphism. So these simple Ds tell us that we have to think of syndromes. Now, all syndromes are not the same. All of them will not have a developmental delay. But some of the common syndromes that we encounter in practice would be a Bardet-Biedl syndrome, a Fragile X syndrome, or maybe a Prader-Willi syndrome. Other syndromes that you may wish to, that one should be aware of would be pseudo-hypoparathyroidism and then pseudo-hypoparathyroidism. Achondroplasia would come in that category. And then a few disorders where there is a severe intellectual impairment, Carpenter syndrome, Cohen syndrome, meningomyelocele, and then others where development is normal, like Elstrom syndrome. Do remember that many of these syndromes are genetic. Of course, all of them are genetic in origin, but many of them occur because of alterations in the paternal chromosome, not in the maternal one. So it's a very interesting field. All of us who are practicing obesity should remember that these syndromes do exist. And Prader-Willi, for example, occurs in 1 out of every 25,000 births, which is quite common. So do not rush to judge the child or the family. Just do look for these genetic syndromes.
Thank you so much, sir. And not only for telling the causes, but making it easy to remember with your style and classification. Thank you. And I think I move on with this to the next question. And may I request Dr. Shrabani Mukherjee to take that question. Ma'am, having listened to the causes of syndromic obesity, what do you think in terms of the Indian population, given your expertise as a molecular scientist, and what is the role of next generation sequencing in the Indian setting, and how does consanguinity play a role? Dr. Shrabani, we cannot see you. Can you say something?
Hello.
Yeah, we can hear you. So, yeah.
Yeah, I put on my video. Again, I will start my video. Okay, thank you, Dr. Nitin. And at the outset, I would like to thank the Dr. Ghani and the MPPCO Society for having me in this platform. So the syndromic obesity, there are lots of big contribution towards the syndromic obesity, and which may be due to a single gene disorders like Alstrom syndrome, Biddle syndrome, or Cohen syndrome. That is mainly due to the inherited autosomal recessive, or sometimes it like Prader-Willi syndrome or AHO, that is due to the error in imprinting of the genes. Mainly, am I visible now? No.
Not visible, but very clearly audible. Maybe we'll
Okay.
continue. Yeah.
Okay. I will go ahead with that. So in the disorders which are inherited at the autosomal recessive fashion, means that the affected person must have a mutation or a pathogenic variance getting from each one gene from each of the parents. The parents in that case may be the carriers. So they must be heterozygous. So the autosomal recessive disorders are strongly associated with the consanguineous marriage. And India, we know approximately 10% marriages are still in the related family members. So in those cases, there is a high chance that the offspring of this consanguineous parents, if they're having any heterogeneous mutation, they can pass on to the children. Like almost in consanguineous marriages, there is a 25% chance of the offspring being affected, and 25% chance they may not be affected, and 50% may be carrier. So if there is a family, if there is a child is detected with any of these abnormalities, then it is advisable to do the molecular genetic testing of the child and also the parents to establish the heterozygosity of the parents, do the test in the sibling, and also for the next pregnancy, they should plan for the pre-implantation genetic testing or prenatal testing. So now coming to the advent of the NGS, where you can do the sequencing of RNA, DNA, or every variants very fast in a very cost-effective manner. So for this autosomal recessive disorder, it is highly used to identify, because from the clinical diagnosis, you have a fair idea that which gene is going to affect. If it's a monogenic disorder, you can do the target sequencing of that gene particularly, or in that BDS, there are 26 genes are involved. You can do a multigenic panel. So you can have a panel of NGS and do the sequencing. So you will establish whether whatever the child is having, whether that is coming as an autosomal recessive disorder or not.
Thank you, Dr. Shabani. So very clear points coming there. And I think the important point that is there is also that what ma'am mentioned, that even family needs to give a sample. And many times we at Velo do a 35 gene panel for monogenic causes of obesity. And sometimes we get these variants which may not be significant or may have undetermined significance. And that's where that parental sampling really helps out. Thank you, ma'am, for that answer. I request the tech team to get in touch with ma'am to somehow start the video as possible. So I move on to my next question and I ask Dr. Dheeraj. Dr. Dheeraj has been working in the obesity clinic here at CMC Velo. And Dr. Dheeraj, what is your take on the prevalence of psychological problems in people with obesity, especially in children as well? And also wanted your take on the prevalence of eating disorders in children and adolescents.
If in adults, I mean, I've worked with adults, so at least our clinic data shows that about a third of patients who come with obesity have psychological morbidity, and about half of those patients have dysthymia and depression. Now, if we see the relationship between obesity and psychological problems, it's a bidirectional one. Those mental illness, they have lifestyle issues, they have a problematic dietary pattern, and they're also on medication sometimes, which would add to the adverse drug effects, which would add to the weight. But on the other hand, those who are obese also, they are not able to have a full functioning in their life. and they experience stigma and ridicule, and all these also add to depression and the psychiatric problems. So if we see this child and adolescent population, we think not all children are goody and cute, but in school they can be nasty. They pick on children who are chubby and overweight, especially the ones who are not doing well in studies. If these kids do, they would pick on them and tease them, and that would have a long lasting impact even in their adulthood, and would cause adult psychiatric morbidity. And this is seen more in women, girls who experience this kind of abuse. Many men, when asked if they had experienced ridicule or were they bullied in their childhood, they would say no. But many women have had that experience. So many girl children would. That's the reason 25% of the girls who have weight problems try some drastic restricted dietary attempts, even taking pills to reduce weight, taking laxatives, etc. So eating disorders as such, there's a meta-analysis which shows about 1.3% of them have a binge eating disorder. If we go for subclinical binge eating, that the percentage raises to 3%. So overall, if we see, COVID has had a big impact on children. They were not able to play well. Their physical activities had reduced, and they were also sitting at home and eating more. So overall, I think I'm sure most pediatricians are seeing a increase in the weight of children. So as things are easing up, physical activities and all should be increased, and more studies regarding the impact of these psychiatric symptoms on weight. For example, why is it that even people like ADHD would develop obesity? That's not intuitive. We don't think obese person to be hyperactive, but this relationship has been observed. So more work needs to be done on this.
Thank you, Dr. Dheeraj. So clear messages there. It's more common in women, bi-directional relationship of psychological problems and obesity, and it's common. It's not that it's not seen, so it has to be looked into. I move on to my next question. I welcome Ms. Ujjwala Bakshi, and we're talking about childhood obesity, and it was discussed a bit in the last session as well. But very briefly, what do you think are the key challenges a child with obesity faces with respect to the nutritional management?
So in our practice, we've observed that, the concept of acha khana, when we say the child has been told since the very beginning that if you perform well in your studies, we'll take you out, we'll take you to a restaurant for an acha khana kind of a meal. So the concept is, the misconception develops there. That means the home cooked food is not acha, is not good. And the child is looking for that very tasty, very high calorie food, which then kind of diminishes the purpose of eating healthy. So I think that is one of the biggest challenges when that I have observed specifically in India, actually, when, in the social gatherings and at home, when people say that, okay, if you do this, we will give you some reward in terms of food, which is something needs to be broken down. We need to break through this ideology, specifically, I think, in India. Yes.
So basically trying to change the reward center. Yeah. Right. So let's take the discussion forward, and I go back to Dr. Kalra, sir. And sir, would you give us some easy way? And you have, I would say, a book of mnemonics that you've provided to endocrinology, but maybe something here so that we can remember as clinicians, when should we refer a child for a genetic test? Something that's easy.
Oh, Dr. Nitin, thanks for that, because this is actually something that I have found very difficult in practice. So let me share two mnemonics here. Both of them work equally well. And this will help all of us remember when to refer a child to a pediatric endocrinologist, when to refer for a proper endocrine follow-up, and especially for genetic testing. So the first would be based on the dangerous Ds. Any child with a developmental delay or diminished IQ. Any child with dysmorphism, and all you have to do is to look at the dome of the head, that is the whether the patient has macrocephaly or acrocephaly, and the digits, dactyly, brachydactyly, syndactyly, polydactyly. So developmental delay, diminished IQ, dysmorphism, especially the digits and the dome of the head, and the dynastic history or the family history, and the diet if the child has hyperphagia. S is for syndrome, and we remember the clinical presentations of syndromic obesity in the following manner. Any child with a swift onset, that is below the age of 5, with severe or morbid obesity, and with a sweet tooth, again hyperphagia. Any child with a history of obesity in siblings, with a history of sanguinity, Dr. Mukherjee spoke about that, a history of consanguinity in the family, and with a suboptimal response to medical nutrition therapy. The mother actually swears that the child is eating nothing, and actually the child is eating nothing. The child is being starved. Still, there is obesity. And to add to these 6 S's, then we have slow development, sight impairment, impairment of sight, and also the size of the head. Again, macrocephaly, acrocephaly. So this is a simple way in which I remember when to refer to Dr. Nitin Kapoor.
Thank you, sir. So dangerous D's and 9S made it very simple. Thank you so much, sir, for that clarity. And conscious of the time, but I would still like to take this next very burning question for Dr. Mukherjee. And with the large body of work that you've done on PCOS and bioinformatics of PCOS, we as clinicians still do not know why PCOS happens. And we are in a PCOS conference, and we're talking of childhood and adolescent obesity. So if you could share some insights briefly from the body of work that you have done in adolescent PCOS, and what is the etiology there?
See, the young adolescent girls nowadays is coming up with the PCOS, and many of them are obese, maybe because of the diet and all those things. Looking at the genetic background, whatever Jiva studies and candidate gene studies has been done, if you look at the genes, in both the syndrome, they are complex disorder, there have a genetic background, and there is an environmental effect also. So not only the gene is acting, environmental factors have lot of influences. If you look at the genes, whatever we have got in PCOS, not me, a lot of people have gathered in PCOS and in obesity, there is a small percent of gene that overlaps, and the other big percentage, they do not overlap. In the small percentage of genes, if you look that when known to be the obesity gene, like EB, like ERBB4, Piper gamma, MC4R, then leptin receptor, CNPP1, HMGA, all those things are also involved in the PCOS, interestingly. So it is possible that the girls or women who are having this background of the gene of this obesity genes, they have more propensity to develop to the PCOS with the influence of the environmental factor like high diet or insulin resistance or some other like environmental toxicants, BPA, all those things. So these genes, so from our study, we have seen that the genetic pathogenic mechanism of lean and obese PCOS are not different. I will give you 2 examples. Like we have studied the insulin receptor gene. We have seen that particular polymorphism induces PCOS in the lean women, but not in the obese women. And other in Piper gamma gene, we have seen that protect the PCOS in the lean woman. So you can make out that there is a difference in the genetic makeup of the lean and obese woman. So there are a lot of studies we need to do in Indian women regarding the genetic that we are also doing, and other groups are also, we have a task force study we are going to start now. And apart from that, there are other genes we have seen, like ENPP1 gene. We have seen in our study that ENPP1 does not show any association with PCOS, but the obese PCOS woman, the genotype is very high. The ENPP1 gene polymorphism, which is also a known gene for obesity. So my opinion is that the women who are having all this polymorphism or variants in the gene which are related to obesity related genes, they have higher risk of development of the PCOS then development the irregular menses and increased androgen and towards the PCOS. Not only the genetic polymorphism, we have also studied the proteome and also the epigenetic modification. We have seen that leptin and leptin receptor, which is a very well-known gene involved in the obesity, are differentially methylated in the PCOS woman, which will also contribute to the differential expression of these genes and differential action of this genes in the PCOS woman. So there is a lot of level of regulation, not only the genetic polymorphism, the epigenetic, their hypermethylation, and all those things also we need to understand and consider in this girls.
Thank you. So genetic and environmental, and in the genetics also, there's so much more that is there. So there is a lot of research that is required. And thank you for sharing that with us. And maybe I move on to the next question. I'll just bring up a point that Dr. Vandana Jain pointed out when I discussed the last point with Dr. Dheeraj, that it's not only the stigma from the peers, but even sometimes it's from within the family, which is very, very true, and that needs to be addressed. My question to Dr. Dheeraj for a short answer would be, what do you think from your experience in addiction psychiatry would you relate to obesity, as is food an addictive substance, and would you apply those principles here as well?
Yes, certain links are like, for example, if a substance that I'm addicted to is denied to me, what would happen? So if food is denied, if I'm not getting the food that's being restricted, what would I go through? The irritability, the inability to concentrate, those changes. Why is it that despite the physical harm that I'm going through because of my obesity, I still persist in my eating behaviors? Why is it that I exercise properly and do my diet control, but after some time I give up and fall into my old ways? So these are some links which are quite related to addiction using other substances. But for diagnosing any behavioral addiction, a lot more evidence is gathered before it is called an addiction, like for gambling or gaming. Food is still not yet described, but however, there are certain links. For example, rimonabant, CB1 receptor antagonist, is used in anti-obesity as an anti-obesity drug. Locasirin, which is a 5-HT2C antagonist, which is used as an anti-obesity drug, also helps in smoking cessation. So there are links between addiction and obesity. But from management side, I mean, there's a lot more that addiction, understanding addiction would help. For example, many people who are addicted to substances have ambivalence towards changing their behavior. So are people with obesity regarding exercise, regarding diet control. So to fight this ambivalence, we could use motivational interviewing, where you develop discrepancy between the state that they see themselves to be in and the state that they are. That would be an aid to motivate. Avoiding arguments and rolling with resistance. Every consultation doesn't have to end in a dramatic decision, but they would have some resistance, but go with it and express empathy. Support their self-efficacy that they can do it with, and they have it within their means to make some changes. Also, the issue of relapse prevention. So they start and they are now walking regularly, but what happens is after a break, it is, for example, it is raining and somebody stops going, then that lapse becomes a relapse. He doesn't restart again. Then he gives up. He would have a negative feeling about, I am waste, I am a failure, I can't do it. However, as a doctor, we could encourage them to get back. A lapse doesn't mean a complete failure, and these things are natural. And the more important thing is to restart the change that you had. And also understanding about high risk situations. For example, in substance use, we discuss about if he's going to a party, how would he deal with when he's offered a drink? So is the case with going to a party for diet control. For a person who is on intermittent fasting and he's going in a time that he's supposed to be fasting, what would he do in the party? So discussing about high risk situations
Thank you, Doctor. It gives a lot of ray of hope for our patients, because we know that addiction sometimes can be quite successfully managed, and hopefully we think obesity should be able to get that victory as well. My last question for the panel, and it is just going to be to Dr. Ujjwala, asking about just your 3 commandments that you would leave our delegates with for children who present with constitutional obesity. What would be your 3 commandments that they should change in their diet? What is the advice that you would give? Just 3 points.
Okay, so first and foremost, we as parents have to be great role models for our children. So if we want our children to be disciplined in terms of food and lifestyle, so it's not just the food that we want to focus. We don't want to keep telling them, oh, you're not supposed to eat this or that, and this is high calorie, this is too sweet. So first and foremost, stopping the nagging behavior. The parents will have to really instill this habit. Second thing is, parents will have to take this as a role model for themselves. Like, they cannot be eating on the same dining table, calorie dense foods and giving low calorie food to their child. This is harsh behavior towards children, that they are innocent. So we need to model what we want to teach them. So that is very important. And I have seen parents coming out for their children's diet modification, and they would be like, it's getting very tricky because we want to eat chicken burgers, and we have advised our child to just eat the patty. And I'm like, isn't that rude for the child to, even observe that? So why don't you eat your chicken patty later, burger later, or just don't eat in front of them? So you got to be, walking the talk. Third thing is diverting their minds from the food towards physical activity. So as we say that, a family that sits together, eats together is going to last for long, they have conversations. So likewise, we as family need to also inculcate the habit of mutual playtime, interactions, rather than just sitting in front of the screen, watching television, not being aware of what's happening, what's coming onto the child's plate. So we should be very much aware of our child's food eating behaviors, observe, as Dr. Kalra also mentioned, that it's not just always about food eating. If there is some kind of signs about hyperphagia, the parents should observe that and reach out to relative professionals, rather than just nagging the child and telling them that, okay, you're not supposed to eat. So we need to be alert as parents, and we need to have some habits modeled in ourselves so that we can teach our children in the right fashion.
Right. Thank you. Thank you for that. Being role model, you should be alert and at the same time be kind. Thank you so much to all the panelists. I hand over back to Dr. Nishant, and thank you for patiently chairing this session. Your final words before we hand over back to the next session.
Thank you, Dr. Nitin. I think this was an excellent discussion, and I would like to sum up briefly in a few sentences. I would say that the clinician should be aware that syndromic obesity may also come to their clinic, and so they should be considering this as one of the differentials. And at the same time, they should consider the points which Dr. Kalra mentioned regarding suspecting, in which case to suspect and when to refer the patient with suspected syndromic obesity. And while some of them could be single gene disorders, as Dr. Shabani said, but there could also be other disorders in which the genetics play a part, and there is a component of the environment which plays a role. It's important to remember that obesity could be associated with diagnosable psychiatric conditions like dysthymia, which Dr. Kotula mentioned, but at the same time, there could be other subtle manifestations, and you might have to use the techniques you use in addiction psychiatry to take care of the addiction to so-called addiction to food. And of course, the important insights regarding childhood obesity would be that parents should be a role model, and you need to change the outlook towards food in children. They should not be viewed as a source of reward, and that is probably important for them as well. So with that, I'll close this session. Thank you.
Thank you so much for those clear summary points. Thank you all for joining in, and I hand over to Dr. Nalini and Dr. Abhilash for the next session. Thank you, one and all.
Thank you, Dr.
Thank you so much, Dr. Nitin. That was a very, very important session on obesity. And moving on with the Mppcos conference, here we have, as we all know that endocrinology is a science with widespread effects. And today, in this session, we'll be dealing with interdisciplinary endocrinology. And today, I and my co-coordinator today would be Dr. Abhilash Nair. I am Dr. Nalini Kuppale, endocrinologist, consultant endocrinologist from Hyderabad. And I am also an associate professor of basic sciences. And my co-coordinator is Dr. Abhilash Nair. Abhilash Nair is assistant professor of endocrinology. Can I have the next slide, please? As Department of Endocrinology at Government Medical College, Trivandrum. Today, dealing with the interdisciplinary endocrinology, firstly, we have with us eminent chairs, Dr. Rama Walia and Dr. Sudha Yadav. Can you have the next slides, please? Dr. Rama Walia is an associate professor in Department of Endocrinology at PGI Chandigarh. She has numerous papers to her credit, and also is has innumerable publications to her credit. And her areas of interest are type 2 diabetes, adrenal disorders, reproductive endocrinology, pediatric endocrinology, and growth disorders. Dr. Rama Walia. And the second chairperson is, next slide, please. Tech team. Next slide, please.
Yes, the second chairperson is Dr. Sudha Yadav. She has a long experience of more than 20 years in the field of dermatology, and she is a well-known dermatologist in Prayagraj, and currently working in the Skin Beats Clinic. Her interests are clinical dermatology, and has a number of editorial papers in the field of dermatology. Welcome, ma'am. I request the chairs to please take over the session. Rama, ma'am, you seem to be muted.
Dr. Rama, please unmute.
Sorry. Thank you, Dr. Nalini and Dr. Abhilash, for the nice introduction. And today my job is actually very easy because I need to introduce Dr. Shashank, who is a well-known personality among us. He is consultant endocrinologist, and currently he is affiliated with Joshi Clinic and Lilavati Hospitals. He has many earned gold medals. He's a top ranker. He was awarded Padam Shri in 2014, and he is alumni of GS8 and KEM, and he has written numerous publications and books. So today we will be listening to him regarding the link of obesity and cancers. We all know that obesity is related to diabetes and cardiovascular risk, and we actually ignore the risk to, sorry for the interruption. So we know today we'll be listening to the risk between association of obesity with cancers. So I'll invite Dr. Shashank for this talk.
Tech team.
At the onset, I would like to thank the organizers for allowing me, and particularly thankful that this topic of obesity and cancer was considered for this meeting. I am apologizing that due to a spiritual retreat, I am not able to join live, and I have sent a recording for the same. So clearly, let us look at obesity and cancer and where do we stand on it. Let us look at the basics. Let us look at the links between obesity and cancer, fat, cancer cell and connect, obesity and cancer with take-home message. We all know that obesity is recognized as a disease and is a global health issue, whether it is American Medical Association, WHO, Canadian Medical Association, or the Organization for Economic Cooperation and Development. We know currently 135 million people living with obesity in India is there, and it is a worldwide prevalent problem. We all know that obesity is a challenge between intake of hunger, satiety, and nutrient absorption, and expenditure, metabolic rate, thermogenesis, exercise, and non-activity energy thermogenesis. So we are spending a lot of energy, and expended energy is coming through either physical activity with exercise or whatever heat is dissipated, particularly in winter, through non-exercise activity thermogenesis. We also know that there is a RMR or BMR, which is resting metabolic rate or basic metabolic rate, which is energy required to be awake, supine, relaxed state, and heat production, which is responding to food, psychological stress, cold environment, and drugs. We all know hormones have a key role in influencing appetite. And we all know that hypothalamus, brain, and corticolimbic system clearly have an influence on the adipose tissue, which make leptin, adiponectin, and resistin, amylin, insulin, pancreatic polypeptide, and the gut, which makes all the incretins. And we all know that they have a negative feedback. And whatever we eat with hedonic inputs, we also know that meal timing and size and energy expenditure is also the key. So a lot of peripheral signals modulate appetite and energy expenditure through hypothalamic neurons. Some of them switch on the appetite, some of them switch off the appetite. Some of them make you hungry, some of them make you full. And all this is in the second order neurons or the arcuate nucleus and the hindbrain, which is nucleus tractus solitarius. And at the peripheral level, we have the leptin, insulin, peptide YY, GLP-1, ghrelin, and vagal afferents. So clearly we know these interactions better and we understand them better as we go along. And we all know that the brain regions activated in response to good food or food associated stimuli is well known. For example, we know lateral hypothalamus regulates response of palatable food and drives food seeking behaviors. It sends dopaminergic signals to the nucleus ambiguans and dorsal striatum. And we know amygdala is the reward value of food. Nucleus ambiguans is the motivational or incentive properties of food. We also know dorsal striatum, motivational and incentive properties of food are there. And we know the insula has the taste or hedonic value, while the orbitofrontal cortex has the reward value of food. So clearly the wanting of food is dopamine signaling and the liking of food is opioid signaling. So when it comes to cancer, cancer and obesity has clinical and public health significance. And there is very good data, epidemiological and preclinical evidence to show that obesity increases the risk of breast and prostate cancer, which are the endocrine cancers, in incidence and mortality. Moreover, there's a lot of data to show that when there's a weight change in humans or when there is caloric restriction in animal models, there is a role of weight loss in counteracting the tumor producing properties of obesity, both for breast and prostate cancer. Given that weight loss is difficult to achieve, remember reduction of weight can reduce both breast and prostate cancer mortality as well as incidence. A lot of challenges have emerged at a population level for the link between obesity and cancer. Given that obesity is a complex trait of behavioral, epidemiological, molecular, and metabolic factors, it is a transdisciplinary approach. We need to understand linking obesity and cancer, and therefore the obesity cancer link has these simple points. We know there is a biological substrate of cancer in obese people. Obesity is a well documented level A risk factor for cancer. Obesity is a prognostic factor for cancer outcomes. So more obese you are, the worse is the outcome. Obesity makes you more vulnerable for a second cancer. Obesity adds to financial burden, impacts quality of life, and impacts on delivery of treatment and toxicity of chemotherapeutic agents. So this is a summary slide to tell you very clearly that when you are obese, it forms a biological substrate for cancer. When you are obese, it's a risk factor for cancer. When you are obese, it's an adverse prognostic factor for cancer. When you are obese, you are at risk for secondary cancer. And remember, when you are obese, your treatment is likely to get affected and you might get toxicity, and quality of life as well as financial burden may be there. So obviously, when we look at transdisciplinary approach, we need to take population-based insights from behavioral science, from epidemiology, from clinical oncology, and look at pathology, biomarkers, omics, and bioinformatics, and look at molecular biology and preclinical models, and look at insights from population and insights from mechanistic studies to look at the links between obesity and cancer. So at a cellular level, clearly we know obese humans have an expanded, reprogrammed, metabolically active adipose tissue, which has a lot of leptin, cytokines, and inflammatory factors. These extra fat cells have a direct effect on the cancer cells, on the signaling pathway like estrogen, insulin IGF-1, PIT1-3K, RAS, JAK-STAT, NF-kappa beta, and metabolic effects. So there is mitogenic effects and metabolic effects on the cancer cells. Also, we know when there is obesity, systemic physiology is altered. We have insulin resistance, excess of glucose, lipids, and free fatty acids, excess leptin and less adiponectin, excess estrogen, and a lot of inflammatory markers. So indirectly on the tumor microenvironment, when there is increased pre-adipocytes, cancer is associated with adipocytes. There is inflammatory cells, leptin, cytokines, and inflammatory markers. So obviously there is a direct effect and an indirect effect on the tumor environment. And these are all the cancers which are linked with obesity. You can see from oral cavity to esophagus to stomach to colorectum to liver to gallbladder to biliary tract to pancreas, lung, malignant melanoma, breast cancer, cervical cancer, endometrial cancer, ovarian cancer, prostatic cancer, kidney cancer, bladder, brain, thyroid, Hodgkin's lymphoma, multiple myeloma, and leukemia. So clearly for all cancers, there is a high odds ratio of 1.03 between obesity and cancers. But if you filter out all the cancers, and when you do a systematic and a quantitative meta-analysis of quad studies, which link BMI with risk of 23 calcium subtypes, the most high and a strong positive association between BMI and cancer is highest is endometrial cancer 1.48, followed by esophageal adenocarcinoma 1.45, postmenopausal breast cancer 1.11, and kidney cancer 1.2. There is an inverse association between BMI and oral cavity cancer, lung cancer, premenopausal breast cancer, and localized prostate cancer. The male-specific association between BMI and is seen between colorectal cancer, and female-specific association has been seen between brain cancer and kidney cancer. So females are more likely to get brain and kidney cancers who are obese. Men who are obese are more likely to get colorectal cancer. If you are obese, oral cavity cancer, lung cancer, premenopausal breast cancer, or localized breast cancer is less likely. And if you are obese, endometrial cancer, esophageal cancer, postmenopausal breast cancer, and kidney cancer is less likely. So a lot of biological mechanisms exist between cancer and obesity, but there are also non-biological mechanisms which increase cancer mortality. And they are all linked to delayed diagnosis and treatment inefficacy. So when you look at cancerous and progression, the mechanisms which cause and create excess energy, positive energy balance, and physical inactivity all lead to visceral adiposity, growth factors, chronic inflammation, and they all lead to insulin resistance, lipid toxicity, COX-2 expression, which all increase the AKT-mTOR signaling, increase intra-tumor steroidogenesis, and increase prostaglandin signaling, which increase the cancer risk and progression. So clearly we now know that whether it is abdominal obesity like high waist circumference, whether it is just obesity, whether it is visceral obesity, whether it's excess food or positive energy balance, all of them cause tumor progression. The classic example on the hormone space is the link between obesity and breast cancer. It is complicated, varying by the menopausal status and breast cancer subtype. Obesity, we know, has reduced breast cancer in premenopausal women, but increased breast cancer in postmenopausal women. So although postmenopausal women breast cancer is attenuated when people who use HRT. So clearly menopause status consistently has been reported to have different associations by hormone receptor status, but how it occurs, why it occurs is not well known. But obesity is strongest associated with hormone receptor positive cases, although classical differences have not been seen. Also, it has been reported that the protective factor of premenopausal breast cancer is associated with increased risk of triple negative and basal-like disease in premenopausal women. Interestingly, obesity may be a risk factor for basal-like breast cancer regardless of menopausal status, suggesting the role for non-hormonal mechanisms for vessel-like breast cancer pathogenesis. Prostate cancer, although initial studies conflicted association with obesity and prostate cancer risk, large number of meta-analyses reported obesity associated with modestly elevated total prostate cancer incidence. And clearly the geographic differentiation and prostatic biopsies is well known. Obviously, the data is very clear that diet-induced obesity promotes prostate tumors, and clearly we know that we have the promotion of prostate tumor growth, and we also know that the TRAM or the mouse model or diet-induced obesity has been seen. So clearly we have evidence to show that prostate cancers can have genomic links which are linked to obesity and which may not be prevalent on a large scale. So this is something which we recognize better, and we also know that have a classical pathway or correlation. From a public health standpoint, obesity cancer link has been linked, and we know that this is modifiable. If we restrict calories and cause weight loss, the likelihood of cancer comes down. And agents like statins, metformin, and non-steroidal anti-inflammatory agents can actually reduce and have a chemoprotective role. So the various models have shown that if one loses weight, you can have a positive impact on cancer. We all know obesity is a disease and not as simple as it seems. We also know obesity has a wide range of illnesses and cancer is one of them. Higher is the BMI, more is the premature mortality and cancer. Weight regulation has very strong biological underpinnings and no one chooses to be obese. Weight loss clearly improves health, including cancer. And we all know that the negative energy balance, the lifestyle management, eating less, caloric restriction might be very, very useful. And it's something which we can do very exact. It's very, very crucial that we reduce portion size, energy density, reduce the food types, meal replacements. And clearly we know there is no best diet. And we clearly know that low carb, low fat diet is over. Weight loss is greatest with meal replacement. We have so many diets which can have even cancer prevention, and there's a lot of inter-individual variability, and adherence is the key. But it is not just important to diet, it's equally important to be fit. And we know that though exercise does not produce weight loss, it is the best weight maintaining agent for cardiometabolic fitness, cardiorespiratory fitness, and also for cancer. So sedentary time has to be reduced, and it's very, very crucial to be understood, and that's something which we recognize better. So remember that physical activity does not always promote weight loss, but can have an anti-cancer impact. So summarizing, obesity has reached epidemic proportions worldwide. Best data on obesity and cancer exists in the United States. US is largely obese population, and prevalence has gone up very high, and therefore 40% of cancer population in obesity is seen in United States. The strongest link between obesity and cancer is very, very compelling, and therefore if you are able to treat obesity and handle it better, cancer rate will reduce. Another major problem is weight gain after cancer. There is a substantial proportion of patients gaining weight after the cancer diagnosis and treatment. In the contemporary scenario, cancer survivors, it is essential to have weight control and weight loss strategies based on lifestyle interventions to become a standard oncology care. So losing weight can have anti-cancer effects, and that is something which we need to recognize. Thank you for a patient hearing.
In summary, Dr. Shashank has nicely correlated the link between obesity and the various cancers, especially the breast cancer and the prostate CA. And fasting has been known to be an effective therapy for preventing obesity as well as cancer, and it has been practiced long in India. So possibly the reason that our ancestors knew that fasting and lower weight is a protective factor, and possibly that is the increasing obesity is leading to increased risk of cancers in current era. So that has been elaborately discussed by Dr. Shashank. he is not available for question and answer session today. So we won't be able to take up question and answers with him. So I hand over again to Dr. Sudha Yadav for introducing the next speaker.
Very good evening. I thank the organizing committee of the Mppcos for giving me this opportunity. Without wasting time, I would now going to introduce Dr. Amya Joshi. He's a consultant endocrinologist, and he's affiliated with the Bhakti Vedanta Hospital and Research Institute. He has got the Young Scholar Grant from IDF and the Endocrine Society. His main interests are the metabolic bone diseases, diabetes, obesity, and the parathyroid diseases. So now I invite Dr. Amya to start his talk. Dr. Amya, please.
Yeah, good evening, ladies and gentlemen. At the outset, I thank the organizing committee, Dr. Sarita Bajaj Madam, Dr. Kalra Sir, Dr. Sahai Sir, Dr. Nalini, and all the organizers for making me a part of this wonderful program on PCOD. And what I've been given a responsibility is to discuss about metabolic vigilance in thyroid disorders. Endocrinologists are basically thyroid doctors. To begin, obviously there is a long spectrum of it, but thyroid essentially doesn't only mean giving a thyroid medicine, but it actually means looking beyond the thyroid for the holistic wellness of the patient, because thyroid medications are even given by general practitioners, broad specialists. What makes endocrinologists unique is the vision to find what is there in a thyroid patient. And whenever a common man thinks of thyroid and the dissatisfaction with his thyroid treatment or thyroid illness that brings him to an endocrinologist is his fixation to weight gain. The most common thing attributed to thyroid is weight change. It's a metabolic disturbance, by the way. Mood swings. Many a times other people attribute someone's mood swings to thyroid disease, and that makes the person disturbed. Reproductive disturbances, very sensitive, very sort of minute adjustments needed here. And the food fads that are associated or as a baggage of thyroid, people keep on thinking that they will not have gobi and what all broccoli and what not soya bean. And ironically, those who need thyroid treatment, many of them think that they should not be needing it lifelong or keep on avoiding it. And those who actually don't need treatment, sometimes some patients with obesity and subclinical hypothyroidism, we know, keep on searching for a doctor who is willing to give them thyroxine, and they look forward to it as a solution for all their problems and agonies. And that's the wonderful world of thyroid, which centers essentially on metabolism. When we look at thyroid dysfunction, we classify it as overt or subclinical. Overt meaning a clear change in both T3, T4 and TSH. Whereas subclinical means the T3, T4 are in a normal range, but the TSH is either suppressed or elevated above or below the normal range. And as I said, that thyroid hormones are essentially metabolic hormones. And so let us try to look at what thyroid hormones do to the overall metabolism. Thyroid hormones essentially store or promote storage of fat in the liver. The thyroid hormones essentially promote clearance of fat from the liver. So hypothyroidism results in more liver fat accumulation, and hyperthyroidism, due to its multiple effects, can have variable effect. Thyroid hormones direct pancreas development and enhances MAPA expression in beta cells. They regulate the feeding behavior and most notably control the energy expenditure. In the muscle, the thyroid hormone determines the shift from type 1 to type 2 muscle fibers, influences regeneration of the muscle fibers and energy expenditure. They regulate the adipocyte proliferation and differentiation in a brown adipose tissue, and excess of thyroid hormone can actually uncouple thermogenetic process. They regulate adipocyte proliferation and differentiation. You will realize that most of the actions are towards the metabolism of fat and carbohydrates and to some extent proteins. And this is a simplistic view of what exactly happens because of thyroid hormones. Thyroid hormones increase intestinal glucose absorption. So hyperthyroidism will cause more glucose absorption. Hyperthyroidism will cause glycogenolysis from the liver or reduce hepatic glycogen and increase blood glucose level. And thyroid hormones increase beta cell function also. So there is at one end increased glucose, at another end increased beta cell function. A balance or imbalance of it can result in dysglycemia or hyper or hypoglycemia. Obviously, in hypothyroidism, will be reduced glucose absorption, more, even beta cell function to some extent can get affected. And also thyroid hormones promote glucose utilization. So glucose utilization is increased by thyroid hormones. So hypothyroidism will have reduced glucose utilization. So the processes are affected in a different way, and the final result of glucose is affected by the other effects. In addition to hypothyroidism, the individual's adaptability to thyroid diseases, hypo or hyperthyroidism. And so we are likely to see myriad of metabolic disturbances in hypo and hyperthyroidism. And the talk is about seeing or judging these metabolic disturbances. Thyroid hormones, most notably T3, increases bile flow, causes depletion of hepatic cholesterol, increases cholesterol synthesis and cholesterol uptake from the circulation. And so the lack of it will cause depletion of hepatic cholesterol, increased intrahepatic cholesterol, and decreased cholesterol uptake from the circulation. Now, what is commonly linked or we screen for thyroid hormones in obesity? And so in obesity, we need to understand what happens to the thyroid hormones. Because of an increased fat mass and the leptin resistance causing increased leptin, there is resetting of the thyroid causing high TSH levels in obesity. There is increased T4 disposal, thereby resulting in a free T4 going low or normal. So we see a typically subclinical hypothyroidism in insulin resistant obesity. It's also important to realize that thyroid hormones have been typically thought to increase energy expenditure, and hypothyroidism has been associated with obesity. And even mild changes in TSH have been shown, at least in some studies, to account for weight. What it means is that we need to understand that obesity can change the thyroid hormones as well as TSH. TSH and T4 levels can also have an impact on obesity. And that brings us to a wonderful analogy where most of the times we as endocrinologists and medical fraternity go on preaching that screen for thyroid hormones to avoid the risk of obesity, infertility, and heart problem. But when we practice, we actually look not only at thyroid, but beyond thyroid, other causes, the obesity itself as a tendency, as a disease, other endocrine causes of obesity, and obviously hypothyroidism. So when we actually practice, we actually look more holistically, and mild thyroid aberrations may not have an impact on weight as many patients think. But as we go on obesity, let me take you to one of the most important studies done from Hyderabad, which looked at the prevalence of obesity in hypothyroidism. So if you look at most of the literature, it looks at prevalence of hypothyroidism. Hypothyroidism in metabolic syndrome, hypothyroidism in heart disease, hypothyroidism in diabetes. Very few actually look at a metabolic disturbance in hypothyroidism. So how common is obesity in hypothyroidism? So they looked at hypothyroid patients and realized that overt hypothyroid patients are more likely to be overweight. So overweight state was more common in overt hypothyroidism as compared to subclinical hypothyroidism, whereas obesity per se was not different in subclinical and overt hypothyroidism. The numbers here for obesity may be biased because of a very small number that they actually got and the cutoffs that they used, because Indian cutoffs about 27.5 is considered as obese, so they might have got a better prevalence. Here, though, they get a reasonably high prevalence of overweight in overt hypothyroidism as compared to subclinical hypothyroidism. And this particular study published by Nursen in JCEF most intricately looks at the thyroid hormone levels in the normal range, dividing the normal thyroid levels into different sort of what you can say ranges. And if you can clearly see that rising TSH even in a normal range correlates with higher BMI, falling free T4 correlates with a higher BMI. You can also see that a higher TSH results in higher weight gain at 6 months and at 5 years. So even in a normal range, if your TSH is on the higher side, it correlates with weight gain. It's the T3 level doesn't correlate with the BMI. It's the TSH that correlates with the weight gain. And in this particular study that it quotes as a cross reference, a Danish study of more than 4,000 people, prevalence of obesity is, or BMI more than 30 is much more common if your TSH is on the higher side of a normal range. It might actually mean that obesity shifts the TSH up, but it's an association that we cannot ignore. And that brings us to how hypothyroidism and obesity are linked. Hypothyroidism reduces metabolism, reduces energy expenditure, causes weight gain. Hypothyroidism promotes insulin resistance. Obesity also is an insulin resistant state. It also affects the leptin, causing leptin resistance, which in turn causes further high TSH. So it's a vicious cycle of obesity and hypothyroidism, further triggering the inflammatory pathway. What I mean to say is that if they coexist, they might cause more damage than usual individual existence. So the raised TSH in obesity, in fact, at times have been shown to correct with weight gain. So when hypothyroid mildly raised TSH with obesity, when the weight corrects, the TSH also corrects because of correction of insulin resistance. In obese patients, when they are given thyroxine, it actually fails to activate thermogenesis as studied by Yadav et al. And there is a very limited data to show that when these subclinical hypothyroid patients are given thyroxine with a purpose to reduce weight. So association of weight gain is there, association of obesity is there, but when a therapeutic trial is given, the effect on weight loss is very, very modest. And hypothyroidism and insulin resistance often coexist, and that's the beauty of endocrinology, to look beyond one endocrine disorder, pick the holistic picture and guide the patient right. Now coming to the core of this particular conference, PCOD. Hypothyroidism results in increased TSH. There is high prolactin level, which decreases the frequency of GnRH and increases FSH. The increased TSH has a spillover effect on the FSH receptors, and all of this is a specific perfect recipe for PCOD coupled with hyperandrogenism triggered by increased prolactin, causing increased adrenal DHEA secretion. And this particular meta-analysis clearly showed that all the researchers found increased prevalence of PCOS in hypothyroidism. Also, those PCOD patients who had hypothyroidism had higher body mass indices, more waist circumferences, worse insulin resistance, and so autoimmune thyroid disease also needs to be looked carefully in PCOD. So hypothyroids need to be vigilant for PCOD. PCOD is more common in hypothyroidism, the reasons we looked at. Similarly, PCOD patients should be screened for hypothyroidism. It could be causing PCOD. Treatment can have favorable impact. And then we look at fatty liver disease. This is where we started. Liver is the bank of the body. So hypothyroidism results in increased visceral adiposity. There is chronic inflammation, impaired lipid metabolism with decreased hepatic lipoprotein lipase activity, reduced hepatic triglyceride clearance, more fat accumulation, more triglyceride accumulation in the liver, causing fatty liver disease. There is 15 to 36% risk of hypothyroidism in NAFLD patients, and those who have hypothyroidism along with NAFLD are likely to progress. So all NAFLD patients, TSH screening is mandatory, and all hypothyroid patients, especially if there is obesity, it is important to be vigilant for non-alcoholic fatty liver disease. And hyperthyroidism also has an effect on the liver. It increases hepatic apoptosis. It can overwhelm the hepatic machinery, causing abnormal liver function tests, and cardiac failure associated with hyperthyroidism can cause liver congestion, and right-sided heart failure can contribute to it, causing increased liver enzymes due to hyperthyroidism per se. Now the most interesting association, because typically thyroid and glucose also go together. Thyroid and weight, but thyroid and glucose also go together. Hypothyroidism or a low thyroid function, even in a normal range or a slightly high TSH or a subclinical hypothyroidism, increases the risk of diabetes by around 13%. And conversion of pre-diabetes to diabetes is higher in those with low normal thyroid function, subclinical hypothyroidism, than in those with a normal thyroid function. So if the person is diabetic or if the person is obese or pre-diabetic with a subclinical hypothyroidism, he is more likely to become diabetic. Probably this indicates an underlying insulin resistance. How much thyroxine treatment helps, we don't know, but a vigilance monitoring definitely is needed. And so lot of societies have looked at, and there is near universal agreement about annual or at least once in 2 years screening for thyroid function in type 1 diabetes. In type 2 diabetic, the British Thyroid Association recommends screening and diagnosis. RSSDI recommends universal screening in type 2 diabetes for thyroid dysfunction. American Thyroid Association does not recommend that, but it recommends 5-yearly screening above 35 years for all. So most of our type 2 diabetics essentially fall into a screening category as per all the societies, if you look at a broader view. Now there are certain specific associations that we need to be aware about, and that one of them is polyglandular autoimmune diseases, where thyroid dysfunction and type 1 diabetes coexist. Hypothyroidism and type 2 diabetes, the common link is insulin resistance, causing obesity, weight gain, fatigue, lethargy. So let us look at this phase. Insulin resistance causing subclinical hypothyroidism, insulin resistance increasing risk of hypothyroidism, insulin resistance increasing risk of diabetes, obesity, and diabetes. If you look at hyperthyroidism, it can cause weight loss, and diabetic patients can also have weight loss, and the symptoms could be missed for. And so you can clearly miss the cachexia, and you can also have coexistent hyperthyroidism and type 1 diabetes. So these are some misses, matches, and associations. And so we need to be vigilant about glycemic changes in thyroid diseases. There are certain interesting scenarios in treatment of thyroid disorders and associations, like glucocorticoids being used for thyroid ophthalmopathy and myxedema coma can increase blood glucose levels. Propranolol given in hyperthyroidism, sometimes in high doses, can increase glucose levels. Methimazole given to treat hyperthyroidism can increase pancreatitis. Thyroid medullary cancer has been a contraindication for liraglutide. So whenever you want to start GLP-1 analog, look at a thyroid nodule, get a calcitonin level done. And sulfonylureas have been linked to goiter and thyroid cancer. Hypoglycemia, well described in all stages in hypothyroidism, and severe hypoglycemia has even been described in myxedema coma. Again, the mechanism is reduced glucose uptake, more of reduced insulin disposal also contributing to hypothyroidism. Cholesterol levels very commonly linked to thyroid disease, and this is one of the well done study called as Tehran thyroid study, looked at more than 4,500 patients, and it concluded that the hypothyroidism is associated with dyslipidemia, it classified at patients as euthyroid, overt and subclinical hypothyroid, and you can clearly see that total cholesterol levels, LDL cholesterol levels are more in overt hypothyroidism as compared to the subclinical hypothyroid and euthyroid patients. There is a significant difference in prevalence of subclinical and clinical hypothyroidism between non-dyslipidemic and dyslipidemic subjects. However, when you adjust for age and sex, the presence of dyslipidemia per se doesn't predict hypothyroidism. But I will take you through a case scenario and you will be convinced that dyslipidemic patients need to be screened for hypothyroidism. What hypothyroidism essentially causes? Increase in LDL cholesterol, increased triglycerides, and reduced HDL cholesterol. So there is a 40-year-old gentleman came to a clinic with routine health checkup reports. He said that he's having weight gain, fatigue, lethargy, and otherwise little bit lower side pulse. If you see that he has got a HbA1c of 6, LDL 164, triglyceride 450, and TSH of 120. Overt hypothyroidism, vitamin D deficiency. Started on thyroxine and statin together, and vitamin D and lifestyle modification. And after 1 week, came with severe aches and pains and rhabdomyolysis. So this was a statin-induced myopathy aggravated by hypothyroidism. Hypothyroidism is a risk factor for statin-induced myopathy, and that's what I wanted to emphasize. So when you see dyslipidemia and hypothyroidism, treat hypothyroidism. And Endocrine Society guidelines also emphasize and encourage use of thyroxine in subclinical hypothyroidism if there is a severe dyslipidemia. We are worried about dyslipidemia because the end result is cardiac problems, macrovascular disease, and hypothyroidism adds to the inflammation associated with dyslipidemia, contributing to the problem. And hypothyroidism has been shown to be associated with risk of increased cardiac mortality. Now, as we come to the end, another thing that is commonly seen in hypothyroidism and a metabolic disturbance is hyperuricemia. Both hypothyroidism and hyperthyroidism result in high uric acid levels. We again need to treat the hypothyroidism or hyperthyroidism and reassess the uric acid levels. Obviously, dietary modifications can continue and then take a call on whether it needs treatment unless there are clear-cut signs of uric acid excess. And this is, in the end, I will be discussing an interesting study from Nigeria, which is one of its kind study looking at prevalence of metabolic disturbances in thyroid disease. So this is one of the unique studies that looked at metabolic disturbance in thyroid disease. All else looked at metabolic disturbance and then how thyroid was there. And it concluded that nearly 40 to 50% patients had high triglycerides, reduced HDL, most common dysglycemia between 45 to 50%, hypertension and central obesity. So 40% patients with thyroid disease have metabolic derangements, one or the other. If you look at how many actually had it, the number could go much higher. And then we look at specific metabolic derangements and hypothyroidism, euthyroidism, and you clearly see that hypertriglyceridemia, hypertension is much more common in hypothyroidism, whereas you can also see that patients with thyrotoxicosis can have much more likely dysglycemia. So this is a distribution of components of metabolic syndrome in subjects with thyroid disease. To conclude, thyroid diseases are commonly associated with metabolic derangements. There are no guidelines clearly to screen for metabolic derangements in thyroid disease, but we need to be vigilant. This could be favorably impacted by treating the underlying thyroid dysfunction, but this needs judicial adjudication, and that's where is the relevance of endocrine consultation for thyroid disease. And there is also need of independent assessment and management. The common metabolic derangements like obesity, PCOD, dyslipidemia, dysglycemia, hyperuricemia, and underlying vascular inflammation can finally contribute to cardiovascular disease, and that's what we are worried about. And that can be favorably impacted by properly addressing the thyroid problem and underlying metabolic derangements. And there is a room for more wider screening for thyroid dysfunction in patients with metabolic derangements. But there is also room for screening of metabolic derangements in patients with thyroid dysfunctions, and so the need for metabolic vigilance in thyroid dysfunction. Ladies and gentlemen, I thank all of you for the patient listening, and I also thank management committee from the bottom of my heart for giving me this relevant topic. Thank you, one and all.
Dr. Sudha, you're muted. Unmute yourself, please.
Now, can you hear me? Am I audible?
Yes, you are.
Yeah. Thank you, Dr. Amya, for giving such an elaborate talk on this complex topic. It's really explained, you really very nicely explained why this interdisciplinary approach is required for hypothyroidism, where there's a derangement of the lipid profile, uric acid, blood sugar level, PCOD. So a lot of the time patients of the PCOD come, because I'm a dermatologist, so a lot of the patients with PCOD come and who had been on the thyroid medication, but they spontaneously stop that. So it is very true that patients of hypothyroidism, they take on and off treatment by themselves also. So now it is more important, relevant to be in touch with a specialist. Thank you once again. So if someone has questions, we can raise from the Dr. Amya. Dr. Amya, I want to know, should we get or how frequently we should ask for the thyroid investigation in the patients of PCOD if for the first time they are coming and they are the euthyroid? So can you suggest at what frequent we should advise for the thyroid level?
Ma'am, thank you for chairing the session, and it's really a pleasure to see you. And the pertinent question. I think every patient with PCOD needs to have a thyroid function test done, because it is the hypothyroidism that could be causing PCOD, and all the criteria suggest that first screen for hypothyroidism, rule it out, and then diagnose PCOD. So at diagnosis, now later on, whenever a patient with PCOD has weight gain or a sudden change in her profile, then there is a room to repeat, or else you can take the baseline thyroid function as standard.
Thank you very much. Thank you very much, Dr. Mia.
Thanks so
now
much.
I hand over to Dr. Nalini to continue the session. I think Dr. Vilash will be moderating the panel discussion. So we should go ahead for that. Thank you.
Thank you, ma'am. So for the next session, we have a case discussion with eminent dermatologists regarding the dermatologic aspects of polycystic ovary disease, which are a frequent problem and require expert care in most of the situations. And it's very difficult for the endocrinologist to manage most of the skin problems normally. So we will have our panelists. We have the first panelist is Dr. Shweta Budyal. She is a consultant endocrinologist from Fortis Hospital, Mumbai, and her interests are in pituitary and adrenal disorders and metabolic bone disorders. Please go to the next slide. Then we have Dr. Sridevi Paladugu. She is again an endocrinologist from Apollo Hospitals, Hyderabad. She has the MM Swami and SV Rao medal in MD, and she's a clinical tutor at Apollo Hospitals Education and Research Foundation. And her interests are in polycystic ovary disease, thyroid disorders, growth and puberty disorders. We have Dr. Ifat Hussain with us from Government Medical College, Srinagar. She is the professor and head of the Department of Dermatology and Venerology. She has been awarded with a lot of awards we can see on the screen, and she has interests in immunobullous disorders, contact dermatitis, connective tissue disorders, and general dermatology. Again, we have Dr. Nidhi Gupta, who is a eminent dermatologist from Dr. Gupta Skin and Hair and Laser Clinic, and she is a member of the IADVL and is a cosmetic dermatology expert and has interests in laser and cosmetic dermatology. So we have the best panel available for our discussion. So with this, I'll go to the case, and then we will have a discussion with the eminent panelists after the presentation. So, so we are discussing a case of a 27-year-old female who is unmarried and presented to the endocrine clinic with irregular menstrual cycles for 3 years. She has excessive hair growth over the face, chest and abdomen since last 2 years, and also has a history of acne over the face since last 1 year. She is obese on examination. She has a presence of hirsutism with a modified FG score of 16/36. We will have a discussion on this. And she has pustular acne over forehead and cheeks, has alopecia, Ludwig stage 2, has grade 3 acanthosis nigricans. Abdominal circumference is high at 101 centimeters, although she doesn't have features of clitoromegaly or changes in voice. Then her investigations reveal a high testosterone level for females, and DHEAS levels are almost normal. Prolactin levels are normal, and TSH is normal. Ultrasound pelvis shows a increased size of both ovaries more than 10 cc. Has grade 2 fatty liver, and the ovaries are are showing a typical peripherally arranged small follicles of 2 to 8 millimeters, suggestive of polycystic ovary. Her HbA1c is 6.8, suggesting of pre-diabetes. Her lipid profile is also abnormal for a high LDL level and a triglyceride level also towards the higher side. So, is PCOS only a reproductive issue, or does it come as a package of endocrine problems, metabolic problems, and skin and hair problems? So, before going to the, so I'll start off with Dr. Shweta. Ma'am, can you just explain to the audience what are the common and the less common skin manifestations of PCOS? And we will also like to know from you what how it affects the quality of life, and are the patients really concerned about the skin-related manifestations of polycystic ovary disease?
All right. Good evening, all. So PCOS is basically ovulatory dysfunction plus hyperandrogenism. So hyperandrogenism, though it can manifest in a variety of ways, I think skin is one of the primary targets for the manifestation. And there are a lot of things many times it's the primary symptom of the patient which brings them to our clinic. So the cutaneous manifestations of PCOS have been studied worldwide. We have a lot of studies from India as well. Hirsutism, acne, and androgenic alopecia are common manifestation. And hirsutism and acne are more common. Androgenic alopecia, again, there's a lot of discord between actual androgen levels and the possibility of having androgenic alopecia. So a lot of women may actually have androgenic alopecia in the presence of normal androgen levels or no suggestion of any PCOS, hyperandrogenism, etc. as well. The other cutaneous manifestations that we actively look for in our patients are signs of insulin resistance, like acanthosis nigricans, skin tags. They can also have seborrhea. Girls who have gained a lot of weight recently can have non-lipid striae related to obesity. Like if we speak about acanthosis, it's a very common manifestation seen in almost 60% of the women in India who present with PCOS. And all these cutaneous manifestations also give us a lot of insight into what must be going on, what investigations should be ordered, how should we be evaluating this patient, and what metabolic derangement should we be expecting. So hirsutism is present almost in 80% of the women. Acne, almost 40%. Acanthosis, as I said, almost 30 to 60% based on the studies. But most of our women with PCOS would have insulin resistance, which may or may not manifest in the form of moderate to severe acanthosis. Skin tags, though, are less common, may be seen in 10 to 20%. I think for developing skin tag, one has to have a higher degree of insulin resistance, and many times they develop later on during the course of the disease when the age advances. So that's all about the cutaneous manifestation. If we talk about again the presenting symptoms, most of the times for younger girls, it's the signs and symptoms of androgen excess which brings them to us. Also oligoamenorrhea. If we look at the more mature women or women in their 30s, late 20s, the primary concern would be infertility, oligoannulation, oligomenorrhea, sometimes even excessive bleeding, irregular bleeding may be the manifestation. And later on, we know that PCOS is a spectrum of disease and they can have a variety of cardiovascular problems, increased risk of CA, endometrium, etc. Speaking to the last question about quality of life. So quality of life is it is being recently realized that it's one of the important domains as far as evaluation and management of these individuals is concerned. All over the world, more and more attention is being given to the psychological impact of chronic diseases. And also in India, we have now started focusing more on how chronic diseases like PCOS can affect actually the mental health domain. Women with PCOS are known to have higher prevalence of anxiety, depression, body image issues, marital or societal discord, being cut off from others because of, again, body image issues, inferiority complex, etc. And we actually have now validated quality of life questionnaire for PCOS, which can help us realize as to which aspects of PCOS symptomatology is affecting the quality of life most, so that it can be addressed better. So I think it's beyond doubt that PCOS does affect quality of life, and it's also the societal perceptions, the role of female gender, and a lot of other things which impact how women perceive themselves and how the psychological health is affected.
My next question would be to Dr. Sridevi. Ma'am, how does insulin resistance and hyperandrogenism affect the pilosebaceous unit? Ma'am, can you hear me?
I can hear you.
Yeah.
I was mute. Good evening, everyone. Now, Shweta has elaborated on the various skin manifestations of PCOS. Coming to the specific question where hyperandrogenism and affecting the pilosebaceous unit.
Dr. Sridevi, your voice is not clear.
Is it? Is it better now? Is it better now?
Yes, a little better.
Okay. So, as I was saying, Dr. Shweta has elaborated on the various skin manifestations, and coming to the pilosebaceous unit itself. Each hair follicle, as we all know, it can be either vellus hair or terminal hair, and each hair follicle also has this sebaceous gland associated together, which we call as pilosebaceous. And at puberty or pre-puberty, say puberty to conversion, there is increased androgen excretion, which determines whether this particular hair follicle will go into the terminal hair or.
Ma'am, it's quite difficult to hear you, ma'am.
Maybe you can turn off your video and
Yeah, ma'am. You can please turn off your video and be close to the
mic.
Yeah.
Is this better? Is this better?
Shade better, ma'am.
Oh, okay. I don't know
Now
what
it's
to.
good. Now it's coming good.
Okay. So I was saying that at puberty, the androgenic response leads to whether the hair follicle changes into a terminal hair or it changes into a sebaceous gland. So the androgens determine whether these each of these hair follicles turn into the terminal hairs or the sebaceous glands. And the androgens, as we all know, are produced in the ovary and adrenal and in the sebaceous gland itself. So excess insulin resistance leads to stimulation of androgenic production and also leads to an increase in the IGF-1, which in turn leads to excess sebum production. So the androgens, usually the testosterone and dihydrotestosterone receptors are present in the sebaceous gland. And excess androgenic production leads to the hair follicle turning into the terminal hair or into the sebaceous gland and later on leading to excess acne. So this is how insulin resistance and excess androgenic production seen in PCOS leads to acne and history.
Okay, so thank you, ma'am. For the next question, we will request Dr. Ifat Hassan, ma'am. I'll just project my slide too. That is, how do we quantitate hirsutism? That's the basic question. And how do we follow up these patients with hirsutism on our clinical visits? How do we what are the easier or practical methods for follow-up? That's the question, ma'am.
For hirsutism, to quantify hirsutism, there are several methods that are available. There are two. We could divide it into two groups. One would be an subjective methods, another would be objective method. Objective methods would mean like microscopic evaluation, photographic evidence, weighing the plucked or shaved hair. But these are impractical and maybe costly too. The most important thing that we all do is by using other methods, like we use the scoring systems. We use the modified Ferriman-Gallwey, this method of scoring system, where we have 11 sites. In the original Ferriman-Gallwey classification, we used to have 11 sites, but now in the modified one, we are using 9 sites. So we use the upper lip, the chin, the chest, upper and lower back, upper and lower abdomen, the thighs, legs, and the forearm. These are the sites that are used, and we use 9 sites. And we give it a scoring system from 0 to 4, depending. 0 would be once no terminal hair would be present, then 1 would be when there's a terminal hair, and so on. And 4 would be like in a male, how it should be. So if it's a score normally from 9 to 15, we call it functional hirsutism, and more than that would be like, it's more than 8 would be more significant. And how to follow them up. In every patient who presents with hirsutism, we usually want to rule out if the patient has a polycystic ovarian syndrome, and for that we go for ultrasound. Usually, to be honest, we get their baseline ultrasounds done on day 2 of the menstrual cycle, and if we have anything suggestive of PCOD, we refer them to the endocrinologist for further lab workup. And if the endocrinologist feels that there's a need for giving some treatment for these patients, we tell our patients to come back from the endocrinologist. And if the hirsutism is there, then we can tell them to go for certain measures that are there. Like we can advise them about temporary measures or about permanent methods of hair reduction, which could be in the form of lasers or topical creams like eflornithine. And subsequently, we follow them up and see how the response is. And at the same time, it's we have to have an interdisciplinary approach.
Regarding the dermatologic aspect, do you photographically follow them up, or just?
Yeah, if we're doing the laser treatment, then we have to do that.
Okay, thank you, ma'am. So for the next question, we will request Dr. Nidhi ma'am to have the first 3 questions regarding the treatment options of hirsutism. Ma'am, how do you individualize therapy based on, is it based on severity or anything else? Or what are the role of local therapies in the treatment of hirsutism?
Good evening, everyone. When the patient of the hirsutism comes to us, basically what we look into the patient is the severity of hirsutism. As Dr. Ifat ma'am said, above 8 is significant. And what is important is the concern of the patient. And second one is the association of other cutaneous manifestation of androgen excess, if they are there, just like the acne or the female pattern alopecia. So in that scenario, we judge the patient. If the severity is not much and there are no associated signs and symptoms of hyperandrogenism, then we can just go for the topical therapy for the patient, and no associated menstrual irregularities are there, we can straightway start the patient for the hair removal methods, or according to the patient, how much is the concern of the patient. He can go for the temporary methods or the permanent method like the lasers. And along with that, we go for the lifestyle modification that is required in all the patients, like the weight reduction and increased physical activity. But if the severity is high and there are association of other signs and symptoms of androgen excess, we need to investigate the patient completely. Then we go for the investigations, like we commonly go for testosterone and FSH, LH, and TSH, and blood sugar, DHES, according to the profile of the patient, along with the ultrasound. And that depends upon the report of the patient. If there is some abnormality, obviously we refer our patient to our endocrine colleagues for the further workup. And if we see that the lab reports they are normal and no further workup is required, then we treat the patient with the local therapies, lifestyle modification, local therapies, that is the laser, and as the ma'am said, the eflornithine cream that works in some cases, but majorly along with the laser. And in the resistant cases, or if we see other associations, we start patients on the systemic therapy also. It's like that.
Okay. Ma'am, Shweta ma'am, I would request you to kindly tell us what are the hormonal therapies or you prefer in patients with PCOS who are having predominantly dermatologic manifestations?
Right. So women who have symptoms of hyperandrogenism in the form of severe hirsutism or treatment-resistant acne, I think the most effective treatment option for these women is oral contraceptive pills, because the ovaries become dormant. It suppresses the GnRH pulse generator completely. The ovarian androgen production goes down significantly, and both practically as well as from the literature, we know that combined estrogen progesterone pills are the effective options, most effective options. If they are not suitable or not indicated or not preferred by the patient, then the next treatment option that I would consider would be anti-androgenic medications. The first one would be spironolactone. Again, spironolactone alone would lead to breakthrough bleeding, irregular periods. So it's a good idea to combine it with ocipils, but it may be used standalone, but we have to explain to our patients that, look, this may happen and it's okay if this happens, like in between spotting, bleeding, etc., between the cycles. The second option is finasteride. The third option is androgen receptor blockers like bicalutamide. So flutamide is very effective in terms of controlling the androgen excess symptoms. There is a possibility of hepatotoxicity, so I do not use flutamide, at least in my practice. So I think these are the hormonal options. Again, not every girl needs them. It depends on the severity and their preference and whether it's generalized, focal. But if somebody is going for permanent treatment options like laser, which are also expensive and which can't be done again and again, I think it's better to control the hormones first by treating them with oral contraceptive pills for at least good 6 months to 1 year period, and then refer the patients to laser treatment, etc.
Yeah, ma'am. The period of treatment is also very important. Thank you, ma'am. So the next question would be to Dr. Ifat, ma'am. Ma'am, Dr. Shweta has already got into the topic of acne. Ma'am, regarding acne, the acne of PCOS, do we need to differentiate it from the routine acne vulgaris, or is it how is acne related to hyperandrogenism? Can you please explain, ma'am?
See, in acne vulgaris, normally we have lesions mainly on the forehead or on the cheeks, or on the nose and on the chest and back. But in hormone-related acne, usually you'll have patients coming to you with multiple closed comedones. They'll be on the jawline and on the neck, and then they can become even pustular or cyst also. So that's a very important differentiating point. The site of involvement of the acne is very important. And yes, it's related, although acne, we all know, is a multifactorial condition. Increased androgen excess, like hypercognification of the pilosebaceous unit, and then increased sebum production, they all together, and increased activity of the propionibacter acne, they can all lead to acne. But in hormonal acne, we'll have more of androgen excess. Yes, that's there. And regarding androgen therapies or OCPs, I don't routinely prescribe for my patient. I'll refer if I feel, if I'll work up the patient, if I feel there's like it's a case of PCOS, I'll refer it to the endocrinologist, but I would not give them myself. Then the seborrhea, yes, there's an association of seborrhea with acne.
Okay, Dr. Nidhi, would you like to elaborate regarding anything regarding seborrhea and acne?
Seborrhea is definitely part of the whenever the patient is having acne, because the androgen secretion, the androgen excess, it leads to the increase in the sebum secretion. So patient is having dandruff along with that because of seborrhea, and the skin is having more of pores, and so it leads to increase in the acne also. So it's definitely an association of seborrhea with acne. Mainly they are associated.
So if we treat seborrhea, will that help in reduction in the acne? Or
Yes,
okay.
definitely. When we treat seborrhea, maybe with the local therapies, we use various formulations. There's tretinoin and we use salicylic acid. They decrease the secretion of seborrhea, and various peels are also done nowadays. They decrease the secretion, and definitely we see the improvement in patient. Also, isotretinoin, what we use, it decreases the sebum level, and that results in the improvement of acne. Even the anti-androgens, what we use, and the OC pills, they also decrease the sebum secretion. That is the action mechanism of action they use. So that works always.
Retinoid could work on many aspects in decreasing acne. So it would be like many parts of the acne, like in the pathogens of acne. So that would all lead to decrease in acne.
Thank you, ma'am, for the insights. Regarding acanthosis, I'll again go to Dr. Shweta for this question. Ma'am, what is the importance of this finding? Do we treat acanthosis at any time, and if yes, if you have any insights, kindly enlighten, ma'am.
Right. So acanthosis, it's one of the very important clinical markers of insulin resistance, and it's for us clinicians and endocrinologists to unearth what is there beneath the surface, because it's just tip of the iceberg. So when it comes to women or girls with PCOS, I think there are three important points. The first is acanthosis, as it is a marker of insulin resistance. It is very likely that the girl has other components of insulin resistance or metabolic syndrome like dysglycemia, atherogenic dyslipidemia, NAFLD, or elevated blood pressure. So we need to actively screen for all these. The second important point is in girls who are presenting as the cases of lean PCOS. Presence of acanthosis is again helpful diagnostically, because that will let me know that this is a case of simple lean PCOS and I'm not dealing with probably non-classic CH and other disorders related to androgen producing tumors, etc. The third is it's an educational tool as well, like for individuals or girls who have moderate to severe acanthosis. I can show it to the patients and their parents, like, look, this is a marker that your child has too much of insulin because of excess weight, and you need to work on the lifestyle. And if you get the weight down, follow healthy lifestyle, it's going to go down. And as the acanthosis goes down, its insulin resistance is going to go down, and that's going to probably correct the entire pathophysiology of PCOS. The second question is, do I treat it? So I never treat it. I encourage them to follow the lifestyle modification very intensively. And with the patients, even if they lose like say 5-6% of their body weight, next visit, they themselves come and tell you that there's significant improvement when that has been the primary concern. If at all the patients are very concerned about this from cosmetic standpoint, I refer them to the dermatologist because I really don't know how to treat it myself. I think that's all.
Okay, ma'am. That's a very nice answer, ma'am. Regarding alopecia, we have a lot of confusions regarding alopecia. Ma'am, I'll request Sridevi madam to just enlighten us. How is alopecia of hyperandrogenism differentiated from other causes? Ma'am, for the first question, I'll request you, ma'am.
Yeah. As you said, alopecia is certainly a cause of concern for most of our patients. And androgenic alopecia, which is mostly a consequence of PCOS, is differentiated by the fact that there is an increase in hair loss in the temporal area and in the vertex area, whereas the hair in the occipital scalp is usually spared. And apart from that, there is no scarring, no inflammation, no scaling, usually which is seen in alopecia areata, and scaling which is seen in seborrhea. Then apart from that, any kind of stress or severe illness can result in hair fall, which can be differentiated from the history of the patient, the time of onset of hair loss, and the duration of hair loss, and is it associated with any stressful condition. Apart from that, from the history itself, we know about the menstrual irregularities, difficulty in conceiving, or changes in voice, or acne, and other such features which will help us in differentiating. Then the newer term which is used for androgenic alopecia is the female pattern hair loss. The female pattern hair loss associated with androgenic excess and not associated with androgenic excess, both are seen. The ones which are not associated with androgenic excess, it could be that the hair follicles themselves are super sensitive to the normal androgenic levels, in which case we can see a similar androgenic alopecia or female pattern hair loss. So, yeah, okay.
Okay. Thank you, ma'am. Ifat ma'am, please, can you just tell us what are the changes in the pilosebaceous unit that lead to this pattern of alopecia or alopecia in the...
One more input I wanted to add is that now, as Dr. Sridevi rightly pointed out, now we call it as female pattern hair loss.
Okay.
And basically you'll have two patterns. One is the Ludwig pattern, another is the Olsen pattern. So the Hamilton scaling that we see in male pattern, the grade 7, 8, where the occipital loss, as she rightly mentioned, will not be there. So in the this Ludwig pattern, you'll have centrifugal expansion in the mid scalp, but the hair margin will be spared. That's a very important thing to note. Whereas in the Olsen pattern, it will be the middle part of the hair that is involved. There will be a this frontal accentuation with a Christmas tree pattern. So those are the two patterns that are there. And it's believed that what happens with these androgens is that there is miniaturization of the anagen hair. Anagen phase of the hair cycle is the growing part of the hair cycle. So that is reduced because of and there's a shortened anagen phase, and there is miniaturization of the hair follicle. That is the main problem that occurs because of these androgens.
Okay.
And these androgens are like these receptors are mainly in the dermal papillae. And And also dehydroepiandrosterone that can act on, there are some receptors present in the sebaceous gland and in the outer root sheath. So although they are considered to be weaker androgen, but they also have an effect in the miniaturization of the hair.
Okay. Ma'am, Nidhi ma'am, please tell us what are the treatment options available for this hair loss in PCOS?
For the female pattern alopecia, what treatment options are? Mainly it's minoxidil, what is approved for the treatment, and 2% is approved for the female use. So that is commonly used. 1 ml application twice daily we give on the dry scalp. And in addition to that, nowadays a lot of hair serums are also available. There are the ready-made cocktails available, and they contain different constituents like the ginseng, caffeine, aminexil, and saw palmetto. They don't have a lot of scientific back to them, but they practically we are using, and they're definitely giving the response. And then comes the role of local procedures we do. We do mesotherapy, where the active ingredient is directly injected at the site of action, and different ingredients we use in the mesotherapy, like the biotin or inositol, minoxidil, and they work in the patients. And also we use PRP therapies nowadays we are using, and which we take the sample of the patient, and a platelet-rich plasma unit is prepared, and we inject like the mesotherapy. We inject in the roots. So these all are other local therapies which are used, and in the systemic, we can supplement the patient with the biotin and iron. They don't have a lot of data to support key supplementation will help in the female pattern alopecia, but practically in our scenario, when patients are usually they have nutritional deficiencies, to supplementation it works. And rest is the hormonal therapy, which as
Which has been
dermatologists we are
discussed.
not using very frequently, and we usually refer to an endocrinologist for the use of anti-androgens or the OC pills if required.
Can I add a point here?
Yes,
like
ma'am,
we
please.
can also nowadays they say that minoxidil, as rightly pointed out, minoxidil 2% is helpful twice daily, but now 5% minoxidil they say you should use
Yes,
it.
when we are also using
Yeah, and other than that, there are other therapies like low level, this laser toning.
Lasers,
That
yes.
has also been said, and also finasteride said that it plays a role.
Local
Even in female
finasteride, yes.
patients, you can give finasteride.
Okay. So from this
Unless
discussion,
in the
yeah,
childbearing
please
age.
go ahead, ma'am.
Unless the female is in the childbearing age, so you can give.
Yeah. So from this discussion, we come to a very, we had a very good insights from all the aspects, all the dermatologic aspects of polycystic ovary disease, both from endocrinology side as well as the dermatology side. And it was very clear from the discussion that it is a team approach, and it is very difficult for an endocrinologist alone to treat or a dermatologist alone to treat the dermatologic and other hormonal aspects of polycystic ovary disease. So for this case, from the very good discussion which we had, we have now we have a plan for this patient that she's having both the menstrual issues, she has hair growth, and she has the metabolic syndrome characteristics also. So the treatment has to be begun simultaneously. It has to start with a very good diet and a regular exercise pattern, a plan to decrease the weight by 5 to 10%. And with that, to help on to the metabolic aspects, you can use metformin for this patient. And even the anti-androgenic actions of spironolactone can be used. And if as the patient is not married and will not be planning to go for a pregnancy soon, and even OCPs can be tried, so that either upfront they can be used, or they can be used later during the course of the treatment. And that will give a regularization of the cycles. It will also bring down the hirsutism part, and definitely as Ifat ma'am and Nidhi ma'am told, we also need local therapies if the symptoms do not resolve within 3 to 6 months of time, or the patient is having significant symptoms or quality of life issues initially itself. You can go for treatment, local treatment methods as early as possible, which includes laser therapy and various topical applications. So with that enlightening discussion, now I think if we have any questions from the audience, we can take that.
Dr. Abhilash.
Yes, sir. Please, sir.
I think Nalini may have reservations. I think very good discussion. I am personally enjoying it. But it seems Nalini is little, she is smiling, but with a pinch of she might have to.
Paucity of time. There's only one.
Yes, sir. We don't have much of time. That's why we were rushing through.
Good discussion.
We have
good.
only one question, and that is I'll direct it to Ifat ma'am. Ma'am, how is nodulocystic acne managed in a married woman who wants to conceive?
Okay, so we can give her oral antibiotics, and we can give her oral and topical antibiotic. We can give her benzoyl peroxide and topical retinoids. We'll not give her or systemic retinoids, and at the same time, she needs treatment from the endocrinologist side too, if required.
Okay, thank you, ma'am. I'll request Dr. Sudha ma'am for the closing comments, and if and after that I will hand over the session to the next coordinators.
Yes, Dr. Abhilash, really it was very interesting and arguing discussion, and I think everybody, especially the dermatologists, must have got the important take-home messages. Thank you, Dr. Nidhi and Dr. Ifat. It was really nice to hear both of you.
Same here.
Thanks once again. I think it was a nice discussion, and we should go ahead for the next session. Thank you.
Thank you very much, and thanks for the invite.
With a sincere thanks to Dr. Rama Walia and Dr. Sudha Yadav ma'am, and to all the panelists who attended or made this discussion so wonderful. I'll hand over the session to the next team, Dr. Sahila Sheikh and Dr. Amrita Chaurasia, for taking us to session 4 of this evening. Thank you.
Thanks, Dr. Nair. That was really interesting. Really learned a lot. And it really helps when you have multiple disciplines on the same platform. So I'm going to take this over.
Just before taking over, my sincere thanks to Dr. Nalini, who made this session so actually possible.
I thought you handed over the baton to me. Thanks, Nalini.
Abhilash, if you allow me, I just want to have a comment that the OCPs that we choose for these PCOS patients, we choose the ones that have anti-androgenic progesterones, like we have drospirenone and cyproterone acid. So that helps much.
Thank you.
The other ones. Thank you.
Over to Sheila, ma'am.
Thanks, Nalini. Thanks. I mean, I know as Dr. Ashraf just commented, Nalini has been worried about time. So I really won't eat up too much into time. But the next session is going to be equally interesting, because the next session is going to be about ovulatory dysfunction, a problem which I think all of us see very, very commonly. It's a problem which the gynecologists and the endocrinologists and a number of other associated fields manage together. And it gives me great pleasure to introduce the chairperson for the day. It gives me pleasure to introduce my co-chair, Dr. Amrita Chaurasia, who's the moderator along with me, who's a professor and head of the department, MLN Medical College, Pragyaraj. It's been a pleasure working with her during this entire meeting. And the chairperson for the day is, of course, Dr. Anurag Leela. If you can go to the previous slide, please. Thanks. Who's the additional professor endocrinology, who's affiliated to the SATE, GSMC and KM Hospital, Mumbai, a fantastic endocrinologist with publications in more than 80 original research articles in several peer-reviewed endocrinology journals. I'm going to hand it over to Anurag, and Anurag will take over the proceedings from here. Over to you, Anurag, please.
Thank you, Shala ma'am. I think everyone is excited about this program and the discussions which are going in the previous session. I was part of it also. So we take it forward, and this is an ovulatory dysfunction session, and it's more for a hormone and the endocrine part, which will cover prolactin, non-classical CAH, and hypo management in males, so which is very pertinent to our practice. So next slide, please. I will introduce the first speaker.
Has conveyed her apologies, Anurag. She will not be able to join in as your co-chair.
Co-chair, Dr. Jaya Chaturvedi. She is a professor in HOD Obstetrics and Gynecology from AIMS Rishikesh. She has not been able to join us. I'll hand over the mic to Dr. Suman Kotwal, who is an assistant professor and endocrinologist in GMC Jammu. And he, sir would talk on hyperprolactinemia and ovulatory dysfunction.
Is this visible? Am I audible?
Yes, Suman, you're audible.
Good evening, respected chairperson. Good evening, ladies and gentlemen. At the outset, I would like to thank my teacher, my guide, Dr. Ashraf Ganai, who has been constant source of encouragement and inspiration for me. My thanks also go to Professor Sanjay Kalra sir, Dr. Shaila Sheikh ma'am, and my friend Dr. Samrit Das, who has given me opportunity to present on this forum. So in next 15 to 20 minutes, I will be discussing about approach to hyperprolactinemia. We all know that prolactin is a hormone that is synthesized and secreted by anterior pituitary. Normally, there are many inhibitory and stimulatory factors that will influence the release of prolactin from the pituitary. But dopamine is most important, which acts as an inhibitory factor for this prolactin release. We know that prolactin has strong structural homology with growth hormone and placental lactogen. Prolactin is involved in control of lactation. In postpartum period, prolactin stimulates the differentiation and proliferation of mammary cells that has been primed by other hormones like estrogen, progesterone, growth hormone, insulin. Extrapituitary prolactin has also been reported, and its role is being elucidated. There are three types of these prolactin isoforms that are found in circulation. Number one is 23 kilodalton prolactin monomer, that is known as a little prolactin. Other isoforms are big prolactin, whose weight is 46 to 56 kilodalton. And third one is big prolactin, whose molecule is more than 150 kilodalton. This is also known as macroprolactin. So in normal subjects, this little prolactin, that is normal prolactin, constitutes around 65 to 85% of the total prolactin, whereas big prolactin constitutes around 10 to 20%, whereas this macroprolactin constitutes around 10% of total prolactin. This macroprolactin has got very little biological activity. Normally, in most of the patients, they don't produce any symptoms, but really, patient can present with a galactorrhea, or they can present with oligomenorrhea, and sometimes in around 10% of the patients, there are incidental pituitary abnormalities. The larger size of this macroprolactin results in lower renal clearance, and this causes elevation of prolactin in the circulation. This phenomena is called analytic hyperprolactinemia. So I will be discussing this in detail, and this can lead to misinterpretation of the prolactin results. In addition, the proteolytic cleavage of this normal little prolactin, that is 23 kilodalton, produces 14, 16, and 22 kilodalton prolactin variant. The role of this 14 and 22 kilodalton is not known, but there has been increasing interest in the role of 16 kilodalton, which has been found to have a role in angiogenesis. The prolactin receptor, we know that is a membrane receptor, and initially thought to be restricted to only this lactating cells, but no, studies have shown that it is present in other parts of the body like your adipose tissue, skin, hair follicle, pancreas, bone, and adrenal glands. We know that hyperprolactinemia is more common in women than men, and it is the second most common cause of infertility in women after PCOS. These specific normal values are higher in women than men and generally lower than 25 microgram per liter, or you can say 25 nanogram per ml. We can divide causes of hyperprolactinemia into analytic causes, physiological causes, pharmacological causes, pathological causes, and if no cause is found, then we call it idiopathic hyperprolactinemia. I'll be discussing them one by one. Analytic hyperprolactinemia is also known as macroprolactinemia. It's a significant analytic cause of hyperprolactinemia with a prevalence of between 12 to 40%. Contemporary prolactin amino acids are not able to discriminate macroprolactin from monomeric, that is little prolactin, and it will not produce any symptom in most of the patients, as I told you earlier, but in some percentage of patients can present with hyperprolactinemia, hypoprolactin symptoms. Macroprolactinemia increases with age and is stimulated by dopamine antagonists, and its response to physiological stimuli that would normally increase prolactin. Although macroprolactin is not of direct clinical significance, but it may lead to misdiagnosis and injudicious control of prolactin if it's not well understood. Misdiagnosis can be avoided if laboratory pre-treats the serum sample with polyethylene glycol, which will precipitate any macroprolactin before measuring prolactin. So we know that there are many causes of physiological hyperprolactinemia, but most important among them are pregnancy, lactation, physical exertion, or stress. During this pregnancy, prolactin increases to the range of 35 to 600 microgram per liter, and during pregnancy, the prolactin we should not do prolactin estimation. Prolactin is not normally increased in non-lactating women and men after nipple stimulation or breast imaging or breast examination. What are the physiological causes? There are a long list of drugs that can cause hyperprolactinemia, but most important are neuroleptics, antipsychotics like risperidone, antidepressants, opiates, estrogen, metoclopramide, and leosulfide. Serum prolactin is normally between 25 to 100, but with the exception of risperidone, which can cause prolactin rise to around 200, or it's also seen with the leosulfide, which can cause prolactin level to more than 200 nanogram per ml. So a detailed history is required, and repeat prolactin we should do after 3 days of abstaining from the drug, if possible. That will exclude this cause of hyperprolactinemia. In pathological causes, we should rule out chronic kidney disease because because it causes elevation in the prolactin level, not only because of the decreased clearance, but also there is increased secretion from the pituitary for unclear reason. Similarly, in some patients with a hypothyroidism, they can have hyperprolactinemia because there is hypertrophy of the lactotrophs as well. This is also seen in patients with a subclinical hypothyroidism, but this type of hyperprolactinemia has become normal after treatment of hypothyroidism. Among most disconcerting cause of pathological hyperprolactinemia are prolactin secreting adenomas known as prolactinomas or hypothalamic pituitary stalk disorder. These prolactinomas, they account for around 50% of the cases of hyperprolactinemia. They are more common in women than men. They are classified into 3 types depending upon the size. So if size is less than 10 millimeter, we call it microadenoma. If it is more than 10 millimeter, we call it macroadenoma. But if it is more than 40 millimeter, we call it giant macroadenoma. In giant macroadenoma, prolactin can go up to more than 1000 microgram per liter. Ectopic prolactin secretion can also occur with Orion dermoids or bronchogenic carcinoma. Idiopathic hyperprolactinemia, in some patients, the prolactin level is around 20 to 100, but no cause can be identified. So they may have small microadenoma, which is not visible on normal imaging. There are also cases of familial hyperprolactinemia, which is due to inactivating mutation in this prolactin receptor. So how to evaluate patient with hyperprolactinemia? As in all cases, we should start with history because history is most important. On history, we should inquire about symptoms like lacturia, secondary amenorrhea, oligomenorrhea in female, and we should inquire about erectile dysfunction, decreased libido, other features of hypogonadism in male. We should also inquire about headache, visual symptoms. We should rule out pregnancy, and we should rule out the medication because these are the commonest cause of hyperprolactinemia nowadays. We should rule out symptoms. We should inquire about symptoms of hypothyroidism. We should take history of the renal disease. Men most often present with a macroadenoma, which is associated with visual symptoms and headache. It's not because of the diagnostic delay in these patients, but males develop more aggressive tumor as compared to women. Males thus are at greater risk of developing hypopituitarism at diagnosis, with gonadal and somatotrophic axis more frequently involved than thyrotrophic and corticotrophic axis. So after history, we should focus on physical examination, and our physical examination should be directed towards looking for chest wall injury. We should look for the signs of hypothyroidism and hypogonadism, and we should do this testing for field of vision. On investigation, dynamic testing of prolactin is no longer recommended by Endocrine Society. We should do only one sample testing at any time of the day. So Endocrine Society has recommended only single prolactin testing at any time of the day. We should rule out pregnancy, hypothyroidism, and renal disease in all patients. In amenorrheic women, FSH, LH, and AMH should be done to rule out PCOS or ovarian failure. In males, we should assess testosterone. In addition, patients should be assessed for acromegaly because mixed cell adenoma can secrete both prolactin as well as growth hormone. We should do MRI to rule out pituitary mass or paracellular mass. What is macroprolactinemia? Macroprolactinemia should be assessed in all samples, though the quality of evidence is low grade, but ideally it should be assessed in all patients. Size exclusion chromatography, this remains the golden standard for confirming this macroprolactinemia, but it is impractical for the regular laboratory use. So an alternative common method, what we use is polyethylene glycol precipitation method, which is fast and convenient. Total prolactin is measured in unmanipulated sample. The amount of macroprolactin is calculated as total prolactin minus free prolactin divided by total prolactin in percentage. To diagnose macroprolactinemia, a polyethylene glycol precipitation ratio of more than 60% or post polyethylene glycol prolactin recovery of less than 40% is used. Although, as I told you earlier, macroprolactin is not bioactive, produces mostly no symptoms, but still can have, in some patients, they can have some symptoms like of normal hyperprolactinemia. So if this hyperprolactinemia, macroprolactinemia is very important because if it is not recognized, it can lead to misdiagnosis and mismanagement of hyperprolactinemia. Considering large variation in amount of macroprolactinemia between hyperprolactinemia patients, there are no guideline recommendations at what level we should look out for this macroprolactinemia. So what are the other prolactin assay pitfalls? The hook effect, as we all know, is a factor which can affect prolactin analysis. This is uncommon phenomena that occurs in giant prolactinoma, where actual prolactin level is in 1,000 to 10,000 microgram per liter, but reported as 20 to 200 micrograms. In patients with giant pituitary adenomas, significant high levels of prolactin molecule saturate this amino acid binding site with signaling antibodies binding directly to excess prolactin without capture antibody, resulting in the results that are lower than the expected. The hook effect can be overcome by serial dilation of serum specimen. A serum dilution of 1:100 is recommended by Endocrine Society, especially in males with moderate prolactin elevation. Biotin is another interference that can affect prolactin reading. Some automated amino acids that incorporate biotin to label the capture antibody antigen are vulnerable. High serum biotin prevents formation of biotin antigen antibody complexes, so resulting in falsely low reading. However, such aberrant prolactin results depends upon the amount of biotin intake. Biotin is also excreted by kidney, so its level is elevated in patients who have chronic kidney disease. Heterophilic or human anti-MOS antibodies can occasionally affect prolactin reading in biotin-like patients. No assay is completely foolproof, and interference should be considered when prolactin results are inconsistent with the clinical picture. Care should be taken in patients who are having autoimmune disease, who are receiving antibody treatment, as exogenous antibodies can induce development of heterophilic or human anti-MOS antibodies. If all investigations prove negative, the hyperprolactinemia can be deemed idiopathic. Such cases may be autoimmune in nature, as evidenced by the presence of anti-pituitary antibodies in some of these patients. So to conclude, Physician must know how to approach hyperprolactinemia and exclude most important diagnosis of differential diagnosis of prolactinoma. That is, we should rule out pregnancy, we should rule out CKD, and we should rule out hyperthyroidism. They must be aware of macroprolactinemia. Detection of macroprolactin with polyethylene glycol is straightforward but not foolproof. All hyperprolactinemia samples should be screened for macroprolactinemia. Patients with hyperprolactinemia can also be affected by hook effect, biotin, and other interference like heterophilic antibodies. Thank you very much.
Thank you, Dr. Suman, for this talk on prolactin and covering all the aspects of physiology and pathology of the prolactin biochemistry and using it in our clinical practice. One question has come, like you have specified that in the talk, but again, our audience is asking, is a pooled prolactin no more to be done? Can we clarify that, sir?
Yes, sir. Endocrine Society has recommended against the pooling of prolactin, but yes, if there is a discordance between the clinical picture and results, we can do that. But Endocrine Society has recommended against taking this pool sample, but we can do that. There is a low-grade evidence for that for pool sample. Only one sample is enough.
And one more question which has come up. So as you have mentioned, biotin can interfere with the prolactin assay. And so in a routine practice, if someone is taking biotin for the hair related issues, how to overcome it?
I think, sir, biotin is a common interferent in these amino acids for prolactin measurement. I think he should stop biotin, or if patient is already, we should take history what drug he's on. If she or he is taking biotin for this hair loss, we should stop it for 7 to 10 days, and then we can check prolactin again.
Yes, sir. Stopping a biotin even for 2 to 3 days will clear the biotin low, and it can be repeated. So, sir, that's there. And sir, one comment from my side for the people who start cabergoline for a high prolactin for 4 weeks or 6 weeks and then stop it, and waxing and waning of prolactin happens in these cases of microprolactinemia. Sir, please guide the audience on that.
Yes, sir. So, your question?
So we see intermittent treatment because people treat a prolactin level and then they take a dose of cabergoline for 4 weeks and then they stop it. So there is a waxing and waning we see in routine practice for a high prolactin. So general message for the audience.
Yes, I'm sorry to say, but yes, most of the gynecologists, they do like that. So they check only prolactin. They don't take the routine history of drug intake or other history. They prescribe prolactin. And this cabergoline, I think they should not take it in between. If patient is really having hyperprolactinemia and if there is a macroadenoma or macroadenoma, they should take continuously, and at least they need this treatment for 2 years. And we should assess this their prolactin after every month, initially monthly, and then we can check after 2 monthly. And if patient is having microadenoma or macroadenoma, we should do their MRI at least once in a year.
And so one last question we can take, sir. Do we still use bromocriptine, or we have shifted completely to cabergoline today?
Because some cases of this dopamine agonist resistance have emerged. So bromocriptine is no longer used, but yes, it can be used if we want to give in pregnancy, because there are more studies with bromocriptine. There are less teratogenic effects with the bromocriptine. So we can use in pregnancy, but most often we use cabergoline in most of the patients. This is more potent drug, and we have to give it weekly basis, because bromocriptine have other side effects like gastrointestinal side effects, and we have to give thrice a day. So in most of the instances we use cabergoline.
Thank you, sir. Thank you for this session. I think we will move to the next session, and I can see Dr. Sri Nagesh there. Welcome, Sri Nagesh. And most of the endocrinology crowd knows Sri Nagesh for his wit and rapid answers, what he can come up. And his professional introduction is he works at Hyderabad. He's an endocrinologist, and his areas of interest is pediatric endocrinology And so the topic today of non-classical CH, which is a continuum from pediatric to adult endocrinology, will be taken well by him. Welcome, Nagesh. We can start your talks. Nagesh, your voice, I think.
Yeah, thanks, Anurag. And at the beginning, I'd like to thank the organizing committee of Mppcos, especially Shaila ma'am and Saptarshi, for all the work they've put in. It's a pleasure and an honor to be associated with Mppcos. And for the next 20 minutes, I'll try to give you a brief overview of non-classical CH. If I can share my screen. Can you see my screen, please?
Yes, sir, it's visible.
Yeah. So what I'm going to speak about is the changing paradigms in non-classical CH. I'll just hide the controls for a second. So this is how my case presentation is going to be. I'm going to give you a brief case scenario for a virtual walkthrough. Tell you about what is non-classical CH, its relevance in the setting of PCOS, how does it present, how do you evaluate, treat, and you'd be surprised to find out about a few newer methodologies that are being developed to diagnose non-classical CH in an easier manner. A 17-year-old girl attends an endocrine OP. The complaints are that she's had irregular cycles for the past 2 years, presented with excess facial hair, hair loss, and acne. She's got a similar history in family. Height of 157 centimeters and a weight of 52 kilos, which gives you a BMI of 21.1 kilograms per meter square. So, like most patients, she has diagnosed herself. And the first question, this is something which I've encountered with a lot of my patients. I ask them why they have come to the OP. They never tell you that they have irregular periods or they have excess hair or they have acne. They just tell you that they have PCOS. And I always ask them, how do you know that you have PCOS? Then they tell me that I have done my ultrasound abdomen. It is showing a polycystic ovarian syndrome. And now I want treatment for PCOS. Over the last 9 years of my practice, ever since I've graduated, I've always tried to tell people that ultrasound is not a marker for PCOS. Diagnosis of PCOS is definitely not done by ultrasound, but this has unfortunately not really taken a lot of root as far as the majority of patients with these kind of disorders are concerned. This girl has the same impression. Her ultrasound shows polycystic ovaries. She has PCOS, but in spite of having a diagnosis for PCOS, she's been advised blood tests and she does not understand why she has to go through this blood test. She's also been using cyclical hormonal therapy for the past 1.5 years without response. So how am I going to go about it in the next couple of months? So this is what I tell a lot of people who come to me. As far as the diagnostic criteria for definition of polycystic ovarian syndrome is concerned, even if you look at the NIH statement, the Rotterdam criteria, which are among the most commonly used criteria for the diagnosis of PCOS, and the Androgen Access Society criteria, which are the most recent and the one which account for a greater amount of diversity in the presentation of PCOS. What is most important is that you want to exclude related disorders. You have to exclude all other disorders of androgen excess or related disorders before you come to a diagnosis of PCOS. An ultrasound just by itself does not give you a diagnosis of PCOS. If you are thinking on those lines, you are mistaken. This is, and most of the time, if you actually look at the ultrasound report, they don't follow all these criteria. You have to have a presence of at least 12 follicles in each ovary, a follicular diameter between 2 mm and 9 mm, an increased ovarian volume, at least more than 10 ml. At least one ovary should be more than 10 ml. And again, there is some dissent and a few minority reports in this. Some people have said that the follicular count should be 15, 10, and 12. The most commonly accepted one by the guidelines is 12. And if you are even more exacting, a lot of people ask me for an ovarian stroma to follicular ratio also. So how many times have you actually seen an ultrasound report which has commented on at least these 3 parameters? I'm sure less than 2 or 3 in 10. And that is the problem with diagnosing an PCOS by ultrasound. And if you look at the strict definitions of a polycystic ovary, polycystic ovaries are detected in 19 to 33% of the normal population. of whom approximately 80% have symptoms of PCOS, though they might be usually mild. 20% of women with polycystic ovaries are absolutely symptom-free and they present to you only with an ultrasound diagnosis. These people don't need any treatment and need your reassurance at best. Unfortunately, I'm not saying that you should not do an ultrasound, but you have to be aware of the fact that presence of polycystic ovaries may only be a marker for increased reproductive and metabolic risk. If you find polycystic ovaries on ultrasound, and if these people have some symptoms of PCOS, it is only an indicator that you should evaluate further. It is not an indicator or a guarantee that you have made a diagnosis of PCOS. Polycystic ovaries are actually associated with an increased ovarian reserve and a reduced rate of ovarian aging in a lot of people, which translates to a longer reproductive age as such. Commonly, whenever you look at somebody with PCOS and you look at an endocrinologist evaluation, this is what you'll find: a thyroid profile, prolactin, DHEAs, testosterone, 17-hydroxyprogesterone, and rarely androstenedione. You have to understand that all these tests are not being done to diagnose PCOS. PCOS is essentially a clinical diagnosis. These tests are being done to rule out all those conditions which can mimic PCOS. Thyroid profile, because severe hypothyroidism can present with polycystic ovaries with a normal menstrual pattern, contrary to what a lot of people think. Hypothyroidism is not associated with irregular cycles. It's more often than not associated with menorrhagia, excessive bleeding in a cycle of normal length. Like the previous speaker pointed out just now, Suman told us, rarely hyperprolactinemia can present with polycystic ovaries, and PCOS can be mistaken for hyperprolactinemia. And in a classical PCOS, rarely you can have a slight elevation of the prolactin levels, which confounds the diagnosis. DHEAs, more often than not, is actually done to rule out adrenal pathology or an adrenal tumor rather than looking at a differential for PCOS. The role of testosterone, again, is not to diagnose PCOS. You don't actually have cutoffs for testosterone, free testosterone, and SHBG in PCOS. If your testosterone levels are high, associated with features like very severe acne, alopecia, you are more likely looking at a Hayran syndrome or you are looking at a testicular tumor. 17-OHP and androstenedione come to the crux of our present discussion today. They are the most important tests, especially 17-hydroxyprogesterone, for the diagnosis of non-classical CH, which is considered the great mimicker of PCOS. This is how the androgen pathway works. You got pregnenolone converted to progesterone, 17-hydroxylase, 21. This converts to 17-hydroxyprogesterone. This is then converted to androstenedione, which is then converted to testosterone. If you got a block in the pathway anywhere around this point, you can have an excess of 17-hydroxyprogesterone. And this is what actually gives you a picture of something which mimics PCOS. Non-classical CH, I'm sure everybody in this hall has actually heard of congenital adrenal hyperplasia. It is an autosomal recessive condition, which is one of the commonest endocrine conditions you see in the OP, especially in the pediatric endocrine OP. But congenital adrenal hyperplasia is not a monolith. It is a continuum of disorders which has three main variants. The classical salt-losing CH, where they present with low cortisol levels, increased ACTH, increased 17-hydroxyprogesterone, low potassium, high sodium. The simple virilizing, where they present only with virilization, especially the female fetus, or peripheral precocious puberty in the male, and non-classical CH, which is most commonly missed in our OPs. It is a less severe form of the disorder, often missed because we lack genital ambiguity in this. And it is further not an immediately life-threatening disorder, so people tend to gloss over it. Many a time it can present later in life, maybe in the early childhood, maybe in adolescence, or maybe later in life when you're planning a pregnancy. You can go all through your life if you got one of the milder variants of CH without even diagnosing this. And it is often misdiagnosed as a different disease, the most common of which is a PCOS. The prevalence, classical is not so common, can present in 1 in 16,000 live births. Non-classical is a lot more common than we think it is. It can present in 1 in 1,000 live Caucasian births. Much more common in Ashkenazi, Hispanics, Slavs, especially the Yugoslavians and Italians. Many a time it is actually considered the most common autosomal recessive endocrine disorder with a carrier frequency of 1:25 to 1:10. As far as Indian data is concerned, we've got a huge amount of international data on non-classical CH, most of them very small studies, but we've got a large amount of data. Indian experience with this is pretty limited. I'm sure this is not an exhaustive list. I'm sure there are a few more, probably a few more done from KEM and AIMS where they're very interested. This was the first study done by Amini ma'am and Amrish Mittal sir. One of the first studies which actually looked at 60 patients, out of whom 5 had non-classical CH. Given the fact that we had very primitive methods of diagnosis, this was a very impressive study. If you have time, please read through the full text. You got one from Khandekar in 1990. Again, the presenting complaint was hirsutism, 53, 3 people with non-classical CH. One from Zargar sir, again female pre and post-menopausal with hirsutism. Series size 142, 2 people with non-classical CH. And in addition to this, he had one more study from Professor Sundar Raman sir, where they actually even identified 11 beta hydroxylase and the other minor forms of CHS contributing to this kind of hirsutism picture. These are the original papers. They're available online. They make for very interesting read. One is from AIMS, PGI, and SKIMS. Most of the time, we pick these cases up with these kind of presentations, where you have a cascade screening where a family member is screened for CH, and then you pick up an NCH in a female relative. Presenting with premature puberty before the age of 8 years, I've seen quite a few of this. Presenting with hirsutism anytime in life, and you have to understand that as time goes on, as you age, hirsutism becomes worse. Irregular cycles, which is a slightly more uncommon form of presentation. Severe pustular acne is again the manner in which they present a lot of dermatologists, and infertility, which is again slightly less common in non-classical CH. 11% of the cases can present before the age of 10 years. By 80% can present between the ages of 10 to 40. The rest 20% pass through life without a diagnosis. The classic features which are typical to non-classical CH, they are less likely to present with anovulation. Most of them have normal cyclicity. Less than 17% present with irregular cycles. More often than not, the commonest presentation is with hirsutism. And like I've said, infertility is not a common feature. Fetal loss is a more common feature. Only 13% of the patients who present to the endocrine clinic will actually present with infertility. Pregnancy complications are again not very common, but the risk of spontaneous abortion is high, amounts to up to 25% of all people with non-classical CH because of the excess androgens produced and the delay in implantation. This was one study which actually looked at the comparison between non-classical and CH. Non-classical CH presents with hirsutism, which worsens as time goes on. Prevalence in hyperandrogenic patients is more common with PCOS. When a person walks to your clinic, even now with hirsutism, the odds are on that it's the case of PCOS. Non-classical CH is still uncommon, but you always have to have it in your consideration. Infertility is always milder in non-classical as compared to PCOS. And metabolic aberrations are quite common in PCOS. Don't assume that all patients who walk into your clinic with a lean PCOS are all non-classical CH. Obesity is as common in PCOS, NCCH, as it is in PCOS, and this androgenism actually contributes to increased body mass. Type 2 diabetes mellitus is still less common than in PCOS, but still fairly common. The biggest advantage we got with non-classical CH is that we got a special test for differential diagnosis. You got a basal or stimulated, short synaptin stimulated 17-OHP for diagnosis. And contrary to what you think, you cannot differentiate based on DHEAs or testosterone. Testosterone can be elevated in both these cases. A lot of times in non-classical CH, you got a block between conversion of 17-OHP to testosterone. So testosterone cannot be used as a marker. Therapy options are also pretty similar, with the occasional use of glucocorticoids in non-classical CH, which is not recommended in PCOS. So this patient has a very important question. If the prevalence is much, much higher for PCOS than with non-classical CH, metabolic complications are similar, infertility is lower or almost non-existent, and treatment is essentially similar, then why do we need to spend so much time and effort diagnosing non-classical CH? The answer is for these 3 reasons. The most important of which is fetal implications. You have a woman with a non-classical CH, there is every chance that the child she is going to have can present with classical CH. Like I've already told you, phenotype genotype correlations are very difficult to maintain in non-classical CH. A woman who was presented with a very mild form of non-classical CH can have a child with a very severe presentation of classical CH, because it is the post-translational mechanisms which have a major role in the evolution of classical CH. Infertility can be seen, and like I've already said, fetal loss is a bit more common in non-classical CH. And it is for these three reasons that every patient whom we suspect of having a non-classical CH, we subject them to such laborious investigations. This is a recent guideline which has actually looked at special focus on adolescent and adult women. This is their level of evidence for the diagnosis of non-classical CH, and this is what they have to say. We recommend screening for NCH due to 21-hydroxylase deficiency in all patients presenting with signs and symptoms of androgen excess, except in specific ethnic populations in which the prevalence of this disorder is negligible, classically African Americans. We recommend diagnosis of CH due to 21-hydroxylase in anybody with a circulating 17-OHP more than 10 nanograms per ml. If you got a basal level of 17-OHP more than 10 nanograms per ml, you don't need to do a synactin test. You can directly and confidently make a diagnosis of non-classical CH. In case you do not get a specific test, specific level on screening, do a short synactin test with tetraposaccharide 250 micrograms. Take samples after 30 minutes and 1 hour, and if the value is more than 10, and in some references, if it is more than 50, you go ahead with a diagnosis of non-classical CH. And wherever you have genotyping, they recommend CYP21A2 genotyping in patients with a diagnosis of non-classical CH, so that you can predict the severity of the disease in their offspring to a certain extent. And based on the results of the co-syndrome stimulation test, suppose you got somebody with a value of 2 nanograms per ml on basic screening, you do a co-syndrome stimulation test and you get a value of 7.6. Please don't label them as carriers. We cannot look at carriers depending on the co-syndrome stimulation test. To determine whether somebody is a carrier or not, we will need to do a genotype. As far as the management is concerned, it is essentially patient-driven and depends on the requirement of the patient and varies from various ages of life. If it's only irregular cycles, the recommendation is initially to start them on estrogen and progesterone and consider graduating to an anti-androgen, the commonest of which is spironolactone. Glucocorticoid can be used only if they cannot tolerate an anti-androgen, and irregular cycles persist even after 1 or 2 trials of estrogen and progesterone. Ideally, the glucocorticoid recommended is hydrocortisone in who are children and who are sexually active. As people become older, hydrocortisone becomes cumbersome and we switch them over to prednisolone. If you are adults and if you are sexually active, because prednisolone does not cross the blood placental barrier. In non-sexually active adults, the best molecule is dexamethasone at a dose of 0.25 mg, usually in the morning or at bedtime. And in some children, in my personal experience, a lot of children who present with premature puberty cannot be controlled on hydrocortisone as they near puberty, and we have to switch them over to dexamethasone. And sometimes if they are non-sexually active and if you have no danger of dexamethasone crossing the blood placental barrier, you can go ahead with dexamethasone therapy even in the adult. Depending on the stages of life, the classical presentation of a child with non-classical CH is with premature puberty with advanced bone age. If they do not have a bone age advancement, wait and watch. If they have a bone age advancement, start with glucocorticoids. Preferred, like I said, is hydrocortisone. Dexamethasone, if they are not controlled with hydrocortisone. And when you do a synactin test, as is commonly done in a lot of these children, and if the post-ACTH cortisol is less than 18 micrograms per deciliter, also consider stress dosing of glucocorticoid when the children is sick. If you have some concerns regarding their progression to puberty or non-attainment of their final height, or if this peripheral precocity progresses to central precocity, consider starting them on a GnRH inhibitor. And a footnote is consider all therapies only if the predicted height standard deviation is less than minus 2.5 of the target height or even lower. If they have premature puberty, they're growing normally, bone age is not much advanced, do not consider therapy, wait and watch. During adolescence, if the child is already on treatment during childhood, you can continue treatment for a few years. One caveat you have to understand is hydrocortisone is rapidly metabolized in a teenager or somebody approaching puberty, and you might switch over to dexamethasone. A lot of girls present during puberty or they discontinue treatment after puberty and come back to us with hyperandrogenism, especially acne and hirsutism, which can be a flashpoint for the patient, and we need to initiate treatment. Stress dosing recommendations are again the same. And if you consider progression from a child to an adult stage, and if they're asymptomatic, you can consider discontinuing the treatment and only reintroduce later if they have fertility issues. If the first manifestation is during adolescence, this has to be a patient-oriented approach, focusing on the main complaints, which is almost always hyperandrogenism related, hirsutism and acne. The initial treatment is oral contraceptives. Later on, add an anti-androgen. If at all they cannot tolerate an anti-androgen, glucocorticoid, usual preferred is either prednisolone or dexamethasone. Give them supportive care like laser therapy, epilation, and ornithine transcarboxylase creams which act on ornithine transcarboxylase. Consider stress dosing if you do a short synaptic test. And when they have a symptomatic relief, give them an option of discontinuing with a caution about reintroducing it if they have subfertility. Perhaps the most important reason for doing these investigations is looking at fertility plan. Infertility is generally uncommon, but miscarriages are low, like I've already pointed out. Plan glucocorticoid therapy only if there is infertility or miscarriage. You do have a risk of a child with congenital adrenal hyperplasia born to a mother with NCCH. The predicted chances for giving birth to a child with CAH is, if the father's phenotype is unknown, 1 in 120. If the father has no relevant mutation, it is 0. 1 in 4 if the father has a heterozygous mutation. So if the mother has NCCH, it's always mandatory to do a father's karyotype. Antenatal management is again a very contentious issue. The basic principle is prevention of genital virilization in the fetus. The preferred molecule is dexamethasone because it crosses the placenta and suppresses the fetal ACTH well, is not deactivated by the placental 11-beta hydroxysteroid dehydrogenase and binds minimally to the maternal CBG, does not cause hypercortisolism in the mother. But a point of note is that the treatment should be started at 6 to 7 weeks. We do chorionic villus sampling only at 11 to 12 weeks, so we don't know till 11 to 12 weeks whether the child is going to be affected or not. So a lot of times you might have to start treatment at 7 weeks and abandon it after 12 weeks. Negative fetal consequences have been imputed, not commonly reported. And unfortunately, treatment is required only in the female, not in the male, because female is being treated to prevent ambiguous genitalia, but prenatal sex determination is not allowed in India. You can put up an application, know the child or sex of the fetus, and then initiate treatment. But that's very cumbersome and takes a long time, and we miss the critical period. So it's not often advocated even by most geneticists. And you have to understand one caveat. This is only an antenatal management to prevent genital ambiguity. It does not prevent the infant disease. Even after you give dexamethasone to the mother, the child, if it is born with classical CH, can present with a salt losing crisis a few days after birth. And coming to the last part of my presentation, we have had a very interesting newer advance in the past couple of last year. This was what they did: assessment of facial morphological features in patients with CAH using deep learning. Basically, what they did was they did a machine learning with random forest analysis and deep neural networks. Multiple facial features and learned representations were studied for CAH prediction, and deformation analysis of facial landmarks was done. And then this was validated by the machine learning, and this was what they said: facial morphological features in patients with CAH is distinct, and deep learning can discover subtle facial features to predict CAH, and we need larger studies before we can come up with algorithms for this. But one caveat about the study was they did it mostly in people with classical and simple virilizing CAH. We don't have a cohort large enough to form outcomes about non-classical CAH. Another method which has come up of late to diagnose non-classical CAH better without doing stimulation test is the urinary steroid profiling. This has been done both in PCOS as well as in non-classical CAH, which looked at steroid metabolites. This was the various metabolites which were evaluated in this. This was done by a gas chromatography, tandem mass spectrophotometry. GC-MS-MS was the mechanism used for this. And androstenediol, estriol, 18-OH cortisol, and ACTH cortisol were the metabolites which were found to have the best predictive value for diagnosing PCOS. Similar work has also been done in non-classical CH, and these were the metabolites they used: androstenedione, THA, 18-beta hydrocortisol, 18-oxocortisol, pregnenolone, 17-hydroxyprednisolone for 3-beta hydroxysteroid dehydrogenase, 11-beta hydroxyethiocolanone, and 11-ketocolanolone. These were the most common metabolites which were used for the diagnosis. But again, doing all of these metabolites is extremely difficult and cumbersome, and these are not routinely done in day-to-day practice. So maybe a decade down the line, urine metabolomics might be used by all of us for diagnosing non-classical CH, which makes our job very easier. But to conclude, we have to understand that unlike classical CH, non-classical CH is not very common, maybe 1 in 1,000 prevalence. The commonest autosomal recessive endocrine disorder. It is undoubtedly the commonest differential diagnosis for PCOS. You don't always have to be a lean PCOS to diagnose a non-classical CH. Obesity is as common in non-classical CH as in the classical PCOS. The major implications are during the reproductive phase, most commonly multiple abortions. The treatment initially similar to PCOS, but what diagnosis of non-NCCH gives you is an option of adding glucocorticoid with excellent outcomes. We have a few imputed newer advances like facial morphometry and urine metabolomics. They're not widely available now, but they may very well be the methods of diagnosis of this disorder in the future. And that is something which only time will tell. That's it. Thanks a lot, and I'd be happy to take questions from you.
Thank you, Sri Nagesh. The non-classical CH, the gynec crowd is asking what is the take-home message. So for every PCOS which comes to their clinic, should they be doing a 17-OHP at least once?
I would not recommend doing a 17-OHP in all cases of PCOS. Like I've already told you, the classic presentation is with the major symptoms of hyperandrogenism, which are hirsutism and acne. If you have actually looked at all the case reports, in almost every single case, the presentation was with hirsutism. If you have somebody with PCOS who presents with a predominant hirsutism pattern, it makes sense to evaluate, at least do a basal screening for 17-hydroxyprogesterone. Not everybody who presents to a OP with PCOS will present with hirsutism. For that, if you want to, you can also do a Ferriman-Galvez score. I've not shown it for.
So if we do a 17 OHP and it comes out to be 4 nanogram per ml as a value, and should it be done in the follicular phase, or is
It's always done in a follicular phase. There's no point in doing it in the luteal phase.
A follicular phase for a lady coming with hyperandrogenism and hirsutism, you did a follicular phase 17 OHP, which turned out to be 4.3 nanogram per ml.
Yeah.
So should we label him as a non-classical CH, or should it be referred to an endocrinologist for further workup?
Like I'm an endocrinologist, I'd always tell you to refer it to me for workup.
Yeah. So, but
basically, if you look at the recent guidelines and the paper from Ricardo Aziz, what he actually tells you is, be it basal or be it stimulated, a cutoff of 10 nanograms per ml is taken as definitive. A screening cutoff is anything over 2 is abnormal, which warrants further screening. If the value is more than 2, it warrants doing a short synactin test.
And now, because the ACTH is freely available,
yes,
you would like to do a synactin stimulated
synactin stimulation
50 minutes 17 OHP, and would you like to do immunoassay or a steroid profile, that is LCMS based steroid profile?
LCMS based steroid profiles are not widely available. We'll have to do an immunoassay right now. They're available only in a few research labs. And even in those research labs, even in a few private commercial labs which are doing this LCMS and this, the methodology is not very good. It's my personal experience that I've seen. In fact, we had a project with where CDFD was doing this gas chromatography tandem mass spectrophotometry. The same samples when sent to a commercial lab and when sent to a research lab, the results were widely variant. So at this point of time, I'm not very confident about doing it about doing a chromatography in a commercial lab.
And so we always talk about non-classical, but do we do see non-classical presentation of classic CH cases? Would you like to comment on that? Like the classic cases presents very late still in our country. So
we have had, but most of the time, the classic CH presenting late is a bit uncommon. The simple virilizing cases presenting late is a bit more common. I've had a few patients who have actually presented to me with ambiguous genitalia and slight labioscrotal fusion and with premature pubarchy at the age of 9 to 10 years. I actually have a set of 2 siblings, one male and the other female, where the male has presented with a precocious puberty and the female has presented without any salt losing crisis. With a salt losing crisis, it's very uncommon that they would present late in life. With a simple virilizing CH, they can present late in life. The diagnosis is not a major problem in that case. The diagnosis comes when you don't have genital ambiguity, at least as far as I am concerned.
Thank you. I think audience, I can't see any more questions in the
we
chat.
got a question on late presentation of CH. Like, I think that's what I answered.
Similar, yeah. And for 11 beta, at least blood pressure. So non-classic 11 beta, whatever we have seen at KEM, they were hypertensive. So
Yes.
measuring the blood pressure do help in those cases, and potassium starts to go low.
Yeah.
And renin would be low. So these are the clues, though it's a rare condition.
And there's another caveat, even when, because essentially there's a problem with evaluating people for non-classical CH, most discussions focus only on 21 hydroxylase. Like you said, 11 beta is fairly easy to pick up. One thing which is commonly missed is 3 beta, the other variant. Unfortunately, many a time we are not able to pick up the other variant. CH has almost 5 or 6 major variants, but we focus only on 21 hydroxylase because it is the most common. We actually tend to miss a lot of other variants who can present with a PCOS like picture with severe hyperandrogenism because we cannot directly evaluate for all these other abnormal variants of CH. And those particular variants can only be picked up by urine metabolites, especially.
Dr. Anurag.
Yeah, we are running late.
We are running very late actually.
Sure, ma'am. So we would we'll move to the next session, ma'am.
Thank you.
Thank you. Thank you, Dr. Nagesh. It was excellent lecture.
Thank you.
Amrita, over to you.
Yeah, thank you, Dr. Shaila. Now we are heading towards the panel. May I have the CVs of the moderators and panelists? After the interesting talk on hyperprolactinemia and NCCH, now there's an interesting panel on hypogonadotrophic hypogonadism, induction of puberty as well as fertility. So the moderators are, first we have Dr. Reena Srivastav. Madam is ex-HOD, Obs-Gynae Department, BRD Medical College, Gorakhpur, and she is past president, UP chapter of Obs and Gynae Society. And she has been ex-president of Gorakhpur Mppcos Society, and she has been affiliated to BRD Medical College, Gorakhpur. That's a state government medical college, and has been awarded with many honors and awards by the government of UP for family planning work, then Dainik Jagran and Amar Ujala for the outstanding work for humanity. And her interest is high-risk pregnancy, menopause, and adolescent gynecology. So welcome, ma'am. The next moderator we have is Dr. Kiran Pandey. Madam is professor and head of the department in Department of OBGY, GSVM Medical College, Kanpur. And she is affiliated to that college only and has been awarded with many national, state level and district level awards. We keep on witnessing them. And Madam has got interest in high-risk pregnancy, again, adolescent oncogynecology and urogynecology. So welcome, ma'am. Welcome to this forum.
Thank you, Amrita.
Yeah, ma'am. Now, can we have the slides for the panelists?
It gives me great pleasure to introduce Dr. Sunil Kota, a very good friend and a consultant endocrinologist who's affiliated to the Diabetes and Endocrine Clinic, Behrampur, Orissa. A very good orator, ESI award for most number of publications in IJEM 2012, best letter to editor trophy for paper entitled Endocrine Disorders and Tuberous Sclerosis. I will not go into all the details of the CV, but yes, the most important thing is he also got the RSSDI 2020 award for best innovation in diabetes care during, mind you, challenging times of COVID-19, which I think is really very, very creditable, with a Scope Scholarship by World Obesity Congress, Mexico, September 2019. Welcome, Sunil, to this forum. Next, please. It also gives me great pleasure to introduce Dr. Ashok Venkanatarasu, who's a consultant endocrinologist at the Sanjeevani Thyroid, Sugar and Hormone Clinic, Hyderabad, Telangana. And as I said, I also know Ashok very well, a very, very good endocrinologist with a number of awards He has the API Ludhiana Original Paper Award, the RSSDI Award for Excellence in Diabetes Care 2018. And I think though he's received the Best Doctor Award for 2019, but actually he deserves it all along. And of course, his interests are improving public awareness in diabetes and other endocrine disorders. And I know he's just coming out with a book on the same. Next, please. Mithili ma'am, how do I introduce ma'am? She's just so special. She's a consultant endocrinologist at Visakhapatnam, former professor of endocrinology, Andhra Medical College, again Visakhapatnam, founder, secretary, Diabetic Child Society, an established DAR project in the Department of Endocrinology, AMC Visakhapatnam, a very, very warm person, excellent speaker, interests type 1 diabetes, GDM and thyroid disorders. A warm welcome to all of you all. Next, please.
So Dr. Smriti is again a very good and very dear friend of mine. She is additional professor in the Department of Obs and Gynae, KGMU, Lucknow, very active academically as well as on many forums. So welcome Dr. Smriti to be a panelist here. We are eager to hear from you. The next one, Dr. Richa Kansal. She is professor and head at the Department of Obs and Gynae, Kalpana Chawla Government Medical College, Karnal, Haryana. She has been also very active and very dear friend of mine. Her interest is again high-risk pregnancy and infertility. So welcome to the moderators, Kiran Pandey ma'am and Dr. Reena. Ma'am, now the forum is yours.
Thank you, Amrita, for the nice words. First of all, my thank you to Dr. Sarita Bajaj, Dr. Amrita, Dr. Sheila for having me here with Dr. Kiran, my friend, and a galaxy of panelists over here. I would like to share my screen. Just give me a minute.
In the meantime, I would like to thank really Dr. Amrita. The panelists, so talented and esteemed panelists are there. So we are overwhelmed and I hope we will be able to do justice with it.
Yes, ma'am. It's a unique kind of forum. The gynecologists and they are all together.
And they are all experts.
All thanks to Sarita Bajaj, ma'am, and the organizing team of this conference.
It's a real delight to share with the endocrinologists on this forum. We are always searching them for so many problems. So to start with, I'll not waste time because we are already so late. She is a case of 19-year-old female presented with poor breast development and primary amenorrhea. Spontaneous, partial pubarchy and thelarchy occurred at 13 and 15 years respectively. So Dr. Sunil, you as an endocrinologist, what salient history should be taken in this case, please?
Yeah, thank you so much, ma'am, and thanks to the organizers for having me here, especially Sheila ma'am and Sarita ma'am. So before we go on to the history, we just want to understand the etiology of hypogonadism. It is either a transient one or a functional one, which can be due to systemic disorders, nutritional disorders, and it can be also due to endocrine disorders like hypothyroidism, hyperprolactinemia, and type 1 diabetes. But then there are permanent causes as well, which can give rise to either isolated hypo or multiple pituitary hormone deficiency. And so to talk about history, because we are running short of time, I would be just going through the points that, yes, has the puberty failed to occur, either it is delayed or begin but failed to progress or regress, then we need to understand the growth. How is the growth of the particular child? Whether the poor linear growth has started from neonatal period, since early childhood or since late childhood. In fact, late onset growth failure indicates a serious condition requiring immediate evaluation. Then birth history is a must, history of consanguinity to rule out autosomal recessive disorders, neurologic symptoms such as headache, visual disturbances, seizures, vomiting, those are to be taken care of. Obviously, because if we want to rule out the systemic causes, we have to find out the history of any systemic illness or presence of any tumor, history of drugs, predominantly this usage of steroids, corticosteroids, anabolic steroids, opiates, chemotherapy or radiotherapy, or we have to search for family history of pubertal disorders and infertility, the nutritional habits and exercise intensity, because these are very common causes of functional hypo.
Yes, thank you, Dr. Sunil, for such nice inputs, because if you don't know the causes, you'll not be able to take the history of these kind of cases. And the next very important is what points to be noted in examination. Dr. Ashok, can you take this in view of the history of this patient? And she has come with delayed puberty, you can say, although it is not delayed, but in general terms, she has been delayed till 19 years. Do you think why? Because everybody has been saying that it might be a delayed puberty, wait for a few years, wait for a few years. So what important points to be noted in examination of this case? Dr. Ashok, please.
Yeah, thanks. Certainly, madam. Thank you, madam. First, I want to convey my sincere thanks to Sarita madam and Sheila madam and other organizing committee. Examination throws important light in getting a diagnosis. One of the important thing is estimation of height and weight,
yes,
and height and arm span. So by means of comparing the height and the arm span, we will come to know Unicode proportions that will give the clear-cut thing whether we are dealing with primary hypogonadism or secondary hypogonadism. Unicode proportions, so it will go favor for the hypogonadtrophic hypogonadism. That is one thing. Another one is a simple thing, and the classical one we need to see about the sense of smell. Anosmia will go for the one of the peculiar syndrome called Coleman syndrome, and mirror movements, moving of one hand fingers is giving the other hand mirror image kind of movements or not. Synkinesis, that is one. And any mid-facial defects, cleft lip or cleft palate, that associated with the multiple pituitary hormone deficiency. And it is well known to associate with other hormone deficiency, whether any features of hypothyroidism. So there are not, we need to see. And other thing, sometimes these people might have the syndromic presentation. Such kind of syndromic presentation, they might have the hearing defects, they might have the heart-related these things. So these points we need to see. And one of the most important thing, by means of seeing the BMI, one of the point is well pointed out by Sunil sir is anorexia nervosa, very low BMI before proceeding for other things. So one thing to rule out malabsorption syndrome, especially celiac, sometimes it might be the monosymptomatic presentation. Another one is there is no such kind of thing, but very particular about the physical orientation or athletic personality. So anorexia nervosa. These are the points to be considered.
Thank you, Dr. Ashok. And on examination, the positive points were that her arm span was more than her height, and pubic hair was scanty, breast development was partial. She had cavus feet and ogival palate. No other stigmata was found. So very well, you have enumerated all the points to be taken in examination so that we can correlate it with the various types of Calvins. So what are the causes of HH and differential diagnosis? Dr. Maithili, you are there, please.
Yeah,
Please
Dr. Rita, hi. So, the causes, I think, are either congenital or acquired. Acquired have already been enumerated by the previous speakers.
Yeah.
So usually they're more common, acquired are more common. It's usually a functional defect secondary to systemic illness, malnutrition. And then, of course, you have to rule out thyroid disorders, prolactin excess, pituitary tumors. So having ruled out the acquired causes, a diagnosis would be a congenital hypo. And the clues would be, as shown in this particular case, the clues would be presence of anosmia or midline defects or skeletal anomalies as depicted in your case.
Yeah, thank you so much. Because there is already a clue. Patient is having a high arch palate, and she has presented with. So these causes have been enumerated, and then the important thing is how to investigate this case. Dr. Smriti, we are already having so many clues. Now, what investigation should be submitted?
Thank you so much, ma'am. Thank you, organizers and Dr. Amrita, for calling me over. What we see here, this is a 19-year-old girl who still has primary amenorrhea and partial pubertal development. So first thing we would want to know is what is the serum estradiol level, because these girls, if they have presented with hypogonadism, it is important to note whether it is hypo hypo or hyper. So first we would like to get a serum estradiol
So
level.
it is already there on the screen. The estradiol is 6.8 and serum LH and FSH, they are quite low, 0.6 and 1.
Yeah.
So what
serum
is your
estradiol
diagnosis?
level cutoff we usually take as 20. Since this girl has 6.8, it is pretty low.
Yeah.
And LH and FSH are also very low. So
Yeah.
this points towards hypogonadotropic hypogonadism.
So what more investigations you like to submit to this case?
So first, it is important that we also do imaging for this girl. We should also rule out global hypopituitarism by doing the serum prolactin TSH levels.
They are normal.
And yeah, hypogonadotropic hypogonadism can be associated. One of the main things are Kallmann syndrome. So would definitely like to know what is her olfactory status and get an MRI done to rule out any acquired causes of hypogonadotropic hypogonadism.
So she is not hypospic. She is having normal smell.
She's having normal smell. Yeah.
Yeah.
So I think we would definitely like to get an MRI still done, because sometimes it can be non-olfactory also causes. They can be because of certain cranial tumors, and MRI, and of course ultrasound abdomen and pelvis, so to have an idea about the size of the uterus, the endometrial thickness, and the condition of the ovary.
Yeah, uterus was infantile and ovaries are pretty small and kidneys were normal. And on MRI, everything was normal. There was no finding.
This appears to be a case of isolated hypogonadotropic hypogonadism.
And what about her bone age, Dr. Smriti? And
yeah, so now because our concerns are basically, what was the height of this girl, ma'am?
155.
155. So our main concerns are what is her bone age, if there is anything we can do to add on to her height, and plus her breasts are not well developed.
Yes.
So we would definitely want to know her bone age if giving estrogen therapy will help
it is
her.
delayed. It is delayed 13 years.
Yeah, so then we would definitely like to give her some kind of a supplement so that her breast development is better.
Yes.
And
So that will come too. And her DEXA was also showing osteopenia.
Right.
Corrected for the bone age.
Right, ma'am.
Any other investigations to be done in this case?
Ma'am, as we can see that we should rule out other systemic causes of acquired hypogonadotropic hypogonadism as well. And juvenile hypochromatosis is important because these girls, they have high iron loads, and so this definitely needs attention, and this definitely needs management.
Thank you.
Thank you.
So is MRI always recommended, Dr. Richa? Are you there? Or we can
Yes,
skip
ma'am.
off in some
Thank you
cases?
for the question. And I'll begin with thanking the organizers for giving me this opportunity to be there on this platform. And thank you, Dr. Amrita. Thank you, ma'am, for the question. I'll take up MRI as recommended that you asked me. Definitely, ma'am. See, the MRI is one thing that is adding up to our diagnosis, and it actually depends upon what all features we are getting along. Now, if we are having a condition wherein, like Dr. Sunil said to us, and even Dr. Smriti pointed out, that if you are having features in which say pituitary is not functioning adequately, then definitely MRI is indicated, because we need to understand how exactly is there a tumor there, there is a trauma that has happened that is resulting up in the problems, or if the insomnia is there. Insomnia
Yes,
is,
there might be some lesion over
Yeah,
there.
yeah,
In
yeah.
spite
There
of
might be
that,
some
the
lesion, ma'am.
findings are just suggestive of it
Yes,
being
yes,
congenital.
yes, definitely. Now, if you are having a patient who is, say, anorexic and her BMI is too low or too high, in that case, ma'am, we can think about, because there are certain syndromes that are associated with it, and we can identify them with the help of an MRI. But at the same time, like a definitive indication that there is anorexia disorder or something, then that can be corrected at the same time,
And same time, if there
pros
is
and
any
cons.
proper history of drugs, suspected functional causes, all these things, we may.
That can be elicited.
Yeah.
That can be elicited.
So what is a GnRH test, and do we actually require it, Dr. Sunil, in this case? Dr. Sunil, are you there?
Yes, ma'am. Yes.
Your expert opinion.
So the basic principle of doing this GnRH analog is that, yes, if you have a primed pituitary gland, it responds to GnRH with a brisk elevation of gonadotropins. But in hypo in females, most of the times the basal values are suggestive. So the traditional GnRH analog, which is given intravenously or the subcutaneously given triptorelin or the leuprolide are predominantly not required. So my take would be to simplify, yes, the basal values, especially it says if you look at the NEJM article in 2012, it says that if you do the LH by ICMA, it is immunometric method. If it is more than 0.1 and if it is more than 0.2 in the immunofluorometric method, it indicates puberty. So the basal values itself are indicative. Hardly do I see any role of GnRH stimulation. Maybe others can also.
Yes, very right, because the practical value is questionable. There is no extra diagnostic information, and the results are highly variable, not cost effective, and it is required when the baseline values are not concluding. So very rightly said. What about genetic testing, Dr. Ashok? Would you like to do it in this case?
Suppose if the things are fitting into classical isolated hypogonadotrophic hypogonadism, probably for the management point of view, it may not, but to make the diagnosis complete and to get the pinpoint prognosis and long-term follow-up and other comorbid condition association. So definitely it will throw the light, madam, with advent of next generation sequencing. So we can make the very pinpoint diagnosis, and sometimes, especially when it is associated with the multiple pituitary hormone deficiency, initially we may not get the other component clinical involvement, but later it can have the association like PROP1 gene involvement. So initially they might not have the involvement, but later they will have. The such kind of prognosis and preciseness will come with the genetic testing.
And a very important point that these girls will go for fertility in future, and they have to be counseled about that. So we need to know it. So what is the diagnosis of this case, Dr. Maithili?
Yeah,
Till now we have worked up, and if you can come
it's
out.
very obvious that this is a case of a congenital hypogonadotropic hypogonadism. The probable defect is, I think you need a genetic analysis, but however, in the absence of hearing loss, in the absence of anosmia, in the absence of any visual disturbances, it is unlikely to be Kalman. Probably we need to look at the other genes. The phenotype depends upon the underlying genetic defect.
So it came, a genetic testing was done in this case, and a large heterozygous deletion of FGFR1 was found in this female. So it comes out to be normosmic congenital hypogonadotrophic hypogonadism. Now, can we have any clues to diagnosis before puberty, Smriti?
So since this is a problem of puberty, sometimes it is, especially in girls, it is definitely not possible. It is only when the girls don't attain puberty or they have partial pubertal development, amenorrhea. Some of them may not even present with amenorrhea. They may have some menstruation and they may present with chronic anovulation.
Yeah.
Or
isolated menstruation can be there.
Yeah,
but definitely in boys, you can have clues in the form of micropenis and cryptorchidism. Yeah. But if a female who is a carrier like this girl, if she goes into future fertility and she gives birth to a child or girl child, we can go for gonadotropic testing in the initial days of birth, like 4 to 8 weeks. Then we can have a clue and we can warn those patients, and those patients can be subjected to genetic study also.
Right.
So what main problems have to be addressed in this case? Swiftly we'll go on to the management. Dr. Richa?
Yes, ma'am. Ma'am, it's a very nice question, because there are very many aspects that we have to talk about. The first and the foremost thing is that this girl has had a partial puberty, and we have to address that. So making up for the secondary sexual characters, that she is able to, psychologically relate to it. The pressure of that development is not there. The image that she has in the society, that all has to be considered at that time. Then with that, we have to think about, like in this particular case, we are not having the effect of growth hormone that we have to question it, because the pituitary was not showing an effect. Otherwise, this would have been one concern. And definitely
So,
thyroid.
yes, puberty, statural growth, bone health, sexual function, fertility, and psychological.
Yes, ma'am.
So how to induce and maintain puberty in this 19-year-old girl, Dr. Suni? Hello? Hello?
Yes, ma'am. I'm just
Yeah.
Actually, the predominant form of therapy, as we all understand, is the estrogen. And if you predominantly look at the guideline which was published in NEJM 2012, it asks us to go for different forms of therapy. Predominantly, the first one is the estradiol, the age-old one, which is the ethinyl estradiol. Initial dose you can start with 2 microgram daily, and then you can gradually increase to 5 microgram daily after 6 to 12 months. And but nowadays what we are using is the 17 beta estradiol oral initial dose of 5 microgram per kilogram of body weight. Then gradually you can go on increasing, and then we have option of giving the transdermal patch. I do not have personal experience of using this, but this is the recommendation from majority of these societies. And also, if you look at the up to date, it says it starts with a lower dose 3.1 to 6.2 microgram per 24 hour and gradually go on increasing. And predominantly what we try to look at is the development of secondary sexual characters, especially the breast. And once there is a breast development, adequate breast development, probably for after 6 to 12 months, then you can add progestins as well. And predominantly we try to use the micronized progesterone. And sometimes we have seen our teachers and seniors using the conjugated equine estrogen for initial 6 to 12 months as well, starting with the initial dose of
Yes,
0.16
very
to
right,
5.
Dr. Sunil. Initially, we were using ethinyl estradiol, then came conjugated equine. Now, the best recommendation is for beta estradiol. So, the natural estrogens, they are preferable to synthetic estrogens because of incomplete metabolization of synthetic and greater risk of thromboembolism. The bone health has to be taken care of with calcium and vitamin D in these subjects, especially she's osteopenic and the requirement of calcium is 1200 and vitamin D is 2000 per day. Males, I don't want to go into. I'll be skipping off these slides because next was what genetic counseling is required before fertility inducing treatment, Dr. Maithili? And this is my last question.
Yeah. So I think this particular case is the FGF receptor 1. I think the mode of inheritance is autosomal dominant. So definitely they need to be explained about the 50% risk of transferring the disease.
So it can be X-linked, it can be autosomal dominant, and it can be autosomal recessive, and maybe several mutations.
Yeah, this particular case which you projected is the receptor 1. It is probably autosomal dominant.
Yeah. Thank you so much. And now this woman is ready for ovulation induction, fertility issues, breast development has been there, growth, epiphyseal closure, estrogenization, feminized body, menses, sexual function, bone health, and well-being. This was after 3 to 4 years of her treatment, and now she is married. She wants a child, and I would like to refer this case to Dr. Kiran Pandey for her fertility issues. Thank you so much, all of you, and give me a minute. I'll remove my screen so that Dr. Kiran can come up.
Thank you, Dr. Reena. I think I like to. Can I share my screen?
Yeah.
Are you?
Is
it visible?
Yes, it is.
Okay,
it is
I will make it a. I will make it
full
a
screen.
I'll make it a full screen. All right. So as Dr. Reena has dealt with it already, the puberty part, and now we are going to talk about the. So although the history, examination, and investigation, everything has been discussed, I just want to know once that will you ask, and will you, when supposing this case has come to you for the very first time for the treatment of infertility in your OPD, she is having a primary, she was having normal menses, and now she's amenorrheic for 1 year. She has secondary sex characters developed to a great extent. Satisfactory. Now, how would you like to take any specific history, because you have to work up for the infertility? So any history, any examination, any investigation from the point of view of infertility, Dr. Sunil? Anything you would like to point out? Yes.
Yeah, actually, as you rightly stated, the lady has entered into puberty, but then there was a later onset of fertility issue. Then the standard workup would always be there. The history of either it is a functional one or it is a uh, the organic one. Then we have to rule out all the causes. And I personally do not believe in any particular thing to be ruled out. Probably all those things which we have covered in the initial portion, the history taking or the physical examination cited by Dr. Ashok and Dr. Smriti has also taken us through. I personally do not believe, I think we have covered each and every aspect.
Would you like
Ma'am,
to take any history of acquired causes of amenorrhea? Because I told you she is having, supposing, amenorrhea for 1 year. So would you like to ask certain things for acquired amenorrhea?
Obviously, ma'am. So
yeah.
So
what all
first
you
of
have
all,
to
we
rule
would
out?
always like to rule out the systemic disorders like renal failure, liver disease, or presence of any other systemic illness. Nutritional disorders are again a very important cause nowadays. People are very much concerned about their appearance and stature. Then endocrine disorders, obviously hypothyroidism, hyperprolactemia, which if it has its onset after
And
the
even
puberty.
acquired infections like something long chronic diseases can also be there. And because she has come to you infertility for the very first time. And you would also like to do certain investigations for the infertility before proceeding for further management.
So my take is probably the basic set of investigations would always include the standard ones, which we have already talked about, the serum estradiol, LH, FSH, and try to rule out other hormonal functions. And obviously, as you rightly tried to indicate, we also are supposed to rule out any secondary causes or the later onset causes which might have given rise to this.
Tuberculosis is one of the very important cause in our setup. So that also should be ruled out for a secondary amenorrhea causes. Because presently this case has not, she was having puberty problem, but we don't know. She has come without any history to me.
Absolutely.
Right. Okay.
Yes, ma'am.
So Dr. Ashok, how will you confirm the diagnosis of hypogonadotropic hypogonadism? How will you differentiate it from hypergonadotropic hypogonadism? LH stimulation test we have already talked, so let's leave it. Dr. Ashok.
Yeah, it is from the history point of view, madam. Suppose one of the most common hypergonadotropic hypogonadism is Turner syndrome. They will have the short stature. Girl child with short stature and delayed puberty unless proved otherwise, it is Turner syndrome. So that kind of clue, a short stature, will go for the hypergonadotropic hypogonadism. Near normal stature, unified proportions. An examination will go for the hypogonadotropic hypogonadism, and basal LH, FSH, and estradiol will differentiate these two things, and that helps us in making a diagnosis, especially hypergonadotropic hypogonadism. And to make the pinpoint diagnosis, we might require genetic testing, and LH stimulation test probably it might require to differentiate it from the constitutional delay in growth and puberty. But in differentiating from the hypergonadotropic hypogonadism, already the child of 16 years old, we may not require for differentiating from the primary hypogonadism. We might not require those.
Yeah, so basically once she has come to us as a case of primary infertility, we have to label her in which WHO classification group comes. So very rightly you have said you have to do the hormonal test and the other endocrines so that you can find out, because hypo now we know, but that is of only 5 to 10% cases. Maximum are into the normal group, or the some are hypergonadotropic hypo. So we have to differentiate first thing. And another thing is that the FSH level can be low, but they can be normal also. So that also has to be seen. The investigation, you have to rule out the pituitary lesions also, because that can be one thing. So you have to establish the diagnosis. And in this diagnosis establishment, I think so this chart is comparative. Like when the patient is coming for the first time, actually, I was not knowing that Dr. Reena was dealing with her. So we have to start with the investigation. So we have to do that it can be a thyroid, it can be a hyperprolactinemic. Is it, if there is a estrogen is normal, then it can be a chronic ovulation. If it is the low estrogen but high FSH, it can be ovarian failure, or the reason may be congenital karyotype or Fragile X or autoimmune screening. But if it is a low normal FSH, MRI has ruled out pituitary adenoma, then we are going towards the hypothalamic amenorrhea. So that is what we have finally reached the diagnosis. So now let's not go into those details. So we have done it. Constitutional delay, you have already said. Otherwise, it is not of much value. But definitely, sometimes you have to differentiate from the constitutional delay. So, Dr. Mithili, how should you counseling be done of these patients before proceeding for ovulation induction? Because she has come with the infertility, she has to be counseled. What all you will advise, and would you like to start your ovulation induction with clomiphene?
Yeah, I think the very pertinent question for all women undergoing ovulation induction. Counseling is mandatory, and as mentioned, the preliminary evaluation has to be perfect. Second is most important is to emphasize on a very healthy lifestyle. And majority of the young women now, especially, little weight reduction is, I think, to be stressed upon. And of course, we address the emotional needs of a young woman who is infertile and going through so much of treatment. All this needs to be taken care of. And also explain the woman the chances of success rate of ovulation induction therapies.
And I think the good nutritional status is also sometimes establishes it, the ovulation, can restore the ovulation in cases of hypogonadotrophic hypogonadism, because that was discussed in the history part also, that you have to see maybe now these days girls are very conscious, and sometimes they, to maintain the figure, they are becoming, going towards the pathological side of the anorexia. So that has to be.
There's another question on clomiphene. I think clomiphene is not the choice in a woman with hypogonadotrophic
Yes,
hypogonadism.
what is it? Will you explain it why for the audience benefit?
Yeah, clomiphene actually, it mimics estrogen. It acts it binds to the estrogenic receptor, and thereby it removes the negative feedback effect. And that is how it increases the GnRH pulsatility and leads to gonadotropin secretion. But in a hypogonadotropic hypogonadism, the basic defect is a GnRH synthesis or the GnRH, isn't it, or the gonadotropin secretion. So in that situation, estrogen, being an hypoestrogenic state, in hypo, you cannot give clomiphene.
Yes, so clomiphene is of no value here. I mean, they will not be successfully ovulate, because the etiology itself is not in the pituitary area. The feedback mechanism is okay. It's the hypothalamic lesion. So here it will not work. Thank you very much. Very rightly you have explained. So clomiphene has no role, and because it requires intact and functional HPO axis is required for clomiphene to work for it. So Dr. Smriti, what is your idea about ovulation induction with gonadotropins? Which type of protocol you will plan to? Would you like to give luteal phase support or not? What is your idea behind it?
Because as we have just been discussing, that oral ovulogens are completely out of question, because both of them work, letrozole and clomiphene work on the intact HPO axis. So we have ruled them out. Now, logically, if you look, because hypothalamus is not working, so GnRH is not being released. So what is the role of GnRH pulsatility? Well, logically it says yes, but practically it is not possible. So we are left with gonadotropins. Now, gonadotropins are definitely the drug of choice for ovulation induction in these women. Now, to decide whether to give them FSH, LH, or HMG, what? So the basic support would be that we get an LH level done for these women. If the LH levels are very low, that is less than 1.2, then we need to add LH also. So it will be better we start with HMG. However, if the LH levels are already there, more than 1.2, then we can go ahead with FSH alone. And this would help in folliculogenesis. And we can also give HCG to trigger the ovulation. And definitely luteal phase support has to be provided with the progesterone. One more thing I wanted to add was just doing, giving FSH, which induces folliculogenesis, may not produce enough estrogen for endometrial development. So the literature also
we'll come to that. We'll come to that, please.
Okay.
Basically, very rightly, you have said and pointed out that it is the basic defect is even the LH is not there. And so these are these specific cases where you have to add LH along with FSH. You might start with the HMG together, or you might need LH in the, you can add it into mid follicular or late follicular phase, because the basic, the mechanism is initially it is FSH dependent, then it is a LH dependency, there is a ovulation, and then the luteal phase support. So these 4 phases. So here LH is very important to be added. Most of the cases LH level is low. So that point is important into ovulation induction, that helps into the development of a good follicle. And later on, luteal support, as you very rightly said, for giving us a higher pregnancy rate. So which regime would you like to take? Any comment on this, Smriti?
Ma'am, we can use either recombinant FSH or highly purified FSH. Both have similar efficacy. We can do the step-up regime, or we can give the same dose and monitor them by transvaginal sonography, see how the follicles are developing, and then titrate a dose of gonadotropins accordingly.
So you can use a step-up or even a step-down. Both the regimes can be added, but basic thing is LH has to be taken. I'm not going into the details of these regimes. They are out of our correct point time limit. But any idea how much FSH, supposing the follicles are not treating, can you, what amount of FSH you can go on increasing?
We should ideally not go, usually up to 300 is more than sufficient to induce folliculogenesis.
Yeah, too much of FSH will not give you the follicle. In fact, giving LH is better. So the quality, what about the luteal phase you would like to support with the HCG or progesterone?
Progesterone should be given. However, HCG can also be added in order to supplement the luteal phase.
Yes, this is here in these cases, supplemental HCG is also may be used along with progesterone. Thank you very much. Dr. Richa, what about estrogen? Is it necessary in hypogonadotropic hypogonadism? And what about,
yeah. And thank you for the question, and honored to share the platform with you, ma'am. Yeah, the thing that we have with the estrogen is that this body is actually lacking estrogen from the beginning. Now, adding up something that gives it as only FSH might not actually produce a sufficient amount of estrogen in order to have an endometrium that is thick enough to receive the oocyte that is there to come and implant the zygote. So like estrogen has to be added up in those cases. If LH has been added, in those cases, it has been seen that estrogen per se addition is not required and it works well. And that is why I agree with Dr. Smriti that giving an HMG is a better option in these cases. It takes off some of the complications that we have now.
At the same time, I think you would like to, because you are monitoring the cases, so you would like to also monitor the endometrial thickness, and depending
Definitely
on that, in these cases, although otherwise we do not give, but in these cases,
additional
basically
estrogen can be added. Yes,
can be done, and depending on that, you can give it even estradiol twice, thrice, or even up to 4 times daily can be given.
Yes, ma'am. A
And
step-up
what
technique
about
has to be done.
And what is your idea about this ovulation induction with GnRH agonist? I think one more question will also only be there if this bell is for finishing. So
yes, ma'am.
Ovulation.
Yes, ma'am. The thing is that with these cases, it has been seen that if they have been prepared well by giving an induction to them or preparing them for the ovulation induction that has to be planned, it gives a good result. But definitely, as per the pathology that is there.
Just a minute, you join and then you ask. Then I will say, I will.
So giving over GnRH analog is a good option. Pulsatile release of GnRH has been the one that has been studied with these. Both IV route and subcutaneous routes are there. They've defined a different dosage for both of them. 75 microgram for IV, and if you go for 75 nanogram for IV and 15 microgram for subcutaneous, they have talked about 90 to 120 minute cycle. But carrying a pump is a very difficult thing, and the feasibility of actually going for GnRH rather than thinking about LH and FSH or
Hello.
Dr. Kiran?
Yes.
Yeah, I think the other panelists are there. I would request you to
wind up, sir.
Yes.
Yeah, it will take only 1 minute. One more question and then we'll
About
finish.
to wind up, sir.
Yeah,
Just,
we'll
finishing
finish.
with my answer.
So Richard, it's very correctly you have said pulsatile GnRH agonist therapy is the ideal, but it is very cumbersome and presently we are not using it. Just a point about, would you like to use in this long term the long acting GnRH agonist protocol?
Ma'am, the thing is that LH is not raised. So, why to down-regulate with anything?
Yeah, there is, that is what. There is no, actually, it is already down-regulated. So, there no role of, and what about the role of antagonist?
Ma'am, antagonist, again, we need to stimulate it out. So, like, there is no fun of going
there is
to
no
anything
point.
else.
So that's
other
just
than-
what the key message is. We don't have to use it. And just the last question, anyone can take it. What about the role of ovum donation?
Ma'am, may I?
Anyone can take it.
The thing, ma'am, that I feel is when the return to fertility is too good with once we add up FSH and LH, why not give them the pregnancy with their own ova? So why to go for donation or why to go for surrogacy? If
Anybody else
improve
can?
and the
Anybody
fertility
else
is
would
much
like
higher?
to take this? Give any other opinion about it? Any panelist would like to give any other idea about it? Role of ovum donation?
Yes, sometimes these women, they need very, very high doses of gonadotropins, and just stimulating in maybe 1 or 2 cycles may not be enough. So if those are the costs, then of course in these women ovum donation would also be a reasonable option if we are not able to succeed with our own eggs.
Okay, so let's finish with
Agreed,
this key
ma'am.
message. Basically, most of the time it is not required, but sometimes if every therapy fails, then this is the last option and we can opt for it. Thank you very much. I don't think we have, actually we didn't had much time, so I tried to cover it up in short. Sorry, panelists, if you must have felt
you so
little
much, ma'am.
cumbersome. Thank you very much. Thank you, Dr. Amrita. Thank you, Dr.
The
Shella. Thank you,
discussion was
Dr.
very good, very good.
Thank you.
Congratulations to all of you. You have managed it very well. But
Thank you. Thank you,
time-
Dr. Ashraf. Thank you. And thank you, Dr. Sarita, for giving us this opportunity.
Nice
Thank you, Reena.
inputs from all the panelists. Thank you so much.
Thank
Thank you, Kiran.
Thank you,
Okay.
Dr. Reena. Thank you.
Thank you, everybody.
Thank
for
you,
the
madam. Thank you.
fantastic
Thank you, Dr. Shella.
And I mean, in view of the paucity of time, I'll just go on to the next panel discussion.
Yes.
Thanks
so much. And thank you, Dr. Shella. It was nice communicating with you.
Same, Amrita. Pleasure.
Thank you, all the moderators and panelists.
Thank you, everybody.
Thank
So
you.
going on to the next discussion, which is going to be a panel discussion, PCOS across the lifespan. And we have none other than Dr. Vagesh Iyer, Professor and former Head, Department of Endocrinology, St. John's Medical College and Hospital, Bangalore, with a number of awards and honors to his credit. Next slide, please. And in the panel, we have none other than, we all know Sir Dr. Mohammad Ashraf Ghani, Professor Endocrinology, National Chief Coordinator, ICMR PCOS Task Force, affiliated to the Sher-e-Kashmir Institute of Medical Sciences, Srinagar, Jammu and Kashmir. Sir really needs no introduction in this panel, but I've been given the honor of doing it. So all these awards, but again, as I said, with the paucity of time, I'm just going to not go through everything, but yes, a number of awards and honors to his name. Next slide, please. We have another very, very esteemed panelist, Dr. Neena Khanna, who's the Professor and Head, Department of Dermatology, AIIMS, New Delhi. And to accompany her, we have, next please, Dr. J.B. Sharma, Professor from the Department of Obstetrics and Gynecology, again AIIMS, New Delhi. Next please. And Dr. M.L. Khurana, Senior Endocrinologist, former scientist from AIIMS, New Delhi. And we also have Dr. Alka Mohan Chutani, again from the University of Delhi, former AIIMS, who's a nutrition consultant, former chief dietitian and HOD Department of Dietetics, again with a number of awards and honors, and was also Treasurer, Secretary, President, Executive Member, IDEA, Executive Member, NSI. And I think with this last introduction of Professor Tabassum Parvez, Professor and HOD Obstetric and Gynecology, SKIMS Saura, who has special interest in infertility, reproductive endocrinology and PCOS, I will be handing it over to Vagesh to take over the proceedings from here. Thanks, Vagesh. It is all over to your and your esteemed panel.
Thank you, Dr. Shaila. It's a pleasure to be among the stalwarts. I feel very much honored to be among the stalwarts. I got my good friends, Dr. Ashraf, and also the good panelists. So for next 25 or 30 minutes, I will be taking the journey of a PCOS across lifespan. We have got specialties from endocrinology, dermatology, obstetrics, basic scientists, and also nutrition. So I'll be asking what the common problems the PCOS patient may go through in the lifespan. So one by one, randomly, I'll be calling the panelists for their opinion. I think first we'll go with the main thing is PCOS is rising at par with other non-communicable disease like cancer, cardiovascular disease, and diabetes. What's the possible reasons we have got with this? Just I like to bring in Dr. Kurana, please. Dr. Kurana?
I think Kurana sir is not there. So should
Ashraf,
I take his question then?
Yeah, please.
So, Dr. Vagesh, first of all, I welcome you. I welcome my great friend, Professor J.V. Sharma.
Hello, sir.
I welcome Professor Neena, my colleague, senior colleague at AIIMS New Delhi. I welcome my Dr. Tabassum, my colleague at Sher-e-Kashmir Institute of Medical Sciences. All of them are my collaborators. So the answer to this your question is very simple, because the society tells us that why across the lifespan, why we have selected such a society broad-based with such a long name, metabolic syndrome, pre-diabetes, PCOS society, means that we believe this group, which initially led in formulation of this society, believe on basis of their experience, on the basis of literature, that PCOS is not a separate disorder, diabetes is not separate disorder, metabolic syndrome is not a separate disorder. These disorders are the same, have a common etiopathogenesis, probably have a common soil, and they have a, across the lifespan, they have a similar behavior. So probably we'll, when we go into the discussion, we will understand better that why these disorders are linked together.
Okay. Thank you, Dr. Ashraf. You know that the common thing why we are seeing is mainly it's a lifestyle disorders. Though we are in the same genes like our ancestors, probably our lifestyle has resulted in these diseases. That's why I like to bring in Dr. Alka Mohan. So we know that obesity or overweight is quite closely linked to PCOS. So what are the dietary advices you want to give for these patients when they come for your consultation?
Firstly, I would like to thank Dr. Ashraf for inviting me on this platform. As has been said, that the prevalence of obesity and overweight is seen to be around 50 to 60% among women with PCOS. And it is seen to vary according to the geographic location. So internationally, it is seen more in USA than in other countries. And as per the study done under Dr. Ashraf, which was done at AIIMS and also at Sher-e-Kashmir, so it was seen that the Delhi women were more obese, they were less hirsute and had a high insulin resistance, versus the Kashmiri women who were more leaner, more severe hirsutism and high androgens. So coming to the diet counseling, when we talk about the dietary counseling, what are the key emphasis? We need to emphasize on eating a healthy, balanced diet with inclusion of physical exercise, intake of adequate water, fluids, and also minimizing stress. So when we talk about a healthy, balanced diet, we like to emphasize on the macronutrients. We know that the 3 macronutrients, carbohydrates, proteins, and fats. But important here is the percentage. The percentage of carbohydrates should be not more, as has been in an Indian diet, which we usually tend to have more than 60 to 65%, whereas we like to curtail it between 45 to 65%. And we like to increase the fiber content. That means we like to emphasize more on high fiber carbohydrate foods. We balance out the carbohydrate foods in the sense the complex unrefined are increased and the refined sugars are decreased. When we talk about the next macronutrient, that is proteins, we like to again emphasize on the lean protein foods. So around 15 to 20% of energy to be brought from the protein foods, and again to include protein foods like low-fat dairy products, and to include the plant-based protein sources is very, very important. Thirdly, the macronutrient fat intake, that has to be emphasized again to be less than 25 to 30% of the total energy. Again, here we emphasize on the healthy fats intake, especially the omega-3 fatty acid, which is helpful in improving the overall health. So in addition to the macronutrients, we give few tips, especially controlling of portion size, not to skip meals, cooking at home, and also nowadays with lot of packaged food, lot of processed food, which is being used. So we also like to educate the patients with regards to reading of the nutrition labels or the food labels. So all this is very, very important when we are talking to a patient who is obese and how he can, or sorry, how she can sort of control her obesity, overweight, and improve the PCOS symptoms.
Thank you, madam. So most of the time when PCOS patient, they come, they approach the obstetrician first with irregular cycles. This question is mainly for Tabassum Parvez, madam. So can you suggest the troublesome irregular menstrual problems in these young women with PCOS?
I thank the organizing committee. I thank Dr. Ashraf Gunai for giving me the chance and to be on this panel discussion for a very important topic, PCOS across the lifespan. In young females, it is very disturbing to have menstrual irregularities. They may have total amenorrhea, or they may come with irregular cycles, or they may come with heavy flow in between the cycles. So this is very disturbing. But the very important thing is how we manage these patients with irregular cycles is oral contraceptive pills to regulate the cycles. And not only that, it will also help in their clinical features of acne and hirsutism. There can be improvement in ovulation, and if they want to conceive after ovulation, it becomes easy with oral contraceptive pills once you regulate the cycles. And treating hirsutism and acne is also good with these oral contraceptive pills. And regulating the menses is very important because it is disturbing for a female. She off and on will come with amenorrhea or irregular cycles. That is very important. And very one thing we have done in laparoscopic ovarian drilling has also played a role in regulating the menstrual irregularities. As far as our these patients are concerned, and it all not only regulates the menstrual irregularities, but also it can help in preventing miscarriages and simultaneously treating their clinical symptoms of hirsutism and next.
Thank you, Dr. Tabassum Parvez, madam. I think one of the other complaints what they come during their adolescent days is with hirsutism and acne. This is for Dr. Neena Khanna. Dr. Neena Khanna?
Yeah. Hello,
Yeah,
can you
how
hear
to
me?
tackle this?
Hi, good evening. Thank you for giving me this opportunity. So the three issues with which these patients come to us are acne, hirsutism, and acanthosis nigricans. These are the three, and sometimes androgenetic. If they're adult women, then they have androgen of patterned hair loss. So these are the four main complaints. So if the patient has irregular periods, then we usually put them on cyproterone acetate and estrogen. If the patient does not have irregular periods, then we are more than happy to manage the patient with skin directed therapy in the form of topical retinoic acid. And if the acne is severe, then we start them on isotretinoin. So those are the drugs which we generally choose. Again, for hirsutism, if the patient has irregular periods, then we start them on cyproterone acetate along with estradiol, ethinyl estradiol. If the patient does not have irregular periods, then a good drug for managing hirsutism is spironolactone, and we give a trial of spironolactone for about 6 to 9 months, and subsequently, if the patient's not cosmetically happy with the result, then we try and do laser therapy for them. Now, it's important to remember that laser is not hair removal, but it is hair reduction. So the patient would continue to, initially we'll have to give it at 4 weekly intervals, but over a period of time, we can increase the gap between laser therapy, the sessions, to about 4 to 6 months. And most of our patients are very happy with this therapy. Now, we have several lasers available, but the lasers which are useful in Indian skin type are diode laser and the long pulsed Nd:YAG laser. So these are the two which we use. The other methods of epilation like waxing or shaving are used by some patients, but many patients don't like to use. Waxing is as effective in reducing the hair as lasers are, but they are slower to give the same result. So, you might have to wax the face or the body for several years before you get the same effect as lasers. The third problem which you had mentioned was acanthosis nigricans. So weight reduction, of course, as Alka mentioned. And secondly, for acanthosis nigricans, we have skin-directed therapy in the form of topical retinoic acid or oral retinoids. Now, if the patient has metabolic problems, then giving oral retinoids sometimes becomes a little difficult because they usually cause hypertriglyceridemia. So we usually try and avoid that. Now, there are a lot of other things available in the form of lipoic acid and acetylcysteine and things like that, which we don't know. There's not too much scientific evidence for response in acanthosis nigricans, though there are anecdotal studies which have suggested they're as effective as metformin in acanthosis nigricans. For androgenetic or patterned hair loss, then the drugs which we like to use are topical minoxidil 5%, given once a day. But again, here, I think the important thing is to remember as to how the patient should use it, because sometimes it causes increased facial hair, which again becomes contrary to the aesthetic effect the patient wants. So topical minoxidil, and I have used both spironolactone and fenestride in women also. But again, if they are in the reproductive age group, then there are issues with that.
Ma'am, one more just extension of this question. For how long we need to give this anti-androgens? That's a next question most of the time patient asks.
Yeah, see, anti-androgens depends on what is the condition we are looking at. So acne, the response usually starts slower than with other drugs, but the response is seen in about 3 months in acne, and sustained effect is usually seen in about 6 months. But many of these patients, or I would say most of these patients, would require maintenance therapy with topical retinoic acid.
Okay, thank you, ma'am. Now we move on to the next aspect of PCOS. We know that it's not only just menstrual irregularities or a cosmetic in the form of acne or hirsutism. Most of these patients are at risk of a metabolic disorders like dyslipidemia, diabetes, IGT, or in a future GDM. So this question is for my friend Dr. Ashraf Ghani. Ashraf?
Yes, sir.
Yeah, fine. I think that's the one. More than these things, I think this will worry us, metabolic disorders. So what are the measures we should take to tackle it? How, from when we should tackle this?
Yes, thank you very much. I think this is a very $1 million, rather $1 billion question. In the afternoon, there was a speech by WHO Chief Scientist, Dr. Soumya Swaminathan. She gave a very insightful speech, and actually she has been associated with ICMR, and she has been also associated with our society from the beginning. And she actually said that in the Indian context, because diabetes is rising in India, in the Indian context, the metabolic syndrome, pre-diabetes, PCOS, and then the other complications like renal dysfunction, cardiac dysfunction, and NASH and all that, that she said that this society should actually focus on such type of research that we pick these very early. So in our research, like we have a data of almost 10,000 women in task force across the country. Before that, I have between AIMS and SKIMS, I have seen almost a cohort of 6,000 women with PCOS. Most of them are adolescents. What we find that generally in the years to go, clinicians would see them separately. A gastroenterologist would see fatty liver and would not actually go on the other aspects. A gynecologist would see the menstrual cycles. As what Ma'am Nina Khanna said, this is what dermatologists will do because the patient comes with a problem. None of us have that much time. None of us are that much actually, I can say, armented to address all the issues. We have sleep disorders, we have psychiatric issues, quality of life. So there are several metabolic issues, especially cardiovascular risk, and now many cancers are common in them. So our attempt in this society was same thing, that we should, first of all, first attempt is that we should screen them, because it has a tip of iceberg phenomena. Almost 90% of the women are not aware of the metabolic issues. 50% are aware that they have this disorder, but 90% do not know that they have other issues, whether it is a lipid abnormality or metabolic. So first of all, we need to make patients aware, make public aware. We need to make clinicians aware that there isn't something under the iceberg, so that needs to be unraveled. When we unravel, then we need to make them understand that this is most of the problems, as you rightly said, is from lifestyle. Genes are there, genes are unmodifiable. We do not know how much contribution is from gene at this moment of time. Research is going on, but we know that modifiable factors, lifestyle is there. If you have family history of diabetes, if you have family history of CAD, family history of fatty liver, chronic liver disease, cancer, breast cancer, ovarian cancer. So you address these girls, these women, especially even male members, that this is a risk in your family. Kindly be on the guard. That's one. So just informing them is a great service to them when they get aware of the problem. Second is that we need to have awareness programs. We need to tell them what is healthy diet, what Dr. Alkamon already said, what is healthy lifestyle. So 90% of times this lifestyle management alone will work. Then, of course, if they have been missed for some time, their age has gone little higher, as when you go towards the menopause, the reproductive issues and cosmetic issues start going little down. They are not that dominant. Of course, they conceive and they are not much concerned. Then that becomes a very vulnerable situation. Because when a woman conceives and infertility goes, then they become little complacent. They do not address to these chronic conditions like diabetes, fatty liver, cancers, and coronary artery disease. So at that time, we need to, as clinicians, put them on the guard that they have to have a periodic screening, and they need to have a lifestyle for all times to come. This is a lifelong disease. It's not just you got babies or you got menstrual cycles, you got menopause and job is done, or you got these laser done for your hair and job is not done. So that is what is the most important. Then we have some drugs which are being experimented now as preventive strategies from adolescents to adults. So somewhere it is bariatric surgery, what madam was saying, even ovarian drilling, and there are so many things. But those are problem-oriented questions. But I mean, lifestyle will remain the cornerstone at all times across the lifespan of the patients.
Yeah, I think that's the most important point you have brought out. I think it's a lifestyle disease that needs to be focused very much. So we're moving on from the adolescent to the young age. We know that once these PCOS patients gets married, there is a pressure on them from them also, from the society also, to conceive, and they find it little difficult to conceive compared to others. So I like to bring upon Professor J.B. Sharma, sir. So what's the treatment options you want to offer for a patient with PCOS who comes with some difficulty in conceiving?
Yeah, thank you, sir, and thank you, Dr. Ashraf, and yourself for this. And I am very pleased to be in the galaxy of excellent speakers here. So as you said, sir, I think Dr. Ashraf has really highlighted that we need to have multidisciplinary, maybe we need to start multidisciplinary PCOS clinics for them, because we have to see these patients in wholesome method. And the incidence is really, really very high. I got at least, 50 or 60 girls, all daughters of income tax commissioner, customs commissioner, police commissioners, and, really, let's say, professor heads, daughters, and also nearly almost 350 to 400 girls. So it's a really, really big problem. So, when they get, initially they have difficulty in menstrual dysfunction, hirsutism, and irregular menses, which has already been highlighted. But once they get married, there's a pressure for pregnancy in them. So we need to, they can be treated. The good thing is that they can be treated. And initially, of course, by now you have already started her lifestyle changes. So she would have lost some weight and all, and her periods might have become regular. Or we can give her OC pills, as Madam Parvez had said, before marriage. But after marriage, I encourage them that, you try to have baby early, because they may be difficult in getting conception. So usually they will require ovulation-inducing drugs. So initially we used to give some clomiphene to them, sir, 50 milligram from day 3 to 7, or some people gave from day 2 to 6, 2 to 5, 5 days, 50 milligram, low dose. Not give 100 to 150 milligram, because they are at higher risk of OHSS also, or in hyperstimulation syndrome. But now usually currently we are preferring letrozole. So with letrozole, the chances of OHSS are much lesser. So 2.5 milligram from day 3 to 7 is the regime which we are using in AIMS. And initially for 3 months, we use that regime. And most patients do conceive, provided they don't have other infertility, causes for that. And of course, before that, they do lose weight and they do have lifestyle changes. But rarely, if they don't conceive on that, then we can give them gonadotropin also. But here is a catch. With gonadotropin, there is a very high risk of OHS in them. So we need to take the help of our, I refer these patients to our IVF team. Not that they go for IVF, but even for this thing, because they will require lower dose of recombinant FSH. Instead of 100 units, 50 units are given if they are resistant to the initial therapy. So 50 units instead of 100, and instead of 10,000 HCG, when the follicle size is 16 to 18 millimeter, we give them about 5,000 international unit of HCG, and be careful that they can go into OHSS, which can be a serious condition. So most patients do conceive on them. I had patients belonging to very top business families and all, and the girls sometimes their mother-in-law used to see. So the girl used to come to her mother's house to take that pill, that it is clomiphene tablet or this thing, and then she conceived and had a pregnancy. So this is what, and rarely, of course, normally laparoscopic ovarian drilling, we very rarely do these days, because that can reduce the, ovarian reserve for them. But as Madam Parvez said, last resort, you can do that, and with that, their periods also settle down and their conception rate also high. And of course, other drugs like, myo-inositol and all, they don't have that much role, but certainly 2 grams of myo-inositol per day with 200 microgram of folic acid can be given. 1 or 1.2 gram of like, the dicarbonate can also be given to them. So this is the treatment, this, but usually, most patients can be, helped by ovulation-inducing drugs.
Yeah, sir, I think once they conceive, it is just the beginning of other problem. They need to be much more close monitoring compared to the others. What problems do you anticipate during their pregnancy? PCOS.
Yes, sir. Yeah, very excellent question, sir. The same as you said. So many times, like suppose we have normally like we don't give metformin to them, but if they are obese and all, sometimes we can give them metformin also, 500 milligram thrice a day or 1000 milligram sustained release one regime. And especially if they are overweight, so that helps in reduction of the weight also. And in fact, this study has proven that giving metformin is safe in pregnancy, because normally we avoided giving any oral hypoglycemic drugs in pregnancy, but this study. So if they have been given this, then they can continue this medication during pregnancy. But otherwise, they are at increased risk of abortion. They are at increased risk of gestation diabetes mellitus, as Dr. Ashraf also said. And hypertension are preterm labor, large for gestation babies. And even when the baby is born, they are at high risk of meconium aspiration, low FGAR score. And like it as high as there was a meta-analysis in which the incidence of early pregnancy loss was as high as 30 to 50% as compared to 10 to 50% in the controls. And when what are the causes for them is that one are the elevated levels of testosterone that will down-regulate expression of HOXA gene, which I think you people know better than me, and it reduces the uterine receptivity and implantation. So chances of implantation failure, recurrent abortion are also high in them. In fact, PCOS is an important cause of recurrent implantation failure and recurrent miscarriages. And then high plasminogen activator inhibitor, PI, is also observed in PCOS, and it has been seen that by giving metformin, the levels of PI are reduced, and that can help actually in reducing the incidence of various problems. So there is increased risk of GDMs are increased 40 to 50%, sometimes preterm labor almost 6 to 10%, hypertension 8 to 10% in them. So all complications are more common in them. So these are high risk pregnancy which need to be catered to a tertiary referral center, and we have to be careful about them, especially GDM. In fact, I was laughing that when we had COVID, sir, we had only 2 epidemics. We either had COVID patient or GDM patient, and many of them were PCOS also. Thank you, sir.
Okay. Thank you, sir. I think that's a very well covered aspect of the conception problems, and once they conceive, what are the pregnancy problems. This I want to again bring in Dr. Alka Mohan. Dr.
Yes.
Alka Mohan? Yeah.
Yes.
Most of the time we say lifestyle management to weight reduction for a obese PCOS patient. We have a small subset of a patient, we call them as a lean PCOS. What dietary advice do you want to give to them?
As I said earlier, that
can I just mention here one point?
Yes, yes,
Dr.
Dr.
Rajesh, what our data says that in Indian setting, this is not a small subset. We have majority lean.
Okay.
So Dr. Alka has a difficult question.
Thank you, Dr. Ashraf. So as has been mentioned earlier also, and Dr. Ashraf has also said that lifestyle modification, and in lifestyle modification, proper nutrition is very, very crucial to naturally manage PCOS, especially for women who are already in the healthy weight range. So it is seen, studies have shown that these people need to cut down the total calorie intake a little bit more as compared to the normal. So studies have found that women with PCOS must eat fewer calories than the same weight women without PCOS. So suppose women who normally requires 1500 kilocalories or 1800. So if she is suffering from PCOS, so she will have to cut down around 2 to 3 kilocalories, even more. So we have to be more careful for these lean patients. In addition to that, here we need to again re-emphasize on the macronutrients, and certain emphasis has to be given on also on the micronutrients. I would just come a little later, but before that, when we were talking earlier, that part of lifestyle modification also includes exercise. So for these patients, resistance exercise definitely is also recommended. So weight training, which is intended to increase the strength, the muscle mass, and studies have shown that definitely it helps to decrease the visceral fat. It helps to decrease the elevated androgen levels, improves the menstrual and ovulatory irregularity. So here we need to understand that these patients, even if they may be lean, but sometimes they do have a higher waist circumference. So we have to target on that. We have to decrease their waist to hip circumference, definitely. Then some more changes, as I said, of course, talking about carbohydrate, proteins, fats is very, very important, but certain more changes also are required in lean PCOS, and studies have found, which is pretty helpful. Firstly is, when we talk about the meals, that is breakfast, lunch, and dinners, studies have shown that if you start with a bigger meal, that the breakfast is a higher kilocalorie. So they had done a study where they did the breakfast having around up to 500 to 600 kilocalorie, the lunch up to 300, and dinner as around 150 kilocalorie versus the control, which was opposite. That is, the breakfast was much lesser calorie and the dinner was much higher. So it was seen that those which the women who had a higher calorie during the breakfast, that is, the breakfast was the biggest meal, the reduction in insulin, glucose, testosterone, and increase in ovulation rates were observed. So we need to emphasize this to the patient also. In addition to their macronutrients, in addition to the exercise, then talking about the micronutrients, again, vitamin D is definitely very, very important. So studies have shown that around 70% of patients are suffering from vitamin D deficiency, and it is considered to improve the menstrual frequency and metabolic disturbances. So as Dr. Ashraf was saying, that we need to assess, and Dr. Sharma also mentioned that we need to assess these patients because there is definitely a delay. नहीं तो कहते हैं ना, मोटा है तो थोड़ा सा और टेस्ट कराएं, ली नहीं तो पतला है, उसको क्या प्रॉब्लम है. So sometimes there is a delayed diagnosis time, even for PCOS, because it is usually said to be strongly associated with obesity. So definitely for diabetes, for heart disease, for even emotional health. So when we talk about lifestyle management, when I said earlier, the stress management is also very, very important. The behavioral changes, because it has been shown that lean women with PCOS as compared to obese women with PCOS, they are more likely to have problems of anxiety, lower stress, higher levels of ACTH. And all this is also related to our food. So they would maybe going to their comfort food zone. They may have refined carbohydrates more. So we have to give them various other options of snacks and other things which they can, which may be their comfort foods. So all these aspects have to be looked into. In addition to that, as I had mentioned earlier, omega-3 fatty acids, and Dr. Sharma talked about inositol, dietary supplements, they also should be incorporated into the balanced diet.
Okay, thank you, ma'am. So Ashraf, when lifestyle doesn't work in inducing weight loss, definitely they seek for a weight loss medication. Do you have any suggestions for a weight loss medication in PCOS?
Yes, that is a very good question. Actually, we have some, I can say, minority of subjects who have extreme obesity. What I have seen in my experience over these years, that when BMI crosses 30 in our Indian population, metformin becomes virtually ineffective. So initially we thought that metformin should be given for the obese ones. Now we have seen that metformin actually in too lean people that causes further weight loss. But if you are obese beyond 30, it doesn't do anything. In those situations, you have to, and second thing is metformin also may be may not be tolerated by a small group of subjects. So in that situation, we have to look for alternative therapies. So what we do, pioglitazone, although glutazones have gone into disrepute, but we have found pioglitazone may cause little weight increase, waist hip ratio increases, but metabolic profile of these women definitely improve. But as far as menstrual cycles, other things is concerned, pioglitazone alone is not going to be that effective. What we generally do, we add an anti-androgen to it, or even we add metformin to it. So here in this obese group where metformin doesn't work beyond 30, there the intensive lifestyle, caloric restriction is very important. Now, as you know, weight loss medications have not worked much, because when they come in the market in short while, they go back. So there are the significant number of patients with PCOS also have psychiatric comorbidities, as Dr. Alka was saying. So again, choosing a drug where you have high risk of suicidal attempts, depression, other things may be little dicey. So what we have options, people, we have used liraglutide in small group of patients. We have used drugs like SGLT2 inhibitors. Now they do cause weight loss. That is one other option. And semaglutide oral, as well as which is going to come, is a good drug for some of these subset of patients. In the afternoon, Dr. Sandeep Agarwal was in the panel. He was my colleague at AIMS. We did a study together where bariatric surgery we found was quite effective in lowering metabolic, hormonal, and all issues. But that is there. But you know, bariatric surgery, again, an invasive procedure. Again, if you don't adhere to lifestyle, the weight comes back in another 5-10 years again. So lifestyle remains there. The problem with lifestyle is their adherence to it is very difficult. So you need to have sustained programs, sustained the counselors, dietitians, which have to periodically go on calling these patients and telling them that this is required. Because failure in intensive lifestyle with time, even bariatric surgery is a rule rather than an exception. So we have to actually have a very important program while we have a lifestyle management periodic. I mean, regular, consistent, persistent program has to be there. Here, I would like to mention one important thing what Dr. J.B. Sharma was saying, our multidisciplinary clinic. In fact, we were the first under the ICMR task force, we were the first to start a multidisciplinary clinic at SKIMS. Dr. Tabassum is one of the members there. We have named it as PCOS station. So what we are trying to do, we are trying to get a gastroenterologist there, an obesity surgeon there, endocrinologist there. We also have this lab there only. So there are scientists there only, gynecologists there, a psychiatrist is there. And in fact, there is requirement of more clinician. So it is always nice if you are seeing these patients in one umbrella at one place, and because of the stage in life for that patient, it may fit in one or the other slot, and all the patients will give, all the clinicians will give a concerted opinion, and that will be actually the good thing. Then that type of a PCOS station, if it is replicated in other hospitals also, and the NIH Mumbai has started again a PCOS station. If this is replicated, I think the care of these patients may become far better.
I think because of time constraint, I'll just restrict to one last question. Dr. Tabassum Parvez, we know that in the across the lifespan, old age is also one such place where malignancies are more commonly seen. Do you think that PCOS women are at a higher risk of certain malignancies?
I think, yes, definitely. We are lately seeing that there is high risk of malignancies like endometrial carcinoma, like breast carcinoma. It is all androgen related. We have high androgens, the chances of high endometrial carcinoma, chances of breast carcinoma go very high. And we can have a combined both breast and endometrial carcinoma, which are seen with PCO females. So we have to take care. We have to check them frequently because
Yes,
of high androgen levels.
Yeah.
And what
Thank
Dr.
you.
Ashraf, I want to comment one thing. What
Yeah.
Dr. Ashraf very rightly said, we have to have under one umbrella a dermatologist, an endocrinologist, a diabetologist, a gastroenterologist, considering their diet, considering their diabetes factor, considering the dermatological factor, because otherwise they go into different clinics for all these different ailments. But basically the cause is one, and that is PCOS, which has to be addressed so that everything is covered.
Yeah, I think we have reached the end of the program already. I received 2 warning bells, but I enjoyed this panel discussion, interacting with all of your stalwarts. Really, I was enriched by conducting this panel. I thank Dr. Sarita Bajaj Madam for asking me to conduct this panelist. Thank you very much. Back to organizers to carry on the program.
Thank you, sir, for organizing so
Thank
well.
you.
Thank you, Vagish. Thank
was
you
a
to all
genuine.
the panelists.
Thank you.
Thank you,
Ashraf,
Dr.
Dr.
Sarita, ma'am.
Tabassum, Dr. Sharma.
It was
Very,
nice.
very nice
Very
discussion.
nice.
Excellent.
Tabassum, madam.
Excellent.
It was very nice and informative.
Yeah, I think Dr. Vagesh got the privilege of concluding this today's.
Yes.
So this was in a
very well
nutshell.
conducted program. Thank you.
PCOS in a nutshell, actually.
Yeah.
Gist of the conference in one session.
So virtually
Thank you,
everybody,
Vagish.
these days everybody has PCOS. Either they are obese PCOS or they are thin PCOS, madam.
How do the males get out of it?
Yeah, that's what I was saying, madam. Even males have PCOS, and even our dogs in my apartment, 5 or 6 male dogs are PCOS.
We have David Abbott is one of the PCOS AE PCOS basic founding members. He is basically he works on preclinical studies. I invited him to India. We had a meeting in 2011 in Ames only. When he came, that time there was not that Sukhram, before Sukhram. He came to, when he got down at airport, he saw everywhere those PCO, there were those STD booths. He was seeing everywhere. Then he came, he asked me, why are there so many PCOs? Then he took a photo. I told him, sir, it is not PCOS clinic. These are public STDs. So I think this is like same thing will happen in future. The way the disease is progressing parallel to diabetes, we might have to open small PCOS.
I think what do doctors want? Patients.
Yes.
So I think we are trying to have males also coming.
Yes, madam.
Correct.
So I don't know what's in the future, but something is there in the pipeline, perhaps, like Dr. J.B. Sharma said.
Okay, thank you.
We have yet to discover a lot about PCOS. I think we are not fully done with it, and we will come across many things which will come in future.
I just hope they don't change the name again, because from Stein-Leventhal to PCOD to PCOS.
Yes.
Madam, we are this society is already trying to think and bring so many other societies together and have a consensus on thinking of, well, the criteria need to be revised, as in the inaugural ceremony it was said. We also need to think of giving a half decent name to this.
That's what I started off saying. It's christened, rechristened, re-rechristened. The name is changing, like so many.
No, only problem with this PCO is when you say PCOS, it brings business of sonologists. It doesn't do good to patient. When I see some patient, we say PCOS, then they go home, they see ultrasound obese ones. Because in obese ones, usually the transducer doesn't pick up the cysts. So they call me from there only, sir, we're not going to come because now ultrasound is normal.
Oh, like Sri Nagesh said, they walk into the clinic, they said, I have PCOS. I mean, they just say, I have PCOS. Why? Because the ultrasound shows. And if it doesn't show, then they don't have. So if it shows, it's PCOS. If it doesn't show, it's not PCOS. I mean, it's like such a clear-cut watershed.
Yes, yes, that
finding.
ultrasound, ultrasound is so much variable, so many
Absolutely. No.
so that creates a lot of trouble,
Confusion.
and we are not able to appropriately treat those. So that name has to go.
Yeah, so again, another name. I think we should get the award for the best naming of the new PCOS christening.
Yes, some name should be given. We should give suggestion. But of course, as an endocrinologist, I will try to put.
Unfortunately, because
metabolism.
Yeah, I mean, it's all related to it's actually a metabolic
disorder, ma'am. Because
that's it. Actually, I agree with you. There's nothing like it's a metabolic disorder, which encompasses a lot of problems along with it, just like diabetes.
Diabetes, hypertension, dyslipidemia, hyperglycemia, all it's a metabolic disorder.
Everything. It's all there.
And of course, and subsequently criteria will have to be changed. Because
I think, Ashraf, give it a syndrome XX.
Syndrome XX was suggested by Andrea Ganab, that is correct. But then again, that will leave the men out of it.
Not why. Why is not there?
Men have to be there.
Okay.
It cannot be XSY under any circumstance.
Yes.
Because Klinefelter's is the only XSY.
They will not get it.
Thank you, Vagish. That was really nice. Thank you so much.
No, it's a pleasure. It was always a pleasure interacting with you all. Bye. Good night.
Good night.
Okay, Dr. Saptarishi. So best of luck.
I think वो सो गया है.
No, he is there. Are we allowed to go? You can conclude.
Sure. I think we invite everybody for tomorrow's session. So we start the oral and poster presentation at 2, and then we have our scientific session from 3. So, and we have the oration also tomorrow. So we are looking forward to all that. Thank you.
Thank you,
Good night.
Very much.
Good night, everyone.
Good night.
I think that I can see Alka, Amrita, Ashutosh, Professor Gear, Rais. Very. I think Alka, I saw you in the morning as well.
Yes.
Wow, lovely. At least now
Alka ma'am is one of our founding members.
Oh, wow.
She was in the backbone.
Thanks to Dr. Ashraf.
Thank you.
Yeah, so at least we're trying to get more and more members in place. Saptarshi, thank you so much.
Thank you.
Like I said, you are the backbone, the right arm, left arm, right leg, left leg, everything.
Ma'am, you both. I thank Dr.
And you are the brain.
Bacha kya?
Real umbrella.
You are the brain.
You are the pillar.
Yes. Then the pillar to hai. Then she also puts an umbrella ahead.
Good night.
Very kind of. Thank you so much.
Thank you.
Good night.
Thank you, everyone.
Bye.
So can I end the meeting with your permission?
Please.
Okay, so I'm ending this meeting now. Thank you.